Welcome to the Neuro 1 video, Nervous System Basics. Before we get to the lecture, I want to introduce our warm-up review quizzes. From this point on, every video is going to begin with a short warm-up quiz to review high-yield material that was covered earlier in the course. We want to keep all this material fresh in your mind as we get deeper and deeper into the course, and we want to force you to learn actively. So, if you haven't done it already, open up your study guide to the Neuro 1 chapter, and I want you to pause the video and try to answer the 3 questions in the warm-up review box. Don't spend a whole lot of time on it right now. You can come back and look things up later if you need to. Just write down what you can remember and then restart the video and I'll go over the answers with you. Ready? First question says, what are the 3 germ layers that are derived from the epiblast? So they're the ectoderm, the mesoderm, and the endoderm. Next, which amino acids are modified in the Golgi apparatus? We mentioned serine, threonine, asparagine, and tyrosine. And the last question, failure of what process results in eye cell disease or inclusion cell disease? So eye cell disease is one of the lysosomal storage disorder. The process that fails is the addition of a mannose-6 phosphate marker to lysosome enzymes, which means that instead of these enzymes collecting in the lysosomes, they get secreted outside the cell. So how'd you do? Pretty well, I hope. If not, you should go back and review that material later on. But for right now, let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on the nervous system basics. Let's get going before my astrocytes get tired of holding up my big old neurons. So this video is going to focus on some of the most basic foundational stuff regarding the nervous system. And we're going to talk about different cell types found in the nervous system and what they do, and then we'll talk about the blood-brain barrier, and finally we'll discuss neurotransmitters and begin kind of turning our attention to how the nervous system works in reality. So first, let's start with the different types of cells that are found in the nervous system. Now, so we're going to start with neurons. And neurons are the cells that send and receive signals. And they have cell bodies, and they have dendrites. And those dendrites are the ones that receive signals, and then they're going to send out signals down axons. Now, at the terminal end of the axon is the synapse, and that's where the neuron releases neurotransmitters to pass the signal along to the next cell. Now, neurons have rough endoplasmic reticulum, just like other cells, but in neurons, we call the rough ER the Nissl substance or Nissl bodies. Now, it's worth knowing that the Nissl substance is only found in dendrites, not in axons. So if you are looking at a neuron and you're not quite sure if you're looking at a dendritic area or an axon hillock, if it has Nissl substance, then it's a dendrite, not an axon. And then besides neurons, there are a bunch of different non-neuronal, what we call support cells or glial cells. And glial cells include several things. They include astrocytes, microglia, oligodendroglia, appendable cells, and then Schwann cells. And then there's a few others you probably don't need to know for in regards to your test. So first, let's talk about the astrocytes. So astrocytes provide physical support. They repair injuries, they clean up excess neurotransmitter, and they form one layer of the blood-brain barrier, which we'll talk about later. So astrocytes basically kind of keep everything nice and supported and quiet inside the nervous tissue so that the neurons can focus on doing their job. And it's similar to the way Sertoli cells actually support a developing sperm. Now, the astrocytes also, though, create scar tissue in response to injury, and we call that reactive gliosis. So in the same way that maybe fibroblasts elsewhere in the body react to injury, in your brain, it's the astrocytes that respond to injury and then potentially create scar tissue in that CNS. Now, one of the molecules found in astrocytes is GFAP, which stands for gliofibrillary acidic protein. So in cases of astrocyte tumors, you would likely see elevations of that GFAP. Now, one type of astrocyte tumor is called the glioblastoma. The older name was glioblastoma multiforme. Now, we'll talk about glioblastomas in another video, but the tumor marker, again, for glioblastoma is that GFAP. So if your astrocyte tumors produce that GFAP, you can actually follow those GFAP levels to assess the status of the tumor. Is it getting better? Is it getting worse? Another cell type are the microglia. So these are your CNS phagocytes. Now, different tissues in the body have different types of phagocytes, like the monocytes in the blood. Well, in your brain, the phagocytes are called microglia, and microglia are going to respond to tissue damage, but they're not responsible for gliosis. They are there to really just clean things up, and they're a large amoeboid kind of phagocytic cell. Now, one thing to know about microglia cells is that HIV-infected microglia fuse to form multinucleated giant cells in the CNS, which is similar to the way peripheral macrophages can make multinucleate giant cells as well. So microglia respond in HIV infection by making, again, those multinucleate giant cells. Now next is oligodendrocytes. So oligodendrocytes are the myelin cells of the central nervous system. So this is what makes white matter white. They are the predominant type of glial tissue in white matter. Now, myelin is essential for the transmission of a signal down a nerve axon, and one oligodendrocyte can actually myelinate many axons, even up to 50 axons per oligodendrocyte. So oligo in Greek, that prefix actually means having few or little. So their numbers are actually kind of few, but they can myelinate a lot. And it's very important to note that these are the cells that are destroyed in multiple sclerosis, a little pathology there. Now, oligodendrocytes look like fried eggs on H&E stain. So because they have this kind of expansive clear cytoplasm, kind of similar to the cytoplasmic clearing of chondrocytes, and we see that with HPV infection. And it's also similar to the testicular tumor called seminoma. So when you see large clear cytoplasm, you're going to see those in oligodendrocytes, HPV chondrocytes, and then testicular seminoma. And then one final thing, tumors of oligodendrocytes are called oligodendrogliomas. So remember that one. Let's move on to the Schwann cells. So these are the myelin sheath cells of the peripheral nervous system, emphasis on peripheral. So whereas one oligodendrocyte can kind of myelinate multiple CNS in that central area axons, each Schwann cell actually is only going to myelinate one peripheral nervous system axon. And actually each peripheral axon is going to have many Schwann cells attached to it. And those peripheral axons can be extremely long. So it actually makes a lot of sense that they require multiple Schwann cells. Now those Schwann cells are also going to promote axonal regeneration. So when you have an injury to an axon, those Schwann cells are going to create the pathway that guides new axonal growth. So they maintain the integrity of the pathway after the axon has actually been damaged. And it's important to note, pathology-wise, these are the cells that are damaged in Guillain-Barré syndrome. Certainly worth knowing there. It's also important to note that an acoustic neuroma is another type of schwannoma. Now, typically located in the internal acoustic meatus. And then again, pathology-wise, what disease is associated with bilateral acoustic schwannomas or neuromas? That's going to be that neurofibromatosis type 2. Okay, so that's a lot of material on the different cells in the nervous system and even a little bit of pathology as well. Let's do a quick Lewis Notes to solidify this in our brains. All right, everyone, welcome to another Lewis Notes, and we're talking about some neuro cells and how they differentiate themselves from each other. So if you want, you might want to break out a piece of paper and write this along with me to help get this really stuck in your brain, because this is really important stuff. All right, so the first one here, we have CNS phagocyte. Where's that going to go? Well, we're going to combine that over here to our microglia, because remember the microglia are the CNS phagocytes just like macrophages are in the blood. The next one we have here is physical support. So what keeps all of our nerves kind of hold together? That's going to be our astrocyte. Remember, they're just doing a lot of heavy working. Destroyed in MS, or multiple sclerosis, where are you going to see that? Remember, that's going to be in our oligodendrocyte, also referred to as oligodendroglia. Myelinates single peripheral nervous system axon. So remember the difference between myelinating a single one and a multiple one. Remember, this is going to be our Schwann cells. Remember, multiple Schwann cells are going to be maybe on even one axon. Reactive gliosis. So reactive gliosis, remember, went with the astrocyte. So as they're repairing stuff, sometimes they can start producing some scar tissue that maybe isn't the best thing, but that's going to go along with the astrocyte. HIV multinucleated giant cells. Remember, that's going to go with our microglia right there. And then next we have fried egg appearance. So that fried egg appearance is going to go along with our oligodendroglia or oligodendrocyte right there. And then our last one here, damaged in Guillain-Barré, that's going to be with our Schwann cell, so you're more than likely to get some sort of question regarding that type of thing. So let's give you a special bonus picture today. What do you think this is? Yep, that's right. This is going to be an astrocyte. And that's his foot process, so this is where the blood's going to come through, and he's really holding things back. All right, guys, so that's it for the Lewis Notes. All right, so now that you know all of these cell types, let's talk about the embryologic origins of these nervous system cells. So think back to the three germ layers, our ectoderm, our mesoderm, and our endoderm. Now, neuroectoderm is a type of ectoderm, and it's extremely important for neural development. So first, it's going to give rise to the neurons of the CNS, the big guys. Now, the neuroectoderm is also going to produce those ependable cells that kind of line the ventricles of the brain, and those are going to make CSF. The oligodendrocytes and the astrocytes also derive from neuroectoderm. And then the neural crest cells also derive from neuroectoderm, and they migrate throughout the embryo and give rise to the neurons of the peripheral nervous system, as well as the Schwann cells and a bunch of other structures as well. And then also the mesoderm. So mesoderm also contributes to the nervous system. It gives rise to the microglia. Remember, those are the phagocytes of the CNS. Macrophages, just so you know as well, which are those phagocytes of the blood, also originate in the mesoderm as well. Now, those embryologic origins, definitely worth knowing. Step 1 likes to test you on the embryological origins of everything, so make sure you continue to pay attention to those. All right, so now let's move on. Let's switch gears. We're going to move on to the blood-brain barrier. And the blood-brain barrier protects the CNS by keeping microorganisms and drugs and such from crossing into the CSF and affecting the brain. Now, there are 3 layers to that blood-brain barrier, and going from the blood towards the CSF. The first layer is the endothelium of the capillaries, and that's going to form tight junctions, and that's going to keep stuff from readily passing back and forth. Now, these are non-fenestrated endothelial cells. They aren't the leaky endothelial cells that you might find, say, maybe in the glomerulus. These are endothelial cells with tight junctions between them. Now, the second layer is the basement membrane of the capillary, and then the third layer is made up of the foot processes of the astrocytes, so those CNS support cells that we talked about earlier. Astrocytes have several roles to play, and the one very important one is going to be part of that blood-brain barrier. Now, obviously, the blood-brain barrier doesn't keep everything out. You want to let certain things in. Glucose and amino acids, they cross that blood-brain barrier slowly, and they use a carrier-mediated transport mechanism. So you need to regulate how much glucose, how much amino acid you let in the brain, and use a carrier-mediated transport. Now, non-polar lipid-soluble substances cross pretty rapidly through diffusion. So this is important because when we talk about anesthesia later on, the more lipid-soluble an anesthetic is, the more potent the anesthetic is going to be. And there are a few specialized regions of the brain that have fenestrated capillaries and actually no blood-brain barrier, which allows molecules in or out of the brain. Now, one example is the hypothalamus, which projects neurons to the posterior pituitary, and it's going to secrete things like ADH and oxytocin. And you need those fenestrations in those capillaries in order to release those hormones into the circulation directly. And then one final point about the blood-brain barrier is that the blood-brain barrier can be damaged. It can be damaged by trauma, by infection, by stroke. And this is one reason why you might develop edema of the brain in those conditions. Now, just as an extra aside here, what diuretic is commonly given to decrease intracranial pressure just for the short term? The answer there is going to be mannitol. All right, so now we're ready to talk about neurotransmitters. And neurotransmitters are secreted from the terminal portion of the axon. Now, different neurons make different neurotransmitters, and each neurotransmitter can do different things depending on the type of receptor to which it binds. Now, technically speaking, it's the receptor, not the neurotransmitter, that determines that downstream effect that the neurotransmitter will have. But it's kind of easier and usually accurate to think about certain neurotransmitters doing very specific things. So first, let's talk about dopamine. So dopamine is a catecholamine neurotransmitter, and it's going to be increased in things like schizophrenia. It's going to be decreased in depression and also decreased in Parkinson's disease. All right, so there are several different parts of the brain that use dopamine. Let's look at this in more detail. What are the 4 major dopaminergic pathways, and what is the result of blocking these pathways? So this is a bit complex. You might have to watch this a couple times. So first we have the mesocortical pathway, and it goes from the ventral tegmental area of the midbrain to the cortex. Now, if you block this pathway, you have an increase in the negative symptoms of schizophrenia, like social withdrawal and depression. Next, we have the mesolimbic pathway, and that goes from the ventral tegmental area of the midbrain to the limbic system. And here, blocking this pathway relieves the positive symptoms of schizophrenia. So this is a pathway that you are targeting with neuroleptic drugs, your anti-schizophrenic drugs that are dopamine antagonists. And then we have the nigrostriatal pathway, and that goes from the substantia nigra pars compacta to the neostriatum. So these are parts of the basal ganglia, and blocking these pathways is going to result in Parkinson's disease, and stimulation of this pathway can result in extrapyramidal side effects. So when you give neuroleptic drugs to someone with, say, schizophrenia, those neuroleptics can actually potentially cause those Parkinson-like symptoms, because not only do they block the mesolimbic pathway, but they are also going to block the nigrostriatal pathway. And in blocking the nigrostriatal pathway, you get upregulation of dopamine receptors, and that can result in those extrapyramidal side effects such as dyskinesia and acute dystonia. And then finally, we have that fourth pathway. This is the tubuloinfundibular pathway, which goes from the arcuate nucleus of the hypothalamus to the pituitary. And blocking this pathway will increase prolactin secretion from the anterior pituitary. So this elevated prolactin causes hypogonadism, which manifests as amenorrhea in women and then decreased libido in men. Then rarely can cause things like gynecomastia and even some galactorrhea. So we'll see in other lectures that the anti-dopamine agents, which are the neuroleptics, can cause elevations in that prolactin, and that one way to treat a prolactin-secreting tumor is to give a dopamine agonist, maybe something like bromocriptine. Now, the next neurotransmitter I want to cover is norepinephrine. So it's also a catecholamine, and besides being secreted by certain neurons, it also comes from the adrenal medulla. So let's look at this again. What disorder is thought to arise from reduced norepinephrine activity? Well, depression primarily. And what disorder arises from increased norepinephrine activity? You got to think about anxiety, maybe even mania. In Pharm Basics, we're going to actually discuss how amphetamines and cocaine cause their effects by increasing the release of norepinephrine. Now, where does norepinephrine come from in the brain? Well, mainly from the locus coeruleus, but it's also made in the reticular formation as well as the solitary tract. All right, next we're going to talk about serotonin. So serotonin, often abbreviated as 5-HT. It's a little confusing. And it's also decreased in the brain with anxiety, decreased with depression. And the primary location of serotonin in the brain is the raphe nucleus. Next, we have acetylcholine. That's going to be decreased in Alzheimer's dementia and also decreased in Huntington's disease, and it is increased in Parkinson's disease. Now, the location of synthesis is the basal nucleus of Meinert, and you have degeneration of this area in Alzheimer's disease. So degeneration of the basal nucleus of Meinert results in decreased acetylcholine, which then will lead to that Alzheimer's dementia. So that's going to be an answer to another study guide question. What disease is associated with the degeneration of the basal nucleus of Meinert and less seen as acetylcholine? Again, Alzheimer's disease. So now let's talk about GABA, or gamma-aminobutyric acid. So GABA is the main inhibitory neurotransmitter of the central nervous system. Now GABA is made from glutamate, and in order to synthesize GABA from glutamate, you need vitamin B6. Now if GABA is the main inhibitory neurotransmitter of the brain, think about what happens when there is less GABA. You have excitation. So potentially a deficiency in B6 can result in less GABA, and that can actually even lead to seizures. Now, GABA is also decreased in anxiety. Again, anxiety being kind of a state of hyperarousal. So anti-anxiety drugs like benzodiazepines and barbiturates are going to increase the effects of GABA. That's how they work. GABA is also decreased in Huntington's disease, and this causes that coriform movement, that excess muscle excitation. And then the location of synthesis of GABA is the nucleus accumbens. I also want you to know that glycine is another main inhibitory neurotransmitter of the spinal cord, and that glutamate is that main excitatory neurotransmitter of the brain. Now, a lot of these locations that we've discussed so far are part of what is called the reticular activating system. So what are the components of the reticular activating system? So there are three main structures. There's the reticular formation, the locus coeruleus, and then the raphe nuclei. Now we saw that the locus coeruleus is where norepinephrine comes from, and that raphe nuclei is where serotonin comes from. Now what is that reticular activating system then? Well, it's going to mediate a lot of consciousness, wakefulness, and attentiveness. So stimulation of that reticular activating system results in more attentiveness. So think about it, more norepinephrine, more serotonin, it's going to result in more attentiveness and alertness. Now, if you lesion or have some sort of pathology of the reticular activating system, you have less synthesis of serotonin, norepinephrine in the brain, and you can actually lead somewhere down to a coma. So a lesion to the reticular activating system, think of coma, decrease alertness. All right, that's it for the lecture part. It's time for that end of session quiz. Go ahead and stop the video, try to answer those questions, and then we'll go through them together. All right, first question. Which nervous system cell matches each of the following descriptions? So first we have looks like a fried egg under histologic staining. Remember, those are going to be your oligodendroglia. Next we have form multinucleated giant cells in the CNS when infected with HIV. Those are going to be your microglia. Myelinates multiple CNS axons. Those are those oligodendroglia. And then myelinates one peripheral nervous system axon. That's going to be your Schwann cell. Damaged in Guillain-Barré syndrome, that's going to be your Schwann cells again. Damaged in multiple sclerosis, that's going to be your oligodendroglia. Macrophages of the CNS, those are going to be your microglia. And then cells of the blood-brain barrier, remember that's those astrocytes that are foot processes. Next, in which neurological disease is acetylcholine altered? So acetylcholine is decreased in things like Alzheimer's disease and even Huntington disease, and then it's going to be increased in things like Parkinson's disease. Although when you hear Parkinson, I want you to first and foremost think of dopamine deficiency and the substantia nigra pars compacta. Next, what is the main inhibitory neurotransmitter of the CNS? And in which disease are levels altered? So the main inhibitory neurotransmitter, remember, it's that GABA. And then if you have that decreased GABA, you're going to see that in Huntington's disease and even anxiety. And the last one here, what are the components of the blood-brain barrier? So you need to be familiar with those three structures that form the blood-brain barrier. Remember, you have the non-fenestrated endothelial cells with tight junctions, you have the basement membrane, and then you have the astrocyte foot processes. All right, guys, that's it for our video today. I hope you learned something. I'll see you next time. Hello, everyone. Welcome to a warm-up review. Let's get going. First question here. Which organelle becomes hypertrophied in hepatocytes with chronic phenobarbital use? The answer is the smooth endoplasmic reticulum. Next question. Which enzyme mitigates the aging effects of cellular division by maintaining chromosomal length? The answer here is telomerase, and telomerase is that RNA protein complex that adds repeated DNA sequences to the terminal ends of the linear ends of chromosomes. Next question. What are the neural crest derivatives in each of the following adult structures? So what do those neural crests become? Well, in our peripheral nervous system, they're going to become the autonomic nervous system, like the vagus nerve and the sympathetic ganglia. You're also going to see it become the dorsal root ganglia, so sensory nerves, cranial nerves, and Schwann cells. Now, in the adrenal gland, you're going to see those become the chromaffin cells in the medulla. And then in the thyroid, you're going to see them become the parafollicular cells, also known as those C cells. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to return to our old friend embryology and talk about how the brain develops and some things that can go wrong. If you remember from the Foundations 1 video, the notochord induces the ectoderm to form the neural plate and the neural crest. We talked about how that neural plate folds up and forms the neural tube, and we called that the process of neurulation. And in the early stages, this is an open tube with an opening or a pore at either end of the tube, which are called neuropores. We'll come back to those shortly. The cells lining the neural tube are eventually going to become the brain and the spinal cord, and the canal itself, the space inside the neural tube, will become the ventricles of the brain and the spinal canal. During week 4 of development, the rostral end of the neural tube, the end that will eventually become the head, will start to dilate into 3 structures that will become the brain: the prosencephalon, the mesencephalon, and the rhomencephalon. The prosencephalon is up front, so that's the forebrain, and the rhomencephalon is the hindbrain. And then at week 5, the prosencephalon becomes the telencephalon and diencephalon, and the rhomencephalon becomes the metencephalon and the myelencephalon. And then what adult structures will these eventually become? Well, the telencephalon becomes the cerebral hemispheres, the basal ganglia, the hippocampus, and the amygdala. These are the high-level structures in the brain. The diencephalon becomes the thalamus, the hypothalamus, and the optic nerves and tracts. The mesencephalon becomes the midbrain. The metencephalon becomes the cerebellum and the pons. and the myelencephalon becomes the medulla. Now this is about a 3-star topic. You may or may not see this on your test, but if you do, you'll be glad you reviewed it. Now let's talk about some of the things that can go wrong in this development, starting with neural tube defects. Remember we said that on the ends of the neural tube are openings called neuropores, which connect the inside of the neural tube to the surface ectoderm. In the 4th week, if the neuropores on either end of the neural tube fail to fuse so that there's a connection between the spinal canal and the amniotic cavity, a neural tube defect results. And the main risk factor for neural tube defects is low folic acid levels. If the embryo doesn't have enough folic acid at this stage of development, that can predispose to neural tube defects, which is why women of childbearing age need to supplement folic acid. Most multivitamins have 0.4 milligrams of folic acid, but some prenatal vitamins double that to at least 0.8 milligrams or even 1 milligram. Women at high risk of having a baby with a neural tube defect are recommended to take 4 milligrams per day. So if you previously had a child with a neural tube defect, then you need to supplement folic acid 4 milligrams, not 0.4 milligrams per day. To check for neural tube defects in utero, we can look at the sonogram and inspect for a defect visually, and we can also look at mom's serum with a quadruple screen, or a quad screen. If there's a neural tube defect, the maternal alpha-fetoprotein will be elevated. If the alpha-fetoprotein level is elevated, that usually would indicate one of 2 big things. One is a neural tube defect, and the other is an anterior abdominal wall defect, which will be covered in another video. In trisomy 21, or Down syndrome, the quad screen would show a decreased maternal AFP. So if you do your quad screen and there's an increase in AFP, but you can't see a neural tube defect or abdominal wall defect on ultrasound, what do you do next? Well, you can perform an amniocentesis and look for increased AFP in the amniotic fluid. And if it's also elevated in the amniotic fluid, then you've confirmed that there must be a defect. There are 3 main types of neural tube defects. Spina bifida occulta is the mildest form. That's where you have failure of the spinal canal to close only on the bony level. There's no herniation of the spinal cord, but there can still be some physical limitations that result from this type of neural tube defect. This nearly always occurs in the lumbosacral region, and often there's a little tuft of hair on the skin over the sacrum, which is a huge clue on your newborn exam. If you see that tuft of hair in exam, you might want to obtain an ultrasound of the region to see if the bones fail to fuse properly. The other types of neural tube defects are the meningocele and a myelomeningocele. If it's just the meninges that are herniated, we call it a meningocele. If both the meninges and the spinal cord have herniated, then it's a myelomeningocele. Next, let's talk about forebrain anomalies. Neural tube defects usually present in the lumbosacral region, but there can be problems with the neuropore at the cranial end of the developing neural tube. And that causes something called microencephaly, or the more commonly used term is anencephaly, or sometimes microanencephaly. This is where the calvarium and most of the brain fails to develop. We have an image of this, but it's a little disturbing. The neuropore fails to close, so the cranium doesn't really develop properly, and it's left open and exposed to the amniotic fluid. But there's usually some brainstem tissue. That's why this is most appropriately called microencephaly or microanencephaly. Micros is Greek for part, so part of the brain is present, but most of it is not. But obviously this is incompatible with life. And as a clinical pearl on ultrasound, these fetuses usually have polyhydramnios, or an excessive amount of amniotic fluid, because they've lost the swallowing center of the brain. Normally, the fetus is constantly swallowing the amniotic fluid and then urinating it back out. But with microencephaly, the swallowing center of the brain is damaged or absent, and the amniotic fluid keeps building up, and you'll see polyhydramnios. Another forebrain anomaly is holoprosencephaly, which we've seen once before. Remember, holoprosencephaly is where the hemispheres of the brain fail to separate across the midline. Two characteristic findings of holoprosencephaly are cleft lip and palate and cycloplia. So the most severe example would be a single midline eye, although it might just be very close set eyes. We said this can be seen in sonic hedgehog gene mutations, severe fetal alcohol syndrome, or in Patau syndrome, also known as trisomy 13. Another group of developmental disorders are the posterior fossa malformations. So instead of forebrain abnormalities, now we're talking about hindbrain abnormalities. We call these Chiari malformations, or sometimes you'll hear them called Arnold-Chiari malformations. I won't get into the distinction between the two because it's not really important for this test. Basically, a Chiari malformation is where part of the cerebellum herniates downward through the foramen magnum at the base of the skull. There are 4 different classifications, but you really only need to focus on type 1 and type 2. A Chiari 1 malformation is the mildest form, where only the cerebellar tonsils herniate. But since you now have cerebellar tissue squished into the spinal canal, this can sometimes compress the spinal cord and lead to something called a syringomyelia. We'll cover syringomyelia in a later video on spinal cord lesions. A Chiari 2 malformation is where you have a lumbosacral myelomeningocele, and that results in a more significant herniation of the tonsils and also the vermis. So there's a big neural tube defect down low, it's lumbosacral, and it causes herniation up at the foramen magnum. But because of this herniation over time, you can see stenosis of the aqueduct and some hydrocephalus. This is an MRI of a child with a Chiari 2 malformation, and you can see that the third ventricle, marked V, is fairly enlarged. So that's hydrocephalus. There's also Chiari 3 and Chiari 4 malformations, which are progressively more severe, but again, I don't think these are likely to show up on your test. One last type of posterior fossa malformation to mention briefly is the Dandy-Walker syndrome. Basically, this is where you have an enlarged posterior fossa and the cerebellar vermis fails to develop. So the fourth ventricle dilates to fill up the space that's left, and this can be associated with hydrocephalus and spina bifida. The other major embryology topic I want to go over is the pharyngeal apparatus, because this is where several of the cranial nerves arise from. Now, I know that some of you panic when you hear the phrase pharyngeal apparatus, or you may know it by the older name, the branchial apparatus. But we're going to focus only on what you need to know for your exam, because it's really easy to get bogged down in this stuff and get confused. The pharyngeal apparatus is composed of the 6 lumps of tissue on each side, and we call the lumps of tissue pharyngeal arches. Then on the lateral sides, the grooves between the arches are called pharyngeal clefts. And then the grooves on the medial side of the arches are called pharyngeal pouches. The clefts are derived from ectoderm. You can remember that the C for clefts matches the only embryologic tissue with a C in the name, which is ectoderm. Not endoderm, not mesoderm, but ectoderm. The arches are derived from mesoderm. Remember that mesoderm bridges the gap between ectoderm and endoderm, in the same way that an arch bridges a gap. And the pouches are derived from endoderm. So endoderm on the inside, ectoderm on the outside, and mesoderm in the middle. We're going to talk about each of these in turn, starting with the clefts, because they're the most straightforward. Then we'll work our way up to the arches. So again, the pharyngeal clefts are the ectodermal portion of the pharyngeal apparatus. Let's focus on what adult structures arise from the pharyngeal clefts. The first cleft develops into the external auditory meatus. The second, third, and fourth clefts form temporary cervical sinuses that are obliterated later. And that's pretty much it for the clefts. Pretty easy. Now, if one of those temporary cervical sinuses fails to be obliterated so that it persists, the patient might be born with what we call a pharyngeal cleft cyst in the lateral neck, which is found under the skin. Another type of neck cyst that you might see is a remnant of the thyroglossal duct, which is formed when the thyroid gland slides down from the base of the tongue into its final position in the neck. That thyroglossal duct is normally obliterated, just like the second, third, and fourth pharyngeal clefts. But if it persists, we call it a thyroglossal duct cyst. And the reason I bring this up is that if you're given a patient with a cyst in the neck, you need to be able to distinguish between a thyroglossal duct cyst or a pharyngeal cleft cyst. So here are a couple of clinical clues. First of all, the location. Pharyngeal cleft cysts are located in the lateral neck, where the pharyngeal apparatus was. And where's the thyroid? In the midline. So a thyroglossal duct cyst will be located in the midline. The second clue is whether or not the cyst moves when you have the patient swallow. A pharyngeal cleft cyst does not move when you swallow, but a thyroglossal duct cyst is pushed around by the thyroid cartilage, so it does move with swallowing. So make sure you can tell those two apart. That's very important to know for your test. So the clefts are pretty easy. Now let's talk about the pharyngeal pouch derivatives. Remember, the pharyngeal pouches come from endoderm. The first pouch will become the middle ear cavity, the eustachian tubes, and the mastoid air cells. So the first cleft became the external auditory meatus, and the first pouch becomes all these middle ear structures. That makes sense. The second pouch gives rise to the epithelial lining of the tonsils. The third pouch becomes the inferior parathyroid glands and the thymus. And then the fourth pouch becomes the superior parathyroid. So the third pouch structures are actually inferior to the fourth pouch structures, which seems a little strange. But take note that the third and fourth pouches give rise to the parathyroid glands and the thymus. This is clinically relevant because of something called DeGeorge syndrome. DeGeorge syndrome is an immunodeficiency syndrome, which we'll talk about during immunology. In DeGeorge syndrome, you don't have normal development of the third and fourth pharyngeal pouches, so you won't have a thymus or parathyroids. Without a thymus gland, the T cells can't mature, and that causes the immunodeficiency part. And without the parathyroid glands, the patient gets hypocalcemia. So for DeGeorge syndrome, you need to remember thymic aplasia, T cell deficiency, and hypocalcemia. Now, let's roll up our sleeves and get after these pharyngeal arches. Again, the pharyngeal arches are mesoderm-derived structures. And the good news is that even though this is pretty complicated, you don't need to get too bogged down in these. Mainly, I want you to know a handful of quick mnemonics and associations that we're going to go over. Each pharyngeal arch has a cartilage, which becomes bony structures, a muscle component, and a nerve. It also has an artery or an aortic arch, and we're going to talk about those in the cardiovascular section. Starting with the first pharyngeal arch, I want you to remember that the first arch gives rise to M and T structures. You start with Meckel's cartilage, which gives rise to several jaw structures, the mandible, the mandibular ligament, and also the malleus and the incus. Remember that the first cleft and the first pouch were associated with the ear, and here the first arch is forming the ossicles of the middle ear. And maybe remember that the ossicles are derived from neural crest, which is ectoderm, not mesoderm, while the mesoderm of the pharyngeal arches gives rise to the muscles and other structures, but the bones and cartilage come from neural crest cells, which have migrated here. For the muscles, again, think about the jaw, and you have the muscles of mastication, including the masseter, the medial pterygoid and lateral pterygoid, and the temporalis muscle, which is one of the T structures. Also, the mylohyoid muscle, and then some more T's, the tensor tympani, the tensor veli palatini, and the anterior 2/3 of the tongue. And the nerves that innervate these structures are the mandibular and maxillary branches of the trigeminal nerve. So lots and lots of M's and T's. And if the first arch neural crest cells fail to migrate, you get another T word, Treacher-Collins syndrome, which is a series of facial abnormalities that you don't really need to memorize for step 1. Step 1 won't expect you to distinguish the differences between facial features of different genetic disorders. But if you're curious, you can find images of Treacher-Collins syndrome on the internet. Basically, these individuals have an underdeveloped mandible and underdeveloped cheekbones. For the second arch, you can remember that the second arch gives rise to the S structures, the stapes, which is another middle ear ossicle, the styloid process, the stylohyoid ligament, and the double S in the lesser horn of the hyoid. The nerve that innervates the second arch muscles is cranial nerve 7, another S. And you know that cranial nerve 7 is the facial nerve, which innervates the muscles of facial expression. So for the muscles derived from the second arch, you have the muscles of facial expression, even though they don't start with S. And then also the stapedius and the stylohyoid, which are back to the S's. And then the possible congenital abnormality here is the pharyngocutaneous fistula, which is a fistula between the tonsillar area and the cleft in the lateral neck. And we also talked about how persistence of this cleft can lead to a pharyngeal cleft cyst, a lateral neck cyst that does not move when you swallow. For the third arch, the quick association is the word pharyngeal. Know that the third arch muscle, the stylopharyngeus, is innervated by a branch of the glossopharyngeal nerve, cranial nerve 9. For arches 4 and 6, think about the words cricothyroid and the larynx. You've got the cricoid cartilage, the thyroid cartilage, and the rest of the cartilages of the larynx, arytenoids, corniculate, cuneiform. And for the muscles, there's the cricothyroid muscle, which comes from the fourth arch, and the rest of the laryngeal muscles come from the sixth arch. Fourth comes before sixth, so fourth gets to choose first. The fourth arch also develops into the pharyngeal muscles, which are involved in swallowing. And since we're talking about the fourth and sixth arches, 4 plus 6 gives you cranial nerve 10, or the vagus nerve. The superior laryngeal branch of the vagus innervates the muscles that came from the fourth arch, the muscles involved in swallowing. And the recurrent laryngeal branch of the vagus nerve innervates those laryngeal muscles that came from the sixth arch, which are needed for speaking. And then, what about the fifth arch? Did we skip that? No. The fifth arch basically recedes and makes no major developmental contributions. So again, to help you remember the structures, the first arch is the M's and T's. Second arch is the S's. The third arch is the word pharyngeal. And the fourth and sixth arches are the words cricothyroid and larynx. All right, that's enough embryology for now. Let's pause the video and complete the end of session quiz, then we'll talk through the answers. All right, let's go through these together. First question, what abnormalities are often found with a Chiari malformation? We said a Chiari 1 malformation can lead to a syringomyelia, and a Chiari 2 malformation can be associated with a myelomeningocele, and it can lead to hydrocephaly. Next question. What amniotic fluid lab abnormality might point you to a diagnosis of anencephaly? You'll most likely see an increased alpha-fetoprotein in the mom's serum and in the amniotic fluid, because anencephaly is a type of neural tube defect. And lastly, from which pharyngeal pouch is each of the following structures derived? Middle ear and eustachian tubes are from the first pharyngeal pouch. Superior parathyroids are from the fourth pouch. Inferior parathyroids are from the third pouch. The epithelial lining of the palatine tonsil is from the second pouch, and the thymus is from the third pouch. All right, That's it for this video. See you next time.
It's time for another warm-up review. Let's get going. Which types of proteins are responsible for fostering the progression through the cell cycle? So the answer is going to be the cyclins and also the cyclin-dependent kinases. Next question. Which cytokine is particularly important in maintaining granulomas? The answer here is going to be TNF-alpha. Next question. Which type of collagen is typically deficient in osteogenesis imperfecta type 1? It's going to be an abnormality of type 1 collagen. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to review the vascular supply to the brain and the functional organization of the brain, specifically the organization of the cerebral cortex. The cerebral cortex can be divided into the motor cortex and the sensory cortex, and the landmark that divides it is the central sulcus. All of the motor cortex is located anterior to the central sulcus, just like the motor of a car is located in the front of the car, usually. And then the sensory cortex is located posterior to the central sulcus. Let's look first at the motor cortex. Just anterior to the central sulcus is the primary motor area, and anterior to that is the premotor cortex, which may be involved in planning movement and guiding movement based on sensory input. Moving farther anterior into the frontal lobe, you get to the frontal eye fields, which is involved in eye movements, causing your eyes to scan over whatever it is you're paying attention to, kind of creating a visual map of that information. And then moving lateral along the frontal lobe, you have the motor area related to language production, which is called Broca's area. Now, if you know any Spanish, the Spanish word for mouth is la boca, which sounds like Broca. So Broca's area controls la boca. And in most people, Broca's area is located on the left hemisphere. Then posterior to the central sulcus are regions of the sensory cortex. So the primary sensory cortex is adjacent to the central sulcus and just kind of across the street from the primary motor cortex. And then as you move down that strip of cortex to the upper temporal lobe, kind of close to your ears, is the primary auditory cortex, which processes auditory information. Then just posterior to the auditory cortex is Wernicke's area, which is linked to the comprehension of language. So the primary auditory cortex processes the sounds you hear, and then Wernicke's area right next door is involved with helping you recognize those words and understand them. And again, Wernicke's area is usually located on the left. Then there's a bundle of fibers called the arcuate fasciculus that forms a connection between Wernicke's area and Broca's area to facilitate communication between these two areas, since both of these areas are involved with language. And actually the connections are bidirectional, even though this arrow just shows it going one way. And then the last area of sensory cortex I want to point out is the primary visual cortex, which is on the occipital lobe on the back of the brain, about as far from the eyes as you can get. Back up at the front of the brain, you have the frontal cortex, which I like to think of as the responsible, no-nonsense, business-like part of the brain. The frontal cortex is involved with judgment and decision-making, and also suppressing primitive urges. The frontal lobe is responsible for overriding the more primal animal urges like feeding and fighting and procreation that come from the more primitive parts of your brain. So a frontal cortex lesion can result in disinhibition and poor judgment and personality changes, and sometimes the return of primitive reflexes like the rooting reflex or the grasp reflex. We sometimes call these frontal release signs. Next, let's talk briefly about the homunculus. The word homunculus means little man in Latin, and it kind of describes the way the different parts of the body are mapped to different parts of the motor and sensory cortex. As you can see, both the motor and sensory cortex are laid out so that the head and face are located on the lateral part of the cortex, and then the hand and arm is superior to that, with the trunk and the legs kind of flopped over into the medial part of the cortex. And you can also see that the hand, for instance, maps to a much larger area of cortex than the feet do, because we need a lot of cortex to manage the fine motor skills related to our fingers. And the mouth and tongue map to a relatively huge area of motor cortex so that we can manipulate our mouths and speak. Now, clinically, the reason that these homunculi are so important is that occlusions of different cerebral arteries will predictably affect certain parts of the cortex and therefore affect certain parts of the body. So before we look at that, let's review the blood supply to the brain. Blood supply to the brain is very important for step 1, especially the circle of Willis, which itself is about a 4 or 5 star topic. We're going to get to the circle of Willis in just a moment. But first, we have to get the blood from the heart and the chest up to the brain. So there are 4 arteries that supply the brain: 2 internal carotids, and 2 vertebral arteries. Let's look at the carotids first. The common carotid runs up the neck toward the head inside the carotid sheath, along with the internal jugular vein and the vagus nerve. The common carotid then divides into the external carotid, which supplies the face and the scalp and the meninges, and the internal carotid, which supplies the brain. We're going to see the internal carotid contributing to the anterior part of the circle of Willis in just a moment. Then the vertebral arteries contribute to the posterior circulation of the brain. The vertebral artery arises from the subclavian artery, and it runs through the transverse foramina of the cervical vertebrae all the way up the neck. And then the vertebral arteries give off the pica, the posterior inferior cerebellar artery, and also the anterior spinal artery to supply the cervical spinal cord. And then the vertebrals merge to form the basilar artery. So the vertebrals and the basilar artery are the main blood supply to the cerebellum and the brainstem. So again, what supplies blood to the cerebellum and the brainstem? The vertebral arteries and the basilar artery. Now we're ready to look at the circle of Willis. You need to be able to label the circle of Willis either on a diagram or on an actual angiogram. So look at the diagram of the circle of Willis in your study guide and we'll label it together. I'm actually going to label these out of order, so just follow along with me. Starting at the top of the diagram, where the actual circle is, you have the main source of blood, which is the internal carotid artery, which is letter D. And then there are 3 main arteries that go out to the brain and supply blood to the cerebrum. Letter A is the anterior cerebral artery, or the ACA. Letter C is the middle cerebral artery, or the MCA. And letter F is the posterior cerebral artery, or PCA. And you'll notice that these 3 arteries are a little bit larger in diameter than a lot of the other arteries in the circle of Willis. So that makes these easier to identify. For example, you can see that letter F is a bit larger than letter G. So remember that the cerebrum is a big part of the brain, certainly bigger than the cerebellum. So the cerebral arteries are bigger than the cerebellar arteries when you have to identify them. In fact, the MCA, which is letter C, the MCA is just kind of a continuation of the internal carotid. So it really is a huge diameter artery. And as we'll see in a moment, the MCA territory of the cortex is enormous. Now, the reason that the circle of Willis is a circle is that you have these anastomoses between these 3 big arteries. And these anastomoses are called the communicating arteries. So letter B is the anterior communicating artery, which runs between the 2 anterior cerebral arteries. And then letter E is the posterior communicating artery, which connects the MCA to the PCA. So that does it for the anterior circulation. Now let's look at the posterior circulation of the brain, which supplies the cerebellum and the brainstem. In fact, let's follow the flow of blood up from the neck again. So letter J is the vertebral artery coming up from the cervical spine. And then the vertebral arteries are going to merge to form letter H, which is the basilar artery. And we said that the vertebrals and the basilar artery supply blood to the cerebellum and the brainstem. And then coming off the basilar arteries, you have a bunch of pontine branches, which aren't labeled here, but those pontine branches supply the pons. Now we said before the vertebrals merge, they give off 2 things. So letter L is the anterior spinal artery, and then letter K is the posterior inferior cerebellar artery, or the pica. So remember those 2 as the arteries that come off the vertebral arteries before the vertebrals merge to form the basilar artery. Again, it's the anterior spinal artery and the pica. Now look at letter I. If there's a posterior inferior cerebellar artery, it stands to reason there must be an anterior inferior cerebellar artery. So letter I is the AICA. And if there are inferior cerebellar arteries, that means there must be a superior cerebellar artery, and that's letter G. And again, the cerebellum is smaller than the cerebrum, so you can remember that the superior cerebellar artery is smaller in diameter than the posterior cerebral artery, if you happen to see them side by side and you're not sure which is which. So G is the superior cerebellar artery, and I is the anterior inferior cerebellar artery, and K is the posterior inferior cerebellar artery, or the pica. Now, it's one thing to label a nice, neat diagram, but let's also try to apply this to actual arteriograms. In real life, things tend to get squashed and distorted a bit, and real anatomy isn't perfectly symmetrical. And you can't identify every single artery on this image. But I hope you can recognize this circle at the top. And then what are these 2 parallel arteries very close together? Those are the anterior cerebral arteries, the ACAs. And what's the artery that links the 2 anterior cerebrals? It's the anterior communicating. And the anterior cerebrals run all the way back to here, which means that this is the MCA, the middle cerebral artery. And this great big fat artery
is the internal carotid, which means that this, on the patient's left facing you, is the posterior communicating artery. And somewhere in here is the posterior cerebral artery, but they kind of get all jumbled up. But this big one over here on the patient's right must be the right posterior cerebral artery. And it's coming together with the left posterior cerebral artery to form the basilar artery, that big midline artery that runs down the anterior surface of the brainstem. Then the basilar artery splits into two vertebral arteries, and this little one coming off the top of the basilar artery is the superior cerebellar artery. And remember, the PCA is bigger around than the superior cerebellar. So that's a pretty good look at the anterior circulation. So now let's take a look at the posterior circulation. In this arteriogram, they've injected the left vertebral, and we're seeing some retrograde flow into the right vertebral as well. And then this is the basilar artery. And we can make out some small arteries coming off the basilar artery here and here. And then there's some arteries coming off the vertebrals here and here. So what do we say comes off the vertebral arteries? Well, there's the anterior spinal artery, which I don't really see, but it would come down like that. And that means that these coming off the vertebrals must be the pica. And these coming off the basilar artery are the AICA, the anterior inferior cerebellar artery. And you notice that these two kind of loop around the cerebellum and anastomose with one another. Then moving up to the other end of the basilar artery, we have a pair of small branches and a pair of larger branches. And one last time, the cerebellum is smaller than the cerebrum, so the small diameter branches are the superior cerebellar artery, and the larger diameter branches are the posterior cerebral artery. We don't really get good penetration of the contrast into the anterior circulation in this image, but you can imagine the posterior communicating arteries up here, and the MCAs, and the big anterior cerebral arteries coming up like this, and the little tiny anterior communicating artery. So that is the circle of Willis.
Now let's talk about which parts of the cortex are supplied by each of those big three cerebral arteries, the ACA, the MCA, and the PCA. Now, this is another 4-star topic. You need to know what part of the cortex each of these three arteries supplies and what an occlusion of that artery is going to look like both clinically and what it's going to look like on a CT scan. Let's start with the ACA. So when the anterior cerebrals come off the MCA, they reflect backwards along the corpus callosum, supplying blood to the medial portions of the cortex down deep in the longitudinal fissure. And if you look back at your homunculus, you see that this corresponds to the leg and the foot region on both the motor cortex and the sensory cortex. So occlusion of the ACA will result in decreased sensation and decreased motor strength of the leg and foot area. Now, we said the middle cerebral artery is a big artery that supplies blood to a big area of the cortex, basically the entire lateral aspect of the primary motor cortex and the primary sensory cortex, and even Broca's area. So an MCA stroke is going to affect motor control and sensation of the face and the hand, and it may cause some aphasia. We're going to talk about aphasia a little bit more in a moment. And then the posterior cerebral artery supplies the occipital lobe. So a PCA stroke will be associated with visual defects because that's where the visual cortex is found. Now, we talked a tiny bit about Broca's area and Wernicke's area, which are both related to language. And we said that an MCA stroke could damage Broca's area and lead to aphasia. So let's talk about aphasia in a little more detail. Aphasia has to do with difficulties producing or understanding language. Some patients have expressive aphasia where they may understand everything that you say to them, but they cannot generate language to express themselves. And then other patients may have receptive aphasia where they may be able to speak, but they can't really understand what you're saying to them, or they can't understand what they read. So aphasia might not affect only speech, but written language as well. Some patients with expressive aphasia can't generate words to speak, and they also can't generate written words to express themselves. So think about aphasia as affecting language globally rather than merely speech. Now we typically think about Broca's area being related to language production. We think about Wernicke's area being related to language comprehension. So that's probably a little bit oversimplified because newer research suggests that Broca's area actually plays a role in language comprehension as well. But if you have a stroke or brain lesion that damages Broca's area, it typically causes a non-fluent aphasia or an expressive aphasia. We call this Broca's aphasia. So these patients may be able to say a few words, but they're not going to be able to string those words together into sentences. Now, their language comprehension is intact. These patients with Broca's aphasia have trouble expressing themselves. So I like to think about Broca's aphasia causing broken speech. Although again, it's not just speech, it may include written language as well. Now, Wernicke's aphasia occurs when there's a lesion to Wernicke's area, and that influences language comprehension. So in these patients with Wernicke's aphasia, comprehension is impaired. So this is a receptive aphasia. These patients have difficulty understanding what is said to them. And when they speak, they may be able to produce a nice fluid stream of words, but those words may not make a lot of sense. So we call this a fluent aphasia. These patients are going to string together several words into a sentence. It just doesn't make any sense. There's also conduction aphasia, in which comprehension is intact and the language is fluent, but they can't really repeat what you say to them. So conductive aphasia occurs due to a lesion of that arcuate fasciculus, that tract that connects Broca's area to Wernicke's area. So if you say a phrase to the patient and you ask the patient to repeat it, there's no connection between what the patient hears and what he can express verbally. There's also global aphasia, in which both Wernicke's and Broca's areas are affected, and that means that these patients have impaired comprehension and non-fluent aphasia. There's also something similar to aphasia called dysprosody. Take a look in your study guide. Prosody means the musical qualities of speech, the rhythm, the stress, the intonation. Now, prosody can influence meaning, and it can be used to indicate emotion or emphasis. If I say, "You're going to rock step one," it carries a very different meaning than if I said, "You're going to rock step one." That's prosody. Now, dysprosody occurs when we lesion the cortex that corresponds to Broca's area or Wernicke's area, but on the non-dominant side of the brain. Remember, we said that Broca's area is located on the left hemisphere in most people because the left hemisphere is the dominant hemisphere. But if you lesion the same area on the right hemisphere, you get dysprosody. So expressive dysprosody is where you have the inability to express emotion or inflection in your speech. These patients come across as very monotone. They may seem depressed, like they have blunted affect. And again, this is due to a lesion of the non-dominant cortex that corresponds to Broca's area, so it's usually on the right hemisphere. And then receptive dysprosody is an inability to comprehend emotion or inflection or prosody in speech, which probably leads to a lot of unfortunate misunderstandings when they can't tell if someone's being sarcastic to them. And again, this is due to a non-dominant cortical lesion corresponding to Wernicke's area. Now let's review a couple of clinical syndromes that can result from lesions to specific parts of the parietal cortex. I'm going to start with Gerstmann syndrome, which is a 3 or 4 star topic. Gerstmann syndrome is caused by a lesion to the dominant angular gyrus, which is on the parietal lobe just posterior and superior to Wernicke's area. And like Wernicke's area, the angular gyrus is also involved with some complex language and communication functions. So a lesion here will result in agraphia, which is an inability to write, and also acalculia, which is an inability to do mathematical calculations, addition, subtraction, multiplication, that kind of thing. It can also result in right to left disorientation, so these patients can't tell right from left. And it can cause finger agnosia, which is an inability to distinguish the fingers from one another. So these patients can't look at a finger and identify it as a thumb or a middle finger or whatever. So they might get really offended if you gave them a big thumbs up. Think about it. So again, Gerstmann syndrome is a lesion to the dominant angular gyrus in the parietal lobe, which is usually the left parietal lobe, because most people are left dominant. But what about a lesion on the non-dominant parietal lobe? Again, that's usually the right parietal lobe. A lesion here can cause something called hemispatial neglect syndrome, which means that the patient neglects or ignores one side of the world, usually the contralateral side or the left side. So a patient may only put makeup on the right side of her face, or may only shave the right side of his face, or he may only eat food on the right side of his plate, or he may see his left arm and not really recognize it as his own arm. So now we're ready to pause the video and answer the end of session quiz. All right, first question. A lesion to which area of the brain is responsible for each of the following clinical scenarios? So hemispatial neglect syndrome is a lesion to the non-dominal parietal lobe, which is usually the right parietal lobe. Poor repetition is conduction aphasia due to a lesion of the arcuate fasciculus. Poor comprehension is a lesion to Wernicke's area. Poor verbal expression is a lesion to Broca's area. Personality changes and disinhibition is a lesion in the frontal lobe. And agraphia and acalculia
is lesion to the angular gyrus on the dominant parietal lobe, which is typically the left parietal lobe. Remember, this is called Gerstmann syndrome. Next, which arteries are chiefly responsible for supplying blood to the brainstem? The basilar artery and the vertebral arteries. And the last question, what artery is damaged in each of the following presentations? In Broca or Wernicke aphasias, it's the middle cerebral artery. Unilateral lower extremity sensory and or motor loss is the anterior cerebral artery. And unilateral facial and arm sensory or motor loss is the middle cerebral artery again. All right, that's it for now. I'll see you next time.
Hello everyone, it's time for another warm-up. Let's get going. What regulates the progression of the cell cycle from the G1 phase to the S phase? Well, there are two tumor suppressors that regulate this. It's the P53 and the RB. Next, which arachidonic acid product has actions that oppose that of prostacyclin? So that's going to be thromboxanes. Remember that prostacyclin decreases platelet aggregation and vascular tone, and thromboxane is prothrombotic. It increases platelet aggregation and vascular tone. Next, in what disorder is there an abnormal breakdown of elastin? So that's going to be alpha-1 antitrypsin deficiency, where you have excessive breakdown of elastin in the lung, and that leads to emphysema. Remember, if you have a question about emphysema in maybe a very young patient or in a non-smoker, think about alpha-1 antitrypsin deficiency. All right, that's it for the warm-up. Let's get to the lecture now.
In this video, we're going to talk about different types of vascular events that can take place in the brain. Specifically, we're talking about intracranial aneurysms, which can rupture and cause a subarachnoid hemorrhage, epidural hematomas, subdural hematomas, parenchymal brain hemorrhages, which we sometimes call hemorrhagic strokes, and then occlusion of vessels by thrombosis and emboli, which we call ischemic strokes. So let's start with intracranial aneurysms. An aneurysm is a focal dilation of a blood vessel, usually due to a focal area of weakness in the arterial wall. Aneurysms can form in the thoracic aorta or the abdominal aorta, but here we're talking about aneurysms in the arteries of the brain, in the circle of Willis. And we call these berry aneurysms because they look like a little berry growing on a vine. Or sometimes we call them saccular aneurysms because they look like they're a little sac. Now, you can find them anywhere in the brain, but usually they're going to arise at a point where two vessels branch or bifurcate. The most common location is the anterior communicating artery. Now over here on the right, you see an angiogram of this huge aneurysm in the anterior communicating artery. Then over on the left, you see a CT of the brain, and this big white density in the middle is the aneurysm that's full of contrast. Now most aneurysms typically aren't problematic unless they get really big and start compressing things, or you might have some stasis of blood inside the aneurysm, which could clot and then embolize. But the most common and the most dangerous complication is that these aneurysms can spontaneously rupture, which is a dramatic, acute event for a couple of reasons. First of all, you're interrupting the blood flow. That means everything distal to the aneurysmal bleed is going to be getting less blood. And then second, the blood itself is very irritating to the brain, and it's going to go into the CSF and irritate lots of different things and cause a really bad headache. And so one of the hallmarks of a ruptured berry aneurysm is that the patient says, "I have the worst headache of my life." So, what kinds of things increase your risk of developing intracranial aneurysms? Well, they typically begin at birth as a small defect in the artery, a little weak spot in the muscularis. And then over time, that little arterial defect just gets worse and worse and worse. And high blood pressure will cause that aneurysm to sort of balloon out even more. So the risk factors for aneurysms are things that create defects in the arteries and things that cause high blood pressure. Autosomal dominant polycystic kidney disease is a classic risk factor. These patients form cysts in their kidneys, and they also can form these saccular aneurysms in the brain. We've mentioned that Ehlers-Danlos syndrome can increase the risk of berry aneurysms because collagen defects that weaken the walls of the arteries. Now, you may also see Marfan syndrome sometimes listed as a risk factor in certain sources, but that's probably not true. Then other risk factors include hypertension, smoking, advanced age. Again, the longer you go on with this defect, the more likely this aneurysm is to balloon out. And then race is another risk factor. These are more common in black patients. If a berry aneurysm ruptures, that causes a subarachnoid hemorrhage. Now for step one, you need to be able to differentiate the common causes and presentations of epidural hemorrhages versus subdural hemorrhages versus subarachnoid hemorrhages. The most common cause of a subarachnoid hemorrhage is a ruptured aneurysm. And the second most common cause of subarachnoid hemorrhage is a ruptured arteriovenous malformation, or AVM. And then other causes include trauma, bleeding disorders, sickle cell disease, and so on. But 80 to 85% of subarachnoid hemorrhages are due to ruptured aneurysms. So what is a subarachnoid hemorrhage? Well, it's where you have blood in the subarachnoid space where the CSF is located. And that blood is irritating and it causes headache. So again, these patients come in complaining of the worst headache of my life. Any patient who comes in complaining of the worst headache of their life needs to be worked up for a subarachnoid hemorrhage. You're going to start with a CT scan of the brain to see if there's any blood. But if you don't see any blood, you're not finished with your workup. The next thing you would do is a lumbar puncture to examine the CSF for any evidence of blood. Now, you can't put a needle into the subarachnoid space without going through the skin and going through a bunch of other tissues. And in that process, you're going to have a little bit of bleeding. So typically, when you do a lumbar puncture, you're going to collect the CSF sample in 3 or 4 different tubes so you can send them to the lab. And you're going to expect that the first tube of CSF is going to be the bloodiest. Then the second tube of CSF should have less blood, and the third or fourth tube should have essentially no blood at all. So if you see blood in the last tube of CSF, you're going to think about a subarachnoid hemorrhage. You expect some blood in that first tube, but not in the third or fourth tubes. But sometimes patients don't come in right away. They might try to treat this awful headache on their own for a few days before they come to see you. And in that case, you might not see any blood cells in the CSF. But what you could see is that the CSF is yellow. We call that xanthochromia. The CSF is basically yellow because of bilirubin. The hemoglobin in the CSF has been broken down into bilirubin. Now, the main treatment for a ruptured aneurysm is to go into the brain, find the aneurysm, and place a surgical clip so that it can't rebleed. But we also give a drug called nimodipine, because about 40% of patients with a subarachnoid hemorrhage due to this ruptured aneurysm are going to have some vasospasm in the cerebral vessels 3 or 4 days after the bleed. Now, what kind of drug would you guess nimodipine is? It's a dihydropyridine calcium channel blocker, kind of like nifedipine. Drugs that end in dipine are all dihydropyridine calcium channel blockers, and they work by dilating vessels, especially arteries. Now, it's been shown that nimodipine doesn't actually prevent this vasospasm, but it's also been shown to improve outcomes following subarachnoid hemorrhage. We don't really understand how it works, but we know that it does work. Next, let's talk about another type of intracranial bleed called an epidural hematoma. An epidural hematoma is where you've had bleeding outside the dura, between the dura and the skull. Epidural hematomas are most commonly due to a rupture of the middle meningeal artery, which runs under the temporal bone. So make sure you know that. If you have trauma to the side of your head that fractures the temporal bone, that can lacerate the middle meningeal artery. And because this is an arterial bleed, a high pressure bleed, as that epidural hematoma expands, it's going to start compressing the brain, and it can cause some herniation of the brain downward across the tentorium. And this can lead to a cranial nerve 3 palsy. So if a patient has a head injury, and then the pupil is fixed and dilated, the eye is looking down and out, that's not a good sign. And another classic clinical feature is that with an epidural hematoma, you have what's called a lucid interval, where the patient has a head injury and he may lose consciousness briefly, but then he gets up and he seems fine. He's lucid, he's oriented, he's conversant. This is called the lucid interval. And then over the next several hours, as that hematoma is expanding and compressing the brain, the patient's going to gradually become obtunded. He'll have herniation of the brain in that dilated pupil. He'll have headache and vomiting and seizures. And these patients often die unless this is recognized quickly and surgery is performed to relieve the pressure and drain the hematoma and stop the bleeding. Now, we're going to look at some pictures of an epidural hematoma in just a second. But first, I want to talk about a subdural hematoma so we kind of compare and contrast. An epidural hematoma is above the dura, right? That's what epi means, above or upon. But a subdural hematoma is below the dura, like a submarine is below the surface of the water. Now, that's an important consideration when it comes to the shapes of these things on CT. So an epidural hemorrhage is between the skull and the dura, and a subdural hemorrhage is between the dura and the brain, or technically between the dura and the arachnoid. A subdural hematoma is not an arterial bleed. It's not a rapidly occurring high-pressure bleed. A subdural hematoma is usually due to a rupture of the bridging vein. It's a venous bleed, a slow bleed. Now, this tends to occur in elderly patients who have poor balance and fall and bump their heads, or in alcoholics who stumble around and bump their heads on something. And trauma can do it too. Even relatively minor trauma like a whiplash injury, which is why we sometimes see subdurals in shaken baby syndrome. Now, because a subdural bleed is below the dura, there's not really anything limiting it from spreading out laterally. Again, it's a low pressure venous bleed. And
This blood is just going to gradually ooze out and spread out between the dura and the arachnoid, which gives the subdural hematoma this classic crescent shape. It can accumulate and push the brain over and cause a midline shift, but I wouldn't hang my hat on that. I would just remember that the subdural hematoma can spread until the dura reflects back at the midline and forms the falx cerebri. But look at the epidural hematoma. Now this is outside the dura, which is tough and leathery, and the dura is attached to the skull at the suture lines. So an epidural hematoma has to kind of peel the dura off the inside surface of the skull as it expands. So it forms this expanding lens shape, kind of like a biconvex lens or an ellipse. But that blood is going to be trapped by the points where the dura attaches to the skull at the sutures. And if you still can't remember that, one student came up with a mnemonic that says the hematoma that's shaped like a person's eye is an epidural. And then the hematoma that's crescent shaped is a subdural. Or you could say the subdural snakes along outside near the skull. So whatever it takes for you to remember that, be sure you can identify each of these correctly on either a CT image or just by a verbal description. Another type of hemorrhage is an intraparenchymal hemorrhage, which is hemorrhage not in the space adjacent to the brain, but rather a hemorrhage within the brain parenchyma itself. We also call these hemorrhagic strokes. Now these are usually due to severe hypertension. For instance, if you use cocaine, the blood pressure might get so high that you have a brain hemorrhage. Other risk factors include vascular malformations, which can rupture and bleed, vasculitis, where inflammation of the vessels makes them more prone to rupture, amyloid angiopathy, where the amyloid protein is deposited in the vessel wall, and that kind of weakens the wall so it can rupture, brain tumors that erode into an artery, and also don't forget iatrogenic causes like anticoagulation. Anticoagulation could lead to any of these hemorrhages, really, especially in elderly patients who are on warfarin who then bump their head and they can get little subdural hematomas. Then one last type of brain hemorrhage to discuss is an intraventricular hemorrhage in the newborn. Now this is in your study guide. Intraventricular hemorrhage is hemorrhage into the ventricular system. It's most commonly seen in preemies with very low birth weight, less than 32 weeks, less than 1,500 grams, within the first 72 hours of life. This hemorrhage originates from the germinal matrix of the subependymal subventricular zone that gives rise to neurons and glia during development. So this is a very sensitive area of development. It's growing lots of new things. This is an area that's more likely to hemorrhage in newborns. All infants born at younger than 30 to 32 weeks gestational age should be screened with an ultrasound to make sure they don't have an intraventricular hemorrhage. So intraventricular hemorrhage is definitely something to be aware of. So that's it for intracranial hemorrhages and hemorrhagic strokes. Very high yield. So before we jump into ischemic strokes, let's pause for just a second and review a couple of these. So I'm going to show you a couple of CT scans and you tell me what kind of hemorrhage we're looking at. This is a lens-shaped hematoma or an eye-shaped hematoma, and we said that's an epidural hematoma. And here's the next one. This is a crescent-shaped hematoma that's snaking along the edge of the skull, so that's a subdural hematoma. And what's going on over here? That looks like some bleeding in the brain parenchyma. And there's a lot of tissue swelling that's collapsing the ventricle and shifting the midline. So a couple of things are going on in this one. Next, we're going to discuss ischemic or thrombotic strokes. So this term stroke basically means brain ischemia, and there are two broad categories of stroke. One category is a hemorrhagic stroke, where you have intracerebral bleeding, and the brain tissue distal to that bleed isn't being perfused. Now the brain is very sensitive to ischemia. If you stop perfusing the brain, then after just 5 minutes you're going to start to have some irreversible damage. It might take 20 minutes to damage the heart, but the brain's very sensitive. It's very needy. It needs a lot of oxygen. If it doesn't get it very quickly, it's going to start dying. Now the other big category of stroke is a thrombotic stroke, where you have a blood clot that occludes the vessel. That's also sometimes called a thromboembolic stroke, because you have a piece of a thrombus that breaks off and embolizes downstream in a smaller vessel. Or you'll commonly hear this called an ischemic stroke, which is a bit misleading because hemorrhagic strokes cause downstream ischemia too. But when you hear the phrase ischemic stroke, think thrombosis. So whenever a patient comes in with stroke symptoms, the first thing you get is a CT scan to look for evidence of a hemorrhagic stroke or an ischemic stroke. Now, fortunately, acute bleeding shows up very nicely on CT scan as a bright, white, hyperdense area. And this area marked with an asterisk is a huge parenchymal hemorrhage. And then the arrows are pointing out that blood has leaked into the ventricles.
But you have to distinguish between a hemorrhagic stroke and ischemic stroke right away, because if it's an ischemic, thrombotic, thromboembolic stroke, you're going to treat it one way, maybe give a thrombolytic to break up the clot. But if it's a hemorrhagic stroke, you definitely don't want to give any thrombolytics or anticoagulants. So it's imperative that you know what type of stroke you're dealing with before you can treat it. Ischemic strokes are commonly caused by thrombus forming on an atherosclerotic plaque in the carotid, and then that embolizes to the brain. Or from atrial fibrillation, where the thrombus forms in the left atrium and then embolizes. Less common causes of ischemic stroke would include septic emboli from infective endocarditis, or if you had a DVT, those would typically embolize to the lungs and cause a pulmonary embolus, unless the patient also happened to have a patent foraminal valley, which allows that embolus to bypass the pulmonary circulation and go straight from the right atrium to the left atrium and then out to the systemic circulation into the brain. Or a fat embolus from a long bone fracture or a pelvic fracture. An ischemic stroke is defined by the presence of infarction of the neural tissue. You have to have infarction. Now, if there's a transient episode of neurologic deficit due to ischemia without infarction, we call that a transient ischemic attack, or a TIA. But if there's infarction of the neural tissue, that's an acute ischemic stroke. And we used to define TIA and stroke based on the duration of the patient's symptoms. That's no longer the case. If there's tissue infarction, which we can usually see on an MRI eventually, that's going to be called an acute ischemic stroke. But when a patient shows up in the ER with acute symptoms, you can't always wait around for an MRI. You need to act quickly. So we're going to treat an acute TIA and an acute stroke in much the same way. So you might give a thrombolytic drug like TPA or streptokinase or urokinase if the patient meets all the criteria to receive thrombolytics. There are a whole bunch of very specific exclusion criteria, which you don't really have to memorize for step one, but basically, relatively few patients who come in with an acute stroke are actually going to be candidates for TPA. You have to pull the drug out, and then you go through this checklist of like 20 different things. Do they have this? Do they have that? Are they experiencing this? And if any one of those things is present, like maybe they had surgery yesterday, then you can't give one of these drugs because the risk of complications outweighs the benefit of the drug. Thrombolytics are contraindicated in patients with active bleeding, patients with any history of intracranial bleeding, patients with recent surgery, a known bleeding diathesis like hemophilia, or severe hypertension. And again, don't worry about memorizing this list right now. But the short version is that relatively few patients who come in with an acute ischemic stroke are actually going to be candidates for TPA. But you should know that there's a definite time window for giving thrombolytics because time is brain. The longer the brain's been ischemic, the more damage is being done. So there's definitely a limited window of time in which thrombolytics can be given for an acute ischemic stroke. However, the exact duration of that time window is somewhat in flux at the moment. For years and years, the window was considered 3 hours. The patient had to come to the ER within 3 hours of the onset of symptoms. Beyond 3 hours was considered too late. But the latest data are now saying that you can go as long as 4.5 hours, and some people are even looking at 6 hours. But the bottom line is that sooner is always better for thrombolytics. Now, on your exam, I really doubt that they're going to give you a clinical scenario where the patient's in a gray area. They might give you a patient who presents with 12 hours of stroke symptoms, and you know right away that he's not a candidate for thrombolytics. But I doubt they're going to give you a patient whose symptoms started 4 or 5 hours ago and make you choose whether or not it's appropriate to give TPA. But one classic scenario that you might see is a patient who wakes up with stroke symptoms. Say he went to bed feeling fine at 10 p.m. and he wakes up at 7 a.m. with hemiparesis and facial droop or whatever. In this case, you have to assume that he had the stroke as soon as he went to bed. So it's been 9 hours and he's not a candidate for thrombolytics. Be aware of that.
And finally, what parts of the brain are most vulnerable to ischemic damage? It's the cerebellum, the neocortex, the hippocampus, and the watershed areas.
What's a watershed area? A watershed area is an area of the body that receives blood supply from the distal branches of 2 different arteries. Now in the brain, the watershed areas are between the anterior cerebral and middle cerebral arteries, and between the middle cerebral and posterior cerebral arteries. So if you occlude one of these arteries with an embolus, the watershed areas are somewhat protected from ischemia because they have 2 blood supplies. But when the blood pressure drops and there's hypotension, these watershed areas are going to be the first to be affected because they're supplied by the most terminal branches of these arteries. All right, go ahead and work through the end of session quiz, then we'll go through the answers. First question, what's the most common site of a baryaneurysm and what diseases are often associated with baryaneurysms? So the most common location of a baryaneurysm is the anterior communicating artery. And the diseases associated with them are autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome. Next, an 85-year-old man with Alzheimer's disease falls at home and presents 3 days later with severe headache and vomiting. What's the most likely diagnosis and which structures were damaged? So this is a subdural hematoma due to a rupture of a bridging vein. Now, if this was an epidural hematoma, you'd expect him to be dead or severely incapacitated. And remember, subdurals are more common in the elderly, and epidurals are more common in teens and young adults. Next, a healthy 52-year-old man presents to the ER with stroke symptoms that began 2 hours ago. What treatment should be considered immediately and what study must be ordered immediately? Again, in any patient with stroke symptoms, you want to determine whether he's a candidate for a thrombolytic therapy like TPA. And one of the first parts of the workup is to determine whether this is a thrombotic stroke or a hemorrhagic stroke. So you need to order a CT of the head without contrast. That's one of the first things we order in a suspected stroke. Let's also run over these rapid fire facts. The worst headache of my life should make you think about a subarachnoid hemorrhage. A lucid interval following head trauma should make you think about an epidural hematoma. Bloody CSF on lumbar puncture is seen in a subarachnoid hemorrhage. The most common cause of subdural hematoma is rupture of the bridging veins. And the most common cause of epidural hematoma is rupture of the middle meningeal artery. All right, that's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. Which organelle in cytochrome are particularly important in intrinsic apoptosis? So the organelle is going to be the mitochondria, and that's going to be releasing cytochrome C. Next question, what is the embryologic origin of the tissue just proximal to the pectinate line? And then what is the origin of the tissue just distal to the pectinate line? So first we have the proximal to the pectinate line, that's going to come from endoderm. And then the tissue distal to the pectinate line is going to be derived from surface ectoderm. Next, excessive amounts of which vitamin should be avoided during pregnancy? And the answer is going to be vitamin A, because excess vitamin A can cause miscarriage and severe birth defects like cardiac abnormalities and cleft palate. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In a previous video, we talked about the functional organization of the cerebral cortex. Now we're going to peel back the cortex and discuss some of the deeper cerebral structures, including the limbic system and the hypothalamus. So let's start with the hypothalamus, which is important for regulating a lot of your body's automatic processes like body temperature, hunger and thirst, sleep and circadian rhythms, and the endocrine system, which it does by regulating the pituitary gland. Now, you won't be tested on the physical location of specific hypothalamic nuclei, but it may be worthwhile to know some of the specific functions of specific nuclei. Now, this is about a 3-star topic. Many of you will have a question on the hypothalamus. So take a look at the study guide and let's fill in some of the blanks. The first 5 nuclei are all in the anterior hypothalamus, and they have names like the supraoptic nucleus and the preoptic nucleus because they're up front near the eyes. The anterior nucleus is where thermoregulation takes place. The anterior nucleus helps us dissipate heat and cool off by sweating and so on. Now, lots of students remember AC, like air conditioning, for anterior cooling. And then if there's damage to the anterior nucleus, that leads to hyperthermia. Next is the suprachiasmatic nucleus, which is exceptionally charming and really inspires devotion in others. No, wait a minute. That's the suprachiasmatic nucleus. This is the suprachiasmatic nucleus because it sits right above the optic chiasm. The suprachiasmatic nucleus is considered the master clock for our bodies because it sets our circadian rhythms. This area receives input from the retinas to determine if it's day or night. So when you become tired at night, it's due to the action of the suprachiasmatic nucleus. And actually, lots of hypothalamic nuclei play a role in wakefulness and arousal. But when you think about circadian rhythms, I want you to primarily think of the suprachiasmatic nucleus. The preoptic area is a tiny cluster of nuclei, and I want you to remember that they secrete GnRH, or gonadotropin-releasing hormone. That's the hormone that stimulates the release of gonadotropins, LH and FSH, from the anterior pituitary. The hypothalamus secretes a bunch of releasing hormones that regulate the anterior pituitary. The supraoptic nucleus regulates water balance by secreting ADH, or antidiuretic hormone. And then ADH is transported down the pituitary stalk and stored in the posterior pituitary. There are only 2 hormones that come from the posterior pituitary, and ADH is one of them. The other is oxytocin. Now, what happens if you damage the supraoptic nucleus and you can't make ADH? This causes a disease called central diabetes insipidus, or central DI. We're going to talk about that in the renal section because central diabetes insipidus results in the inability to concentrate the urine. And then the paraventricular nucleus makes oxytocin. And again, oxytocin gets stored in the posterior pituitary. So both hormones of the posterior pituitary come from the anterior hypothalamus. The paraventricular nucleus also secretes corticotropin-releasing hormone and thyrotropin-releasing hormone. So it's regulating the anterior pituitary's production of ACTH and TSH. The middle of the hypothalamus is sometimes called the tuberal hypothalamus because it's adjacent to the tuber cinereum, which is the little hollow funnel that leads down into the pituitary stalk. But anyway, the next four nuclei are all located in the tuberal hypothalamus. The arcuate nucleus has a bunch of functions. It secretes growth hormone releasing hormone, which again is a releasing hormone that regulates the anterior pituitary. It secretes dopamine, which regulates the anterior pituitary by inhibiting the release of certain pituitary hormones like prolactin. The arcuate nucleus is also involved in making sure that gonadotropin releasing hormone is released in a pulsatile manner, which is important for normal ovulation. So both the preoptic nucleus and the arcuate nucleus are involved in GnRH secretion. And then the arcuate nucleus also helps to regulate the appetite, which is sort of a common theme of all of these tuberal nuclei. The lateral nucleus regulates and stimulates hunger. So stimulation of the lateral nucleus makes you hungry. And there's an important hormone called leptin that produces satiety. So the lateral nucleus is inhibited by leptin. And if you damage the lateral nucleus, you won't get hungry, which leads to anorexia, or loss of appetite, and weight loss. Then the ventromedial nucleus is the opposite. This one regulates satiety, so it can be stimulated by leptin. And damage to the ventromedial nucleus will result in increased appetite and obesity, and also savage behavior for some reason. And finally, the dorsomedial nucleus also regulates hunger, and stimulation of this one causes obesity and savage behavior. And finally, there are just two nuclei in the posterior hypothalamus. The posterior nucleus is involved in thermoregulation again, but opposite of the anterior nucleus. This one helps you warm your body when you're cold through shivering and piloerection and so forth. And damage to the posterior nucleus will result in an inability to remain warm in cool environments and eventually hypothermia. So the posterior nucleus is the opposite of the anterior nucleus. Makes sense. And finally, the mammillary nuclei are found in the mammillary bodies, which is part of the limbic system. The mammillary bodies are involved with memory, and damage to the mammillary bodies causes something called Wernicke-Korsakoff syndrome, which we'll talk about when we discuss the limbic system. Let's go back to circadian rhythms for a moment. What part of the hypothalamus was involved in setting circadian rhythms? The suprachiasmatic nucleus. Well, let's talk briefly about the hormone melatonin, which is also involved in circadian rhythms and arousal and wakefulness. Melatonin is secreted by the pineal gland, and it helps to regulate behaviors based on the seasons and the amount of natural light that's available. Melatonin tends to be produced in darkness. So in the winter, when the days are shorter and there's less natural light, the pineal gland produces more melatonin. And among other things, melatonin suppresses the production of LH and FSH, and it suppresses libido. So sex drive may be relatively inhibited in the winter months. But then in the spring, when the days are getting longer and there's more sunlight, the sunlight suppresses melatonin production and the sex drive is stronger, which explains why animals tend to mate in the springtime. Melatonin secretion also follows the circadian rhythm that's established by the suprachiasmatic nucleus, so that melatonin secretion peaks around midnight and then it tails off during the day. And this provides information to the rest of your body about the length of the nighttime. So the pineal gland and melatonin play a role in the sleep-wake cycle, but not as important a role as the suprachiasmatic nucleus does. Now, since the hypothalamic nuclei are the highest yield part of this video, let's do a little review. Welcome to our Doctors in Training game show, Name That Nucleus. In today's game, I'm going to put some clues up on our big game board, and I want you to shout out the correct hypothalamic nucleus. Ready to play? Let's go. Our first clue, located in the anterior hypothalamus, damage to this nucleus causes dilute urine and secretes antidiuretic hormone. That's the supraoptic nucleus. Next, stimulation of this nucleus increases the appetite, damage to this nucleus causes anorexia and weight loss, and leptin inhibits this nucleus. That's the lateral nucleus. Next, regulates the secretion of TSH, regulates the secretion of ACTH, and secretes oxytocin. That's the paraventricular nucleus. Next, receives input from the retina, controls circadian rhythms, and is known as the master clock. That's the suprachiasmatic nucleus. And our last one, damage to this nucleus leads to savage behavior. Damage also leads to obesity. And this nucleus is stimulated by leptin. This is the ventromedial nucleus. That's all the time we have for today's game, but tune in next time for Name That Nucleus. Another deep part of the brain is the limbic system. The limbic system is the part of the brain that controls emotional behavior and motivational drives. Sometimes we say the limbic system is responsible for the 5 F's: fighting, fleeing, feeding, feeling or emotions, and sex, fornication. So you can think of the limbic system as the primitive part of the brain, kind of like a caveman brain that says, hungry, need food, or need sleep, need sex. It's the animal part of the brain, or what Freud called the id. The limbic system is also involved in learning and memory. So we hope that your limbic system is engaged right now and that you're going to be able to remember all this stuff that you're packing into your brain come test day. The limbic system is closely tied to the pleasure centers of the brain, which makes sense if it's going to be ruling the emotions. It's also closely tied to the prefrontal cortex, which is involved in executive functions and problem solving, as well as personality. So when your prefrontal cortex is busy solving a difficult puzzle or solving a problem, it's also communicating with the limbic system and the pleasure centers, which is why we get pleasure and a sense of accomplishment from solving problems. And the prefrontal cortex is also responsible for inhibiting the limbic system, so we aren't constantly acting on those animal instincts. The limbic system consists of the cingulate gyrus, the fornix, the hippocampus, which is important for memory, the septal nucleus, the mammillary bodies, and the amygdala. The amygdala is a group of nuclei that receives inputs from lots of different parts of the cortex, and it's involved in summation of signals from all over: the limbic cortex, the parietal cortex, the temporal cortex, the occipital lobes, and especially from the auditory and visual association areas. So the amygdala is a site of summation of a lot of different signals and inputs. And then the amygdala transmits signals back to the cortical areas from which it received those inputs. Now, what happens when you stimulate the amygdala? Well, it can increase or decrease arterial blood pressure and heart rate. It affects GI motility and secretion, defecation, urination, that sort of thing. It influences the secretion of various anterior pituitary hormones. Stimulating the amygdala also results in movements related to eating, such as licking and chewing and swallowing. And it can trigger negative emotions, things like fear, rage, and aggressive behavior, and also awareness of invasion of personal space. So if you're studying and someone's standing a little too close and reading your notes over your shoulder, it's your amygdala that makes you feel uncomfortable with that. And stimulation of the amygdala can also trigger complex sexual responses, such as erection, copulatory movements, and ejaculation. So the amygdala is connected to the autonomic nervous system and also connected to emotions and sexual arousal and eating. So again, it's a very primitive, primordial part of your brain. Now, the amygdala is a paired structure, meaning there's one on each side of the brain. And if you get lesions in the amygdala bilaterally, that leads to something called Kluver-Bucy syndrome, which is characterized by an interesting constellation of behaviors. First of all, the patient's not afraid of anything, so they lose the fear response. That makes them fairly disinhibited because they don't fear people or they don't fear danger. So if you take an animal and you lesion both of the amygdalae, the animal no longer is going to fear predators or fear the dominant member of the group. The animal doesn't become aggressive, they just sort of become docile. And we can see that in humans with Kluver-Bucy syndrome as well. At the same time, these patients are extremely curious about everything. They also exhibit hyperorality, or an oral fixation, where they place everything in their mouth, even eating solid objects sometimes. Now, I like to think about the girl in the musical Hairspray, Tracy's friend Penny. Penny's constantly sucking on a lollipop. She's fairly docile. She kind of just goes along with whatever the rest of the gang is doing. She doesn't really even seem to have any fear of disobeying her mother and bucking the established social order. And then one other feature of Kluver-Bucy syndrome is hypersexuality. These patients have a sex drive so strong that the patient may even attempt to have sex with animals. Now, that didn't make it into the movie. Maybe it's in the extended director's cut. Anyway, that's the amygdala. Let's talk about some other lesions of the limbic system. We said that the hippocampus is important for memory, especially making new memories. So bilateral hippocampus lesions can result in anterograde amnesia. Another part of the limbic system involved in memory is the mammillary bodies, which again houses the mammillary nuclei. We said that destruction of the mammillary bodies results in something called Wernicke-Korsakoff syndrome. Now, Wernicke-Korsakoff syndrome is most commonly seen in alcoholics who become deficient in thiamine, vitamin B1. Wernicke-Korsakoff syndrome is characterized by nystagmus and ophthalmoplegia, ataxia, and encephalopathy, confusion and disorientation. And then eventually they can develop anterograde and retrograde amnesia. So there's the memory connection. And sometimes these patients will exhibit confabulation, where they can't remember something, so they make something up to fill in the gaps of their memory. That's called confabulation. It's pretty striking when you see it. Now it's time for the end of session quiz. So go ahead and pause the video and complete that, and then we'll go through the answers. First question, which hypothalamic nuclei fit each of the following descriptions? Savage behavior and obesity result from stimulation. That's the dorsomedial nucleus. Savage behavior and obesity result from destruction. That's the ventromedial nucleus. The master clock for setting circadian rhythms is the suprachiasmatic nucleus. Releases hormones affecting the anterior pituitary. There are several of these. You have the arcuate nucleus, the preoptic nucleus, and the paraventricular nucleus. So those are the three main ones. Responsible for sweating and cutaneous vasodilation in hot temperatures. That's the anterior nucleus. Responsible for shivering and decreased cutaneous blood flow in the cold. That's the posterior nucleus. Produces ADH to regulate water balance. That's the supraoptic nucleus. Regulates the release of gonadotropic hormones. That's the preoptic nucleus and the arcuate nucleus. Destruction results in inability to stay warm. That's the posterior nucleus. Receives input from the retina. That's the suprachiasmatic nucleus, which receives that retinal input to regulate circadian rhythms. Stimulation leads to eating, and destruction leads to anorexia. That's the lateral nucleus. And then destruction results in diabetes insipidus. That's the supraoptic nucleus because it produces ADH. Next, deficiency of what nutrient causes damage to the mammillary bodies? That's thiamine deficiency, or vitamin B1, most commonly due to alcoholism. And the last question. A patient is evaluated for behavior and personality changes. She used to be argumentative and aggressive, but she's become fairly quiet and docile. She's also become socially disinhibited and has been making inappropriate sexual advances toward friends, relatives, and strangers. During the interview, you note the patient's tendency to chew on pens, chew on her fingers, chew on her necklace. The damage to what neurologic structure might account for these behaviors? So this presentation suggests Kluver-Bucy syndrome, docile behavior, disinhibition, hypersexuality, and hyperorality. And Kluver-Bucy syndrome is caused by bilateral amygdala lesions. All right, that's it for now. I'll see you next time.
Welcome to my show. I trust you're doing well out there. And you, Monster, how are you feeling? That's too bad, buddy. I promise to look in it right after the show. But for now, we have a caller. Colin, you're on the line.
Yeah, I was wondering, which hypothalamic nuclei are involved with controlling the appetite?
This is a great question, Colin, and a fantastic way to kick off our show. Colin, the lateral nucleus and the ventromedial nucleus are involved with controlling the appetite. Stimulating the lateral nucleus leads to hunger, while stimulating the ventromedial nucleus leads to satiety. And the hormone leptin is important in regulating appetite because leptin inhibits the lateral nucleus and stimulates the ventromedial nucleus. So leptin causes satiety. And one more thing. Destruction of the ventromedial nucleus leads to increased appetite, obesity, and savage behavior. We're good. But it is time for a commercial break, so please don't change the channel.
It's time for another warm-up review. Let's get going. First question here, which amino acids are found in nuclear localization signals? The mnemonic here is going to be PAL, P-A-L, for proline, arginine, and lysine. All right, next one. What molecule targets proteins in the Golgi apparatus for lysosomes? And that's going to be mannose 6-phosphate. Next, which embryonic structure is derived from the hypoblast and serves as a secondary energy source? And the answer is going to be the endodermal yolk sac. That brings us to the end of the warm-up. Let's get to that lecture now.
One of the things that's very high yield about neurology is being able to look at a patient's neurodeficits and then localize the lesion to a particular area of the brain, especially in the brain stem, where there are a whole bunch of different tracts and nuclei that come together so that one little lesion can cause a bunch of different deficits. And one of the important clues in those brainstem lesions is the cranial nerve deficits that you find. So in this video and the next one, we're going to be talking about the cranial nerves. And then we'll look at the brainstem and start figuring out what these lesions look like. Now, I'm sure you've already memorized the cranial nerve names and numbers. I'm not going to review that. But I do want to review the anatomy of where these cranial nerves are located as they come off the brainstem. You definitely need to be able to identify these on a gross image. So take a look at the brainstem drawings in your study guide, and I want you to pause the video and label as many of these as you can, and then we'll go over them together. Don't spend a lot of time, but do as much as you can in a minute or so. So first we have the dorsal view, or the posterior view. A is the pineal body. B is the superior colliculus. And what did we say a lesion to the superior colliculus will cause? Paralysis of upward gaze. C is the optic tract, which becomes cranial nerve 2 on the ventral side. But note that there are just a handful of cranial nerves that emerge from the posterior or dorsal brainstem. D is the inferior colliculus, which receives a lot of auditory information, and then it relays that information to the primary auditory cortex. E is the trochlear nerve, or cranial nerve 4. That's another one that emerges dorsally. Then F is the trigeminal nerve, or cranial nerve 5, just kind of peeking out from the other side of the pons. G is the vestibular cochlear nerve, or cranial nerve 8, which is another ventral one, and so is H, the facial nerve, cranial nerve 7. Then peeking out from the front of the medulla, we can see I, which is the glossopharyngeal nerve, cranial nerve 9. Then J is the hypoglossal nerve, cranial nerve 12. K is the vagus nerve, cranial nerve 10. And L is the spinal accessory nerve, cranial nerve 11. Then looking at the ventral view, which is probably higher yield, M is the olfactory tract, which is going to go on to become cranial nerve 1. N is the optic chiasm. And O is the pituitary stalk. Now, the pituitary has been cut on this drawing, but remember that the pituitary sits right underneath the optic chiasm, because if there's a pituitary tumor, it might compress the chiasm and cause bitemporal hemianopsia. P is the mammillary bodies. Now, what did we say a lesion there causes? Wernicke-Korsakoff syndrome. And what was the vitamin deficiency associated with that? Thiamine deficiency. Q is the oculomotor nerve, cranial nerve 3. R is the trochlear nerve, cranial nerve 4, which is coming around from the back of the pons. S is the trigeminal nerve, cranial nerve 5. T is the abducens nerve, cranial nerve 6. U is the facial nerve, cranial nerve 7. V is the vestibulocochlear nerve again, cranial nerve 8. W is the glossopharyngeal nerve, cranial nerve 9. X is the hypoglossal nerve, cranial nerve 12, which comes off between the medullary pyramids and the olives up front. Y is the vagus nerve, cranial nerve 10, which tends to be a little bit bigger than these other cranial nerves coming off the medulla. So if you get disoriented, the big one is most likely the vagus. And then Z is the accessory nerve, or the spinal accessory nerve, cranial nerve 11, which actually comes up from the spinal cord. Before we get into the functions of the cranial nerves, we also need to review the location of the cranial nerve nuclei. So cranial nerve nucleus is a collection of neuron cell bodies of the neurons that form that cranial nerve. Now, some of these nuclei are fairly condensed, while others stretch out longitudinally and extend for several centimeters. And a lesion of one of these nuclei will cause specific neurological deficits, just like if you severed the cranial nerve peripherally. So knowing the location of these nuclei will help you localize brainstem lesions and brainstem strokes that we're going to be seeing later on. So there are 4 cranial nerve nuclei in the pons, and 4 below the pons, and then 4 cranial nerves originate from above the pons. And to remember which ones are in the pons, I want you to think about a cheerleader with pom-poms, starting a cheer by saying 5, 6, 7, 8. So cranial nerve nuclei 5, 6, 7, and 8 are in the pons. Cranial nerve nuclei 9, 10, 11, and 12 are located below the pons, mainly in the medulla, except for the spinal accessory nerve nucleus, which is found in the spinal cord. And then cranial nerves 1, 2, 3, and 4 originate above the pons. So the nuclei for cranial nerve 3 and 4 are found in the midbrain, and cranial nerve 1 and 2 originate from the forebrain. Now we're going to look at each cranial nerve individually, starting with cranial nerve 1. So for each nerve, you should know the nerve's function, how you test it, what happens when there's a lesion so that the nerve isn't functioning properly, and where the cranial nerve exits the skull.
But you don't need to worry about knowing the fiber types, like whether each nerve contains general somatic efferents or general visceral afferents and that sort of thing. So cranial nerve 1, or the olfactory nerve, is what provides the sense of smell. So you can test it by having the patient smell something like cinnamon or coffee or orange peels, something that produces a recognizable odor. Now you don't want to use an irritating smell like alcohol or menthol. Those will actually stimulate the trigeminal nerve. A lesion of the olfactory nerve will cause loss of sense of smell, obviously. Cranial nerve 1 exits the skull at the cribriform plate, sending branches into the nasal cavity. So if there's a fracture of the cribriform plate, that might sever those nerve branches and result in anosmia, or loss of sense of smell. The next several cranial nerves deal with the eyes. So cranial nerve 2 is the optic nerve, which of course provides vision, or the sense of sight. It exits the skull through the optic canal, and you can test the optic nerve by testing visual acuity using a Snellen eye chart, by testing the pupillary reflexes, which we're going to discuss at the end of this video, and also by testing the visual fields, which we'll discuss right now. To understand visual field defects, we need to review how visual information is gathered by the retina and then transmitted to the brain via the optic nerves. We divide the visual field for each side into a nasal or medial side and a temporal or lateral side. And likewise, each retina is divided into a nasal side and a temporal side. Now, when we look out at the world, the lens projects a mirror image onto the retina, so that objects on the temporal side of the visual field are actually perceived on the nasal side of the retina, and objects on the nasal side of the visual field are perceived by the temporal side of the retina. So far, so good. Then, as we follow the visual signal down the optic nerve toward the brain, you eventually reach the optic chiasm. Now, chiasma is a Greek word for crossing, like an X or the letter chi. So at the optic chiasm, there's a crossing over of visual information. So that information from the temporal visual field of the right eye and the nasal visual field of the left eye is carried by the left optic tract. So objects on your right are perceived by the left side of your brain. And information from the temporal visual field of the left eye and the nasal visual field of the right eye is carried by the right optic tract to the right side of the brain. Then, once you've got that down, we're ready to think through some visual field defects. There are 5 basic visual field defects that are high yield for step 1 and level 1. Now, the first one's pretty easy. What happens if you lesion the optic nerve on one side? Well, that's going to leave you with no vision in that affected eye. The next one, what if you lesion the middle of the optic chiasm? Well, this might occur with a pituitary mass that grows big enough to compress the optic chiasm, because the pituitary sits just inferior to the optic chiasm. So if you compress or otherwise lesion the optic chiasm, you're going to disrupt those crossing fibers from the nasal retina, which carry information from the temporal visual fields. So a lesion of the optic chiasm will result in loss of temporal vision in both eyes, and we call this bitemporal hemianopsia. It's kind of like tunnel vision. Now, what if we lesion an optic tract? Remember, the optic tracts carry information not from the contralateral eye, but from the contralateral visual field. So a lesion of the right optic tract will cause loss of vision in the left visual field in both eyes. We call this homonymous hemianopsia. In this case, left homonymous hemianopsia. Now, what if you just lost vision in the center of the visual field, in both eyes? Well, this occurs with a lesion of the macula found in the retina, such as from macular degeneration. And then if you had homonymous hemianopsia with macular sparing, so you lose one side of the visual field, but the central visual field remains intact, this can occur with a posterior cerebral artery infarction. So the macula is so important to our vision that the macular tracts receive collateral circulation from the middle cerebral artery. That's why the macula is spared with a PCA infarction. So make sure you know those 5 visual field defects. Now let's move on to cranial nerve 3, which is the oculomotor nerve. As the name suggests, it provides motor innervation to most of the extraocular muscles. We'll review which muscles in just a moment. But you also need to remember that cranial nerve 3 provides motor innervation to the levator palpebrae muscle, which raises the eyelid. So a cranial nerve 3 lesion will cause some drooping of the eyelid, which we call ptosis. And cranial nerve 3 sends parasympathetic fibers to the ciliary muscles and the pupillary sphincter. So cranial nerve 3 lesions can impair accommodation and can result in a dilated pupil. Now, cranial nerve 4 is the trochlear nerve, which innervates the superior oblique muscle, another one of the extraocular muscles. And cranial nerve 6 is the abducens nerve, which innervates the lateral rectus muscle, which abducts the eye. The abducens abducts. It's not difficult. Now, all 3 of these, cranial nerve 3, 4, and 6, exit the skull together through the superior orbital fissure, which makes sense since they're all basically going to the same place.
So let's look at how the extraocular muscles work together to move the eyes, and how the cranial nerve palsies will cause the eyes to deviate in certain directions. The extraocular muscles are the lateral rectus, the medial rectus, the superior rectus, the inferior rectus, the superior oblique, and the inferior oblique. So you need to know what cranial nerve innervates each of these 6 muscles and in what direction each muscle moves the eye. Now, I'm sure you're familiar with the mnemonic LR6SO4 or LR sulfate, which reminds you that the lateral rectus muscle is innervated by cranial nerve 6, and the superior oblique is innervated by cranial nerve 4, and then all the other muscles are innervated by cranial nerve 3. Now, for the movements, let's start with the straightforward ones. The lateral rectus abducts the eye. It moves the pupil laterally. The medial rectus adducts the eye. It moves the pupil medially, plain and simple. Then the superior rectus is not quite as simple, but it's not bad. The superior rectus elevates or raises the eye when the eye is abducted. And the inferior rectus depresses or lowers the eye, again, when the eye is abducted. Now let's explain that. Here we're looking down on the eyes and the extraocular muscles. Now the eyes and the orbits are oriented at about a 45-degree angle from each other. And the superior and inferior rectus muscles are lined up roughly along that axis. So when you're looking straight ahead, which ophthalmologists call primary position, when you're looking straight ahead, the eyeball is already rotated off of that natural angle. Now when the eye is abducted so that it lines up with the plane of the superior and inferior rectus muscles, those muscles produce pure elevation or depression. That's why I said the superior rectus elevates the eye when it's abducted, and the inferior rectus depresses the eye when it's abducted. So we test those muscles not by having the patient look straight up, but by having the patient look out, then up, or out, then down. So you have the patient follow your finger laterally to test the lateral rectus, then up to test the superior rectus, and then down to test the inferior rectus. Then the last 2 extraocular muscles are the superior and inferior oblique muscles, which get even trickier because the inferior oblique starts anteriorly and wraps underneath the eye and attaches toward the back. And then the superior oblique starts posterior, but it passes through the trochlea, which acts like a pulley, and then it attaches toward the back. So all the movements are kind of backward. So you can remember that the obliques do the opposite. O for oblique and O for opposite. The superior oblique moves the eye down, and the inferior oblique moves the eye up. But notice that the 2 oblique muscles both attach to the eye in the same plane, and that plane is about 80 degrees from the plane of the superior and inferior rectus muscles, so it's almost perpendicular. This means that when the eye is adducted so that it lines up with the plane of the oblique muscles, the obliques are isolated. So the superior oblique depresses the eye when it's adducted, and the inferior oblique elevates the eye when it's adducted. So again, to test the obliques, you have the patient follow your finger medially, which is going to test the medial rectus, and then up to test the inferior oblique, and then down to test the superior oblique. So your finger's making an H to test all 6 cardinal directions of gaze. And notice that you may see these directions drawn in 2 different ways. You can draw it so it represents the direction that each muscle makes the eye move, or you can draw it to show what directions you have the patient look to test the extraocular muscles. So now let's talk about what it looks like when there's a lesion of one of these 3 cranial nerves. Let's start by drawing in the basic direction that each muscle points the eye. Again, the lateral and medial rectus are easy, lateral and medial. Superior and inferior rectus are both oriented so that they tend to adduct the eye, so the superior rectus moves the eye up and medial, and the inferior rectus moves the eye down and medial. And the obliques are opposite, so they tend to abduct the eye. So the superior oblique is down and out, and the inferior oblique is up and out. Now that we've got those directions down, it's pretty easy to figure out what an individual cranial nerve lesion is going to do. If there's a cranial nerve 6 lesion, the eye is going to deviate medially, and the patient will be able to abduct the eye. That's pretty easy. And cranial nerve 6 lesions are the most common cranial nerve palsies affecting the eye because cranial nerve 6 has so far to travel. If there's a cranial nerve 4 lesion, which is pretty rare, the eye is going to drift upward, especially when the patient's looking away from the side of the lesion, when the eye is adducted, because the superior oblique depresses the eye when adducted. And these patients tend to tilt the head away from the lesion to compensate. And then a cranial nerve 3 lesion will paralyze all these muscles. So the eye is going to deviate down and out. Just remember down and out with a cranial nerve 3 palsy. But don't forget that cranial nerve 3 also sends parasympathetic fibers to the pupillary sphincter and to the eyelid. So with a cranial nerve 3 lesion, not only do we see a down and out eye, but you also see pupil dilation and ptosis. So let's talk about the pupillary light reflex. First, remember that fight or flight sympathetic stimulation causes mydriasis, or pupillary dilation, in order to let in as much light as possible while you're fighting off a predator or running away from a predator. And the rest and digest parasympathetic stimulation causes meiosis, or pupillary constriction. But you also know that the pupils dilate and constrict in response to the amount of ambient light. That's why we test the pupillary light reflex. This tests both the optic nerve and the oculomotor nerve, because both have to be intact for the pupils to function normally. So let's look at how it works. So here we're looking down on the head from above again. So what happens when you shine your pen light in the patient's left eye to test the pupillary reflex? The afferent signal is carried from the eye toward the brain by the optic nerve to the optic chiasm, where some of the fibers cross over, and then down both of the optic tracts. Now, some of these neurons synapse in the lateral geniculate nucleus, which is part of the thalamus that relays visual information to the primary visual cortex. But that's not important right now. What is important is that some of these optic tract neurons are bypassing the lateral geniculate nucleus and projecting to the pretectal nucleus. So this is an entirely different route than regular vision. Now, the pretectal nuclei project to the Edinger-Westphal nuclei bilaterally. The Edinger-Westphal nuclei are located in the midbrain, and they contribute the parasympathetic neurons to cranial nerve 3. So when the pretectal nuclei get a signal that there's increased light entering the eye, they stimulate the Edinger-Westphal nucleus, which sends a parasympathetic signal back up the oculomotor nerves to the ciliary ganglia. From there, the signal goes to the pupillary constrictor muscles of the irises, and the pupils constrict. So with all that crossing and bilateral signaling, light shining in either eye will cause pupillary constriction in both eyes. Now, there are two main ways you can mess up this pupillary reflex. One way to be to somehow impair the afferent signal, blocking the incoming message that there's light shining in the eye. We call that an afferent pupillary defect. The other way is to impair the efferent signal, the parasympathetic signal that actually triggers the pupillary constriction, and that's called an efferent pupillary defect. So, say there's damage to the left optic nerve. Is that an efferent defect or an afferent defect? That's an afferent defect. So if there's a lesion of that left optic nerve and you shine the light in the left eye, nothing happens. Neither pupil constricts. The pretectal nuclei and the Edinger-Westphal nuclei have no clue that you're actually shining light in that eye. And then when you swing your light over to the right eye, which is the good eye, you see the right pupil constrict. And the left pupil constricts also, because the oculomotor nerve's parasympathetic signal is perfectly intact. So if you shine your light in one eye and neither pupil constricts, that's called an afferent pupillary defect. Or sometimes it's called a Marcus gun pupil. But say instead of an optic nerve lesion, you have a left oculomotor nerve lesion. So when you shine your light in the left eye, the signal goes down to the pretectal nuclei and the Edinger-Westphal nuclei, but that damaged cranial nerve 3 can't send the parasympathetic motor signals to the left eye. But the right oculomotor nerve is just fine. So here, the right pupil does constrict when you shine light in the left eye. And then when you swing your light over to the right eye, again, the right pupil constricts normally, but the left pupil still won't constrict. So that's an efferent pupillary defect. One pupil won't constrict when the light shines in either eye. So it's important to swing that light back and forth from one eye to the other and watch one eye at a time to make sure they constrict normally regardless of where the light is. That's called the swinging flashlight test. Now, the parasympathetic fibers in cranial nerve 3 are located on the peripheral outer part of the nerve, while the motor innervation to the extraocular muscles is carried in the center of the nerve. So it may help you to remember P for parasympathetic and peripheral, and M for motor and middle. But this anatomic structure means that a mass lesion that compresses the oculomotor nerve from the outside is more likely to affect what? The pupils or the extraocular muscles? The pupils. A mass lesion will compress the parasympathetic fibers going to the pupils long before it compresses the central nerve fibers to the extraocular muscles. But since the fibers to the extraocular muscles are located deep within the nerve, they're more susceptible to ischemic damage. So diabetics, who are at high risk of microvascular ischemia, are more vulnerable to pupil-sparing third nerve palsies, where the eyes deviate down and out, but the pupillary light reflex remains intact. So that's cranial nerves 1, 2, 3, 4, and 6. We skipped cranial nerve 5, but we're going to cover that one in the next video, along with cranial nerves 7 through 12. But for right now, let's take a look at the end of session quiz. First question. Which cranial nerve nuclei are located in each of the following locations? So first is the medulla. That's cranial nerves 9, 10, and 12. Cranial nerve 11 is the spinal accessory nerve, so it originates in the spinal cord. Which nuclei are located in the pons? Remember, it's cranial nerves 5, 6, 7, 8. And in the midbrain, you have cranial nerves 3 and 4. Next, where is the pathology located in each of the following scenarios? So right anopsia is a lesion in the right optic nerve. Then the next bullet had a little typo. It should say bitemporal hemianopsia, and that's a lesion of the optic chiasm. And then right homonymous hemianopsia is the left optic tract. And the last question. When light is shown in a patient's right eye, his right pupil fails to constrict, but his left pupil constricts normally. And when light is shown in the left eye, the left pupil constricts, but the right pupil does not. So where's the pathology most likely located? Well, this is a defect of the right ocular motor nerve. This is an efferent defect. We know that the light is getting in normally because when you shine the light in the right eye, the left pupil constricts. The problem here is that no matter where you shine the light, the right pupil won't constrict. So again, this is a problem with the right ocular motor nerve. That's it for now. We're going to cover the rest of the cranial nerves in the next video. I'll see you then.
Hello everyone, welcome to another warm-up. Let's get going. During which weeks of fetal development does organogenesis take place? Remember, it's weeks 3 to 8. Next, which group of genes is responsible for skeletal development? So remember, it's the HOX, H-O-X genes. Next, what is required for a molecule to enter into the nucleus through a nuclear pore? Well, nuclear localization signals are required, which are 4 to 8 amino acid sequences that are rich in things like lysine, arginine, and proline. All right, guys, that brings us to the end of the warm-up. Let's get to the lecture.
Welcome to Cranial Nerves Part 2, the much anticipated sequel to the smash hit Cranial Nerves Part 1. In this video, we're going to finish the rest of the cranial nerves, starting with cranial nerve 5. Cranial nerve 5 is the trigeminal nerve, which has 3 divisions: the ophthalmic branch, the maxillary branch, and the mandibular branch. Now, the first 2 branches are purely sensory, while the mandibular branch has both sensory and motor functions. The ophthalmic branch exits the skull at the superior orbital fissure, the maxillary branch exits the skull at the foramen rotundum, and the mandibular branch exits at the foramen ovale. Now, in terms of function, the ophthalmic branch provides sensation to the forehead and down the bridge of the nose. The maxillary branch provides sensation to basically from the eyes down to the upper lip, and then also the lateral part of the nose, as well as the nasal mucosa and the palate and the upper teeth. And then the mandibular branch provides sensation to the jaw and extending in front of the ears all the way up to the temples. It also provides touch sensation to the anterior 2/3 of the tongue, but not taste sensation. Taste sensation is provided by the facial nerve and the glossopharyngeal nerve primarily. And the mandibular branch also provides motor innervation to the muscles of mastication, which we'll get to in a moment. But while we're talking about the sensory functions of the trigeminal nerve, let's talk about how we test the trigeminal nerve. So you can test for pinprick or light touch on all 3 regions of the face. You can also test some cranial nerve reflexes. So you can test the corneal reflex by touching the cornea gently with a wisp of cotton, see if that makes the patient blink. So that's going to test the ophthalmic division of the trigeminal nerve, and it's also going to test the temporal branch of the facial nerve, or cranial nerve 7, because that's what provides the motor innervation to the eyelids. We'll talk about that in a moment. So the corneal reflex is testing 2 cranial nerves, cranial nerve 5, the ophthalmic branch, and cranial nerve 7, the temporal branch. Then there's the lacrimation or tearing reflex, which also requires function of the same 2 nerves. So cranial nerve 5 is going to sense the pain if you touch the cornea, and then cranial nerve 7 is going to produce the tears. But lacrimation reflex is really not one we usually test. And then compression of the trigeminal nerve is going to cause trigeminal neuralgia, which is a shooting electricity-like nerve pain on the face. And it's usually very difficult to treat. It's usually due to compression of the trigeminal nerve root near the pons. And we also said that the mandibular branch provides motor innervation to the muscles of mastication. The masseter, the temporalis, and the medial pterygoid are all responsible for closing the jaw. And then the lateral pterygoid is the muscle that opens the jaw. And you can test that motor innervation by asking the patient to open the jaw against resistance, or maybe just have them clench their teeth while you're feeling the temporalis muscle and the masseter muscle. So that's it for the trigeminal nerve. But before we move on to the facial nerve, let's talk about the cavernous sinus, because the first and second divisions of the trigeminal nerve run right through the cavernous sinus. Other nerves that run through the cavernous sinus include the oculomotor nerve, the trochlear nerve, and the abducens nerve. And other important structures nearby include the internal carotid, the pituitary gland, the optic chiasm, and the sphenoid sinuses. So, if there's an infection in this so-called danger triangle, that infection can spread to the cavernous sinus and lead to cavernous sinus thrombosis, blood clotting in the cavernous sinus. And this can lead to cranial nerve palsies and also pain or numbness from compression of these branches of the trigeminal nerve. So be aware of that. Cranial nerve 6 was covered in another video, so now let's move on to cranial nerve 7, which is the facial nerve. The facial nerve exits the skull through the internal acoustic meatus, along with cranial nerve 8. Because remember, when we looked at the cranial nerves coming off the brainstem, both cranial nerve 7 and 8 came off the posterior pons together, so they're going to exit the skull together. Now, there are 5 branches of the facial nerve: the temporal branch, zygomatic, buccal, marginal mandibular, and the cervical branch. And there are several different mnemonics for these, like 2 Zanzibar by Motorcar or 10 zebras bit my chin. The big function of the facial nerve is motor innervation of the muscles of facial expression, as well as motor innervation of the stylohyoid muscle, the posterior belly of the digastric muscle, and also the stapedius muscle in the middle ear. And remember, all of these structures are derived from the second branchial arch. So S for second arch, S for cranial nerve 7, S for stylohyoid, and so on. We've already alluded to some of the other functions of the facial nerve. In addition to the motor function, it provides parasympathetic innervation to the lacrimal glands to cause tearing. It also innervates the submandibular glands and the sublingual glands, which make saliva. The parasympathetics tend to make things leaky, lacrimation, salivation, and so on. And the facial nerve passes through the parotid gland, but it does not actually innervate the parotid gland. So it causes salivation, but not salivation from the parotid gland. Submandibular glands actually produce more saliva than the parotids do anyway. We also said that the facial nerve provides taste sensation to the anterior 2/3 of the tongue. Now, to test the facial nerve, we're mostly testing the motor function by having the patient wrinkle up his forehead or raise his eyebrows or furrow his eyebrows or puff out his cheeks or close his eyes tightly while you're trying to stretch the eyes open. So lots of different tests for the facial nerve. So imagine on your exam, they give you a patient with a unilateral facial weakness. The patient may present with relatively acute onset of facial droop, where the right side of the mouth seems to sag, or the right eye won't open or close all the way. When you ask the patient to smile, the smile is clearly asymmetrical. So maybe you do some of those facial nerve tests, like have him puff out his cheeks or keep his eyelids shut while you try to force them open, and clearly the right side of the face is weak. Well, since we're talking about cranial nerve lesions, you're probably thinking that's a right facial nerve palsy, and you may be right. A unilateral facial nerve palsy, or facial nerve nucleus lesion, will cause this unilateral facial droop. And the term you may hear for this is Bell's palsy. Now, technically, Bell's palsy is only supposed to be idiopathic facial nerve palsy, but lots of things can cause a facial nerve palsy. So one mnemonic for these is Lovely Bella had an STD. So the L in lovely is for Lyme disease. The Bell in Bella is for Bell's palsy, which is, again, idiopathic facial nerve palsy. The H in had is for herpes simplex and also herpes zoster. The A in An is for AIDS. And then the STD is for sarcoidosis, tumors, and diabetes. Now, of all of these, herpes simplex virus is probably the #1 cause of what gets diagnosed as idiopathic Bell's palsy, because we don't really have a great way of detecting or diagnosing HSV in these patients. So I wouldn't get too hung up on whether or not something is really true idiopathic Bell's palsy. In practice, we tend to call any unilateral facial palsy Bell's palsy, and then say it's Bell's palsy secondary to Lyme disease or herpes simplex or whatever. But when that patient comes in with unilateral facial weakness, the other big thing you have to worry about is an acute stroke. Bell's palsy is pretty benign, and it's usually going to be self-limited. We usually give steroids like prednisone for a week or so, but these patients are usually going to recover within about 3 weeks. But a stroke is another matter entirely. You need to be able to recognize an acute stroke and treat immediately. The next question in your study guide says, how do the symptoms of a facial nerve or facial nerve nucleus lesion differ from the symptoms of a facial motor cortex lesion, like a stroke? Well, a facial nerve lesion, like in Bell's palsy, will cause paralysis of the ipsilateral side of the entire face. So if you knock out the right facial nerve, all the facial muscles on the right side of the face will be paralyzed, and the patient will have facial droop on the right. But a facial motor cortex lesion, like a stroke, will result in paralysis of the contralateral side of the face and only the lower face. The contralateral part probably makes sense because you know that the right side of the face is controlled by the left motor cortex. But why does a stroke not affect the upper face? Well, look at the next question. The facial motor nucleus receives motor fibers for the lower face from the contralateral motor cortex, but it receives motor fibers for the upper face from both motor cortices. In a left motor cortex stroke, only the right lower face will be paralyzed because the right upper face still receives innervation from the right motor cortex. But since the left motor cortex is the only cortex that innervates the right lower face will be paralyzed. So, if a patient comes to the ER complaining of facial droop on the right side, you need to quickly determine if this is a stroke or just acute Bell's palsy. And the forehead is going to be a big help to help you determine this. If the forehead is paralyzed along with the lower face, then you're probably dealing with Bell's palsy. But a stroke will only affect the lower face. So you're going to be sure to examine whether or not the patient can move his eyebrows. If the patient comes in with facial paralysis, but he can still move his eyebrows, then you need to get moving because this is probably a stroke. The next cranial nerve is cranial nerve 8, the vestibular cochlear nerve. Now we already said that this exits the skull through the internal acoustic meatus along with the facial nerve. It's responsible for both equilibrium and hearing. And you can test it by testing hearing and also by looking for nystagmus and balance problems. And then the next nerve is the glossopharyngeal nerve, which is cranial nerve 9. The glossopharyngeal nerve exits the skull through the jugular foramen, along with cranial nerve 10 and cranial nerve 11. Cranial nerve 9 is one that has a ton of different functions. It provides motor innervation to the stylopharyngeus muscle. It provides parasympathetic innervation to the parotid gland to make saliva. It sends branches to the carotid sinus to measure the blood pressure and also branches to the carotid bodies to measure blood chemistry. It also provides sensory innervation to the pharynx and to the back of the tongue and taste sensation to the posterior third of the tongue. It's the glossopharyngeal nerve, so the sensation of the tongue, sensation of the pharynx, it's going to be pretty easy to remember. And then one way you can test the glossopharyngeal nerve is by checking the gag reflex, which also happens to test vagus nerve function. Next is cranial nerve 10, the vagus nerve, which again, it's going to exit the skull through the jugular foramen. The functions of the vagus nerve include motor innervation of several pharyngeal muscles involved in swallowing and elevating the palate, and also innervation of the larynx. So swallowing and speaking require a functional vagus nerve. The vagus is also one of the body's main parasympathetic nerves, so it carries parasympathetic signals to the heart and to the GI tract. It also provides sensory innervation to the pharynx and the trachea and the esophagus, so irritation of the vagus can trigger coughing. And it provides a taste sensation to the very back of the tongue. Now, testing the vagus nerves usually involves having the patient elevate the palate by saying ah. But you can also check the gag reflex, and you can listen to the voice quality. That's going to tell you if the laryngeal muscles are working properly. Now let's look at the question in your study guide that says, if the right vagus nerve or nucleus is damaged, to which side will the uvula deviate? Well, the main muscle that elevates the palate is the levator veli palatini, and it's innervated by the vagus. So if the right vagus is damaged, the left side of the palate will elevate normally, but the right side will kind of sag, and that means that the uvula deviates to the left. So with a vagus lesion, the uvula will deviate to the side opposite the vagus lesion. And the next question says, a patient's uvula deviates to the right when she says ah. What neurological structures might be damaged? I recommend working backward on this type of question. Rightward deviation of the uvula means that the muscles in the right palate are raising the palate, but the muscles of the left palate are not. So what innervates the left soft palate? Well, it's the left vagus nerve. And most of the motor neurons of the vagus nerve originate in the nucleus ambiguus, in the medulla. So a left nucleus ambiguus lesion could also do this. Now when you hear nucleus ambiguous, I want you to think of two very specific functions, swallowing and speech. So the functions of the nucleus ambiguus aren't very ambiguous. They're very specific, swallowing and speech. I always thought it was kind of funny that the vagus nerve contains neurons from the nucleus ambiguus. Can't really make that stuff up. Now, what about a cortical lesion? Well, the nucleus ambiguus receives input from the motor cortices on both sides via the corticobulbar tracts. So a lesion above the nucleus ambiguus won't necessarily cause the uvula to deviate. There are just a couple more cranial nerves which are found in a separate table. Cranial nerve 11 is the accessory nerve, or the spinal accessory nerve. It provides motor innervation to the sternocleidomastoid muscle and the trapezius, so you can test cranial nerve 11 by having the patient turn his head against resistance and shrug the shoulders against resistance. And that brings us finally to cranial nerve 12, which is the hypoglossal nerve. It exits the skull through the hypoglossal canal, which is pretty easy to remember. And of course, since glossal means tongue, it's also easy to remember that the hypoglossal nerve provides motor innervation to the intrinsic muscles of the tongue. And to test the tongue, you ask the patient to stick out his tongue and make sure it sticks out straight. The next question of the study guide says, if the right hypoglossal nerve or nucleus is damaged, to which side will the tongue deviate when sticking out? Well, remember we said with a vagus nerve lesion, the uvula will deviate away from the lesion. But the hypoglossal nerve is a little bit different. With a right hypoglossal nerve injury, the muscles on the working side, in this case the left side, will push the tongue forward. But the muscles on the injured side are weak. So the tongue deviates toward the side of the lesion, in this case toward the right side. So you can remember that for the hypoglossal nerve, the tongue licks the lesions. Remember those L's. Hypoglossal nerve lick the lesion. And again, with a cortical lesion, you usually won't see tongue deviation because the cortex projects to both hypoglossal nuclei. And now it's time for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers together. First question, what two nerves are tested with the gag reflex? Remember that's cranial nerve 9 and 10. Next question, a 19-year-old man presents with a furuncle on his philtrum and the cavernous sinus becomes infected. So what neurological deficits might you see in this patient? So remember, cranial nerves 3, 4, and 6 all pass through the cavernous sinus, so this can cause varying degrees of ophthalmoplegia. For example, with the cranial nerve 3 lesion, the eye is going to point down and out. With the cranial nerve 6 lesion, the eye won't be able to abduct. And then ophthalmoplegia is actually going to present very often with double vision or diplopia. And also, since cranial nerve 5 passes through the cavernous sinus, an infection could lead to pain or numbness on the upper face. And our last question, how can a stroke of the facial motor cortex be distinguished from Bell's palsy? So remember, a stroke of the facial motor cortex will result in contralateral paralysis of the lower face, but the eyebrows and the forehead will be spared with a stroke. Bell's palsy causes paralysis of both the upper and lower face. So that's it for the cranial nerves. I'll see you next time.
These two guys don't get along, but when it comes to education, they are never wrong. Yeah, if you pay attention, you might get an A. They don't like each other, but that's okay, 'cause they are bosom buddies.
Hello, and welcome to another episode of Bosom Buddies. I'm Dr. McInnes, and unfortunately, with me again is Dr. Lewis.
Hello.
So, today I wanted to talk about the tongue.
Whoa, hold on there. I don't think I want to discuss the tongue with you.
Why not?
It makes me uncomfortable.
Why would talking about tongues make you uncomfortable?
I don't think you and tongues go very well together.
What are you talking about? I have a tongue.
Please don't remind me. Now I have your tongue burned into my brain.
Go lick a battery. Let me teach something. Okay, so a classic question you'll often get is what nerves innervate the tongue for motor and taste? Motor innervation is from the hypoglossal nerve, cranial nerve 12. Taste sensation is mainly from cranial nerve 7 in the anterior 2/3 and from cranial nerve 9 in the posterior third. And then a tiny bit of taste sensation in the extreme posterior of the tongue is from cranial nerve 10. That's it. What'd you think?
I'm tongue-tied.
Hilarious.
Really?
No, that was terrible.
Can we stop talking about tongues now? I feel a little nauseated.
Yeah. Goodbye, everyone.
Bye. Hello everyone and welcome to another warm-up review. Let's get going. What molecules provide the structural framework for DNA and the nuclear envelope? These are the nuclear lamins. Next, what substances are utilized by natural killer cells to induce apoptosis in other cells? So granzymes and perforin are the substances that NK cells use to induce apoptosis. Next, what drugs interfere with microtubule functioning? So there's going to be griseofulvin, You'll have the benzimidazoles like mebendazole and thiabendazole. You have vincristine and vinblastine. You have paclitaxel, and then there's colchicine. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to review the anatomy of the brainstem and the spinal cord so that we can work up to unraveling the mystery of brainstem strokes. Now, the cranial nerves and the cranial nerve nuclei are covered in another video. And in this video, we're going to look at how these nuclei are arranged within the brainstem. But first, let's review the major spinal cord tracts, which obviously have to pass through the brainstem on their way to and from the brain. So the three main tracts that we're going to discuss are the dorsal columns, the spinothalamic tract, and the lateral corticospinal tract. Now, we're going to review the location of these tracts later on. For now, I just want to focus on what kinds of information these tracts carry and where they decussate. So let's start with the dorsal column medial lemniscus pathway. This is the pathway that carries fine touch, vibration sense, and proprioception signals from the body to the brain. The nerve fibers carrying these signals enter the cord from the extremities or the trunk, and then they enter the dorsal columns on the dorsal side of the spinal cord. Now, in the dorsal columns, the tract ascends on the ipsilateral side of the cord until it reaches the medulla, which is where it decussates or crosses. That's worth knowing. The dorsal columns decussate in the medulla, and then they're called the medial lemniscus. We'll look at the location of the medial lemniscus in the brainstem shortly. And then the medial lemniscal fibers terminate in the thalamus in the ventral posterolateral nucleus, the VPL, and then that projects to the sensory cortex. The thalamus is like a relay station between the spinal cord and the cortex. Now, you probably won't have to regurgitate a bunch of these picky details for step one. They mostly want you to be able to localize lesions. So remember, proprioception, vibration sense, and fine touch are carried by the dorsal columns, which decussate in the medulla and then become the medial lemniscus in the brainstem. Next is the spinothalamic tract, which carries pain and temperature sensation. Remember, spinal tracts are named from where they come from first and then where they're going. So the spinothalamic tract is carrying pain and temperature sensation from the spine to the thalamus. The nerve fibers enter the cord and ascend just 1 to 2 levels in something called Lissauer's tract, and then they decussate in the anterior white commissure, just anterior to the gray matter in the center of the spinal cord. So the spinothalamic tract decussates in the anterior white commissure, and then it ascends contralaterally and eventually reaches the thalamus relay station in the sensory cortex. This is different from the dorsal columns, which ascended all the way to the brainstem before they crossed in the medulla. Now, there's a similar tract for the pain and temperature sensation of the face, which is called the trigeminothalamic tract. Because remember, the trigeminal nerve provides the sensory innervation of the face. And the trigeminothalamic tract and the spinothalamic tract run together in the brainstem. But cranial nerves generally don't decussate. So, in the right side of the brainstem, the spinothalamic tract is carrying pain and temperature information from the left side of the body, and adjacent to that you find the trigeminothalamic tract carrying pain and temperature information from the right side of the face. Then our third spinal tract, for now, is the lateral corticospinal tract. So this is carrying motor information from the cortex to the spinal cord. It's corticospinal. From the motor cortex, the signal comes down through the internal capsule, through the brainstem into the medullary pyramids, and there it decussates in the caudal medulla. And then that goes down into the spinal cord. Next, let's look at some cross-sectional anatomy of the various levels of the brainstem. Now, you could be asked to identify structures on the brainstem, but again, you're more likely to have to identify the location of a brainstem lesion based on the clinical presentation. Understanding these cross-sections will make it a lot easier. You can divide the brainstem into the main zones: the midbrain at the top, the pons in the middle, and the medulla at the bottom. So let's start at the top with the midbrain, and then we'll work our way down. Now, in the study guide, there's a diagram of the rostral midbrain. Technically, each level of the brainstem can be divided into a rostral portion and a caudal portion. So rostral means beak, kind of like rooster, rostral. And then caudal means tail. So the rostral medulla is the portion closest to the beak, and the caudal medulla is the portion closest to the tail. Or you can remember that rostral rhymes with nostril, so the rostral is the portion closest to the nose. So again, this is a drawing of the rostral midbrain. It's the superior portion of the midbrain, closest to the nose, farthest from the tail. And you know it's the rostral midbrain because you can see a prominent red nucleus on each side. If you see the red nucleus, you know you're in the rostral midbrain. This white space in the center of the midbrain is the cerebral aqueduct, which is filled with CSF. And the darker area surrounding the aqueduct is the periaqueductal gray matter. Now, because this is the rostral or superior midbrain, posterior to the aqueduct, we're going to find the superior colliculi. If you flip back a few pages in your study guide to the cranial nerve drawings, you're going to see the superior colliculi up here in the midbrain. And remember, the superior colliculi houses the vertical gaze center, so a lesion here would cause paralysis of upward gaze. Now, speaking of cranial nerves, which cranial nerve nuclei do we find in the midbrain? Well, if 5, 6, 7, 8 are in the pons, then you can remember 3 and 4 are a little higher in the midbrain. And remember that the cranial nerve nuclei descend in numerical order from top to bottom. So in the superior midbrain, you find the cranial nerve 3 nuclei, which are these two black dots. And in the inferior or caudal midbrain, instead of the cranial nerve 3 nuclei, you'd find the nuclei for cranial nerve 4. Now, moving laterally, you have the medial lemniscus. I know it's weird that the medial lemniscus is found laterally in the midbrain, but down in the medulla and in the pons, it's located more medially, as we're going to see. We'll see the medial lemniscus traveling throughout the brainstem, carrying vibration and proprioception and fine touch information from the dorsal columns up to the thalamus. So keep track of where the medial lemniscus is going. Nearby is the spinothalamic tract, and then lateral to that is the medial geniculate body. Now on the anterior part of the midbrain, these two big wing-looking things are the cerebral peduncles, which house the corticobulbar tract and the corticospinal tract. We're going to see the corticospinal tract traveling through all these levels of the brainstem too, so keep track of that as well. And then this dark stripe of tissue is the substantia nigra, which is damaged in patients with Parkinson's disease. So that's the rostral midbrain. Now, we don't have a drawing of the caudal midbrain, but again, you can identify the caudal midbrain because you will not see the red nucleus, and then instead of the superior colliculus, you're going to have the inferior colliculus. And instead of the cranial nerve 3 nuclei, you have the cranial nerve 4 nuclei. Next up is the pons. And for the pons, I want you to divide it into the medial pons and the lateral pons. Let's start with the medial pons. The medial pons contains the MLF, the medial longitudinal fasciculus, which is involved in eye control, and the medial lemniscus again. I told you to keep track of that. Then you also see the abducens nerve nucleus and the corticospinal tract, which is traveling down from the cortex, and it's eventually going to end up in the medullary pyramids. And the reason that you want to lump these medial structures together is that they receive blood supply from the median and paramedian branches of the basilar artery, which penetrate the pons. So a basilar artery stroke could selectively knock out these medial structures. The lateral aspect of the pons is supplied by the AICA, the anterior inferior cerebellar artery, which is a circumferential artery that circles around the outside of the pons. So the AICA supplies blood to the structures in the lateral pons, which include the lateral spinothalamic tract, the cranial nerve 7 nucleus, the cranial nerve 8 nucleus, and the spinal trigeminal nucleus and tract, which is associated with cranial nerve 5. Cranial nerve 5 has a really huge nucleus that runs from the top of the pons all the way down into the medulla. It's enormous. It's also very complicated. But remember, the pons contains the nuclei for cranial nerves 5, 6, 7, 8, and all those are pictured here. And the most inferior part of the brainstem is the medulla. There are two structures that tell you you're looking at the medulla. The inferior olivary nucleus, which is this big squiggly area, and the medullary pyramids on the anterior aspect of the medulla. So when you see those, you should immediately recognize that you're looking at the medulla. Now, what's found in the medullary pyramids? The corticospinal tracts, descending from the motor cortex. This happens to be a drawing of the rostral medulla. And again, you need to think about a medial portion and a lateral portion. The medial medulla contains the medullary pyramids, the medial lemniscus again, and here you can see it's rotated 90 degrees, so it truly is medial, and also the hypoglossal nucleus, cranial nerve 12. And all three of those medial structures are supplied by the anterior spinal artery, which runs right along the anterior surface of the medulla in the groove between the pyramids. But the lateral portion of the rostral medulla is supplied by the pica, the posterior inferior cerebellar artery, which wraps around the medulla on its way to the cerebellum. The lateral medulla contains the lateral spinothalamic tract, carrying pain and temperature information from the body, the spinal trigeminal nucleus and tract, the inferior cerebellar peduncle, and the vestibular nuclei. And we said that cranial nerves 9, 10, and 12 originate in the medulla. We already saw the hypoglossal nucleus in the medial medulla, that's cranial nerve 12, but in the lateral medulla you have the nucleus ambiguus, which is involved in speech and swallowing. So it contributes motor neurons to the glossopharyngeal nerve, cranial nerve 9, and also the vagus nerve, cranial nerve 10. There's also the dorsal motor nucleus, which contributes to the vagus nerve, and the nucleus of the solitary tract, also called the nucleus solitarius, which also contributes to the vagus nerve. So again, you definitely want to know which brainstem structures are medial and which ones are lateral, and what level you find them. But it's probably much less important to be able to label all these images. There's also something called the reticular activating system, which is made up of a bunch of structures running through all levels of the brainstem, as well as structures in the thalamus and the hypothalamus. The reticular activating system mediates alertness and wakefulness and arousal. So a lesion of the reticular activating system will result in stupor and coma. We've mentioned that the vagus nerve is the primary parasympathetic nerve in the body and how it has a bunch of different functions: parasympathetics, motor, general sensory, special sensory, and so on. Well, because of this complexity, the vagal nerve receives contributions from several different nuclei. The nucleus ambiguus contributes motor innervation to the pharynx, the larynx, and the upper esophagus. So again, I want you to associate the nucleus ambiguus with speech and swallowing. The nucleus solitarius receives the vagus nerve's sensory information from the pharynx and the trachea and the esophagus, and also taste sensation from the very back of the tongue. It also receives the taste information from the facial nerve and the glossopharyngeal nerve, and information from the carotid body chemoreceptors via the glossopharyngeal nerve as well. And then the dorsal motor nucleus contributes parasympathetic fibers to the GI tract and the heart and the lungs. Now, don't get tripped up by the fact that it's called the dorsal motor nucleus. It actually contains parasympathetics. Now, what about the sympathetic nervous system? Where's that located? Well, the sympathetic nervous system has its cell bodies not in the brainstem, but rather down in the spinal cord at the T1 to L3 levels. And these cell bodies synapse with the sympathetic ganglia outside the spinal cord, such as the superior cervical ganglion. And that brings us to a brief discussion of Horner syndrome. Horner syndrome is a disorder of the sympathetic innervation of the face. So the three main features of Horner syndrome are ptosis, or drooping of the eyelid, miosis, or constriction of the pupil, and anhidrosis, absence of sweating, and also flushing of the affected side. So this sympathetic innervation of the face might be disrupted with a lung tumor in the apex of the lung that compresses the sympathetic trunk as it travels from the thoracic spine up to the face. So you can also see Horner syndrome in certain spinal cord disorders like advanced syringomyelia. And then also you can see it with a stroke of the lateral medulla, which we're going to go over when we finally talk about brainstem strokes. Now that we've reviewed the anatomy of the brainstem, from the midbrain to the pons to the medulla, let's keep working our way downward and review the anatomy of the spinal cord. We looked at the function of the spinal cord tracts, so now we're going to take a little closer look at how these tracts are arranged within the spinal cord. So there's a drawing in your study guide, and I want you to pause the video and label as much of this as you can, then restart the video and we'll go through them together. Letters A and B make up the dorsal columns, which we said carries proprioception, light touch, and vibration sensation. So letter A is the fasciculus cuneatus, which carries information from the upper body and the arms toward the brain. And then letter B is the fasciculus gracilis, which carries information from the lower body and the legs. It may help you to think about feet walking on the grass, to remember that the fasciculus gracilis carries information from the lower body. You can also remember that the dorsal columns are arranged like the body is, with the legs on the inside and the arms on the outside. So, does this drawing in the study guide show the upper spinal cord or the lower spinal cord? Well, it must be the upper spinal cord because you do have a fasciculus cuneatus. In the lower spinal cord, you really only see the fasciculus gracilis. And where do the dorsal columns decussate? In the medulla, remember? And what tract do they become in the brainstem? They become the medial lemniscus. Letter C is Lissauer's tract, which we said was the tract that carries pain and temperature signals from the body to the spinal cord. And it ascends one or two spinal levels and then crosses over to the spinothalamic tract. So where's the spinothalamic tract? That's letter H and letter I. Letter H is the ventral or anterior spinothalamic tract, and then letter I is the lateral spinothalamic tract. The lateral spinothalamic tract carries pain and temperature sensation, and the anterior spinothalamic tract carries crude touch or pressure sensation. So light touch is the dorsal columns, crude touch is the ventral spinothalamic tract. Now there are a couple more ascending tracts we just haven't mentioned yet. Letter J is the ventral spinocerebellar tract. Letter K is the dorsal spinocerebellar tract. Both of these carry proprioceptive signals from the spinal cord to the cerebellum.
Then the rest of these are descending tracts, which carry signals from the brain down to the rest of the body. Letter D is the lateral corticospinal tract, which carries motor commands from the motor cortex to the rest of the body. Remember, this tract decussates in the medullary pyramids on its way down. And you should also know that it's organized opposite from the dorsal columns. So the fibers carrying signals to the legs are located in the lateral part of the lateral corticospinal tract, and the signals for the arms are carried in the medial part of the tract. So you can match up the L's. The legs are lateral. There's also a ventral or anterior corticospinal tract, which is letter G. It's much smaller than the lateral corticospinal tract, and it's less important, but it's also involved in motor control. Then letter E is the vestibulospinal tract, which carries signals from the vestibular apparatus to the body. Signals about head position and head tilt to help you with reflexive postural control to keep you upright. And letter F is the reticulospinal tract, which carries signals from the reticular formation of the brainstem to the rest of the body. These signals are also involved in postural control, and they help modulate pain and autonomic function. But the most important tracts for you to be able to identify are the dorsal columns, the spinothalamic tracts, and the lateral corticospinal tracts, the same ones we went over at the beginning. And speaking of postural control and balance, let's talk briefly about the Romberg test. The Romberg test is where you have the patient stand with her feet together, then you have her close her eyes and see if she can maintain her balance, which is normal, or whether she falls over. So why do we do this? What are we testing for? Well, there are three sources of information that help you maintain your balance. Proprioception in the legs, vision, which helps you tell if you start to lean one way or the other, and the vestibular apparatus. So if the patient can't stand even with her eyes open, you know there's something wrong with either their vestibular apparatus or the proprioception. But assuming she can stand with her eyes open, you have her close her eyes, and that's going to eliminate the visual input. Now she's just left with proprioceptive input and vestibular input. And if proprioceptive input is damaged, the patient's going to fall. So the Romberg test is a test of dorsal column function, which carries that proprioceptive signal. It's not a test of cerebellar function. Let me say that again. The Romberg test does not test the cerebellum. Dr. Romberg saw lots of patients with tertiary syphilis, and he developed this test as a way to check for tabes dorsalis, which affects the dorsal columns and proprioception. Let's talk about a couple of other points of anatomy that have clinical applications, starting with the intervertebral discs. Remember that the spine is a column of vertebrae stacked on top of one another, and in between the vertebrae are discs of cartilage called intervertebral discs, which act as shock absorbers and allow the spine to bend and twist. The outer portion of the disc is called the annulus fibrosus. Annulus means ring. This is basically a ring of tough fibrocartilage that contains a lot of strong type 1 collagen and also type 2 collagen. And then the center of the disc is called the nucleus pulposus, which is much softer and more gel-like for maximum cushioning and shock absorption. But if that annulus degenerates over time, the nucleus pulposus can herniate through posteriorly, and it can compress the nerve roots, especially at the lower lumbar spine. And as it compresses the nerve roots, this can cause nerve pain, numbness, tingling, or weakness. And because the nerve root exits the spinal canal at the neural foramen below the vertebrae, herniation of the L4-L5 disc will compress the L5 nerve root. Herniation of the L5-S1 disc will compress the S1 nerve root. And compression of the S1 nerve root will cause pain down the back of the leg and loss of the ankle reflex. And then one last brief bit of anatomy to review is the three layers of the meninges, which are the protective coverings of both the spinal cord and the brain. The meninges are made up of three distinct layers. The pia mater, which is thin and delicate and clings firmly to the outer surface of the brain and spinal cord. Then outside the pia is the arachnoid mater, which is kind of like a mesh or webbing. That's where the name arachnoid comes from. It's like spider webs, arachnids. Both the pia and the arachnoid are derived from the neural crest cells. And then between the pia and the arachnoid is the subarachnoid space, which is where the CSF is found. Then the outermost covering is the dura mater, which is thick and tough and durable, hence the name. Dura means hard. And the dura is derived from mesoderm. Then outside the dura is the epidural space, which is sort of a potential space between the dura and the skull, or the spinal canal and the spinal cord, where there's a little fat and some vasculature. But in the skull, you can have bleeding in this space from head trauma, and that forms an epidural hematoma. And in the spinal cord, we can deliver anesthetic into the epidural space to help relieve the pain of childbirth, for instance. Now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go over them together.
First question, what artery supplies the medullary pyramid and the medial lemniscus in the medulla? That's the anterior spinal artery. Next, what artery supplies the inferior cerebellar peduncle, the nucleus ambiguus, and the lateral spinothalamic tract in the medulla? These are all supplied by the posterior inferior cerebellar artery, or the pica. Next, where does each of the following spinal tracts decussate? So the first two, the lateral corticospinal tract and the dorsal column medial lemniscal pathway, decussate in the medulla. And the spinothalamic tract decussates in the anterior white commissure of the spinal cord, 1 or 2 spinal levels above where it entered the cord. Next, which spinal tracts convey the following types of information? Light touch, proprioception, and vibration sensation, that's the dorsal columns, which includes the fasciculus gracilis and the fasciculus cuneatus. Voluntary motor command from the motor cortex to the body is the lateral and ventral corticospinal tracts. Pain and temperature sensation is the lateral spinothalamic tract. Important for postural adjustments and head movements is the vestibulospinal tract. And proprioceptive information to the cerebellum is the dorsal and ventral spinocerebellar tracts. And the last question, what is the triad of Horner syndrome? We said that was ptosis, meiosis, and anhidrosis. And that's it for the end of session quiz. I'll see you next time.
Welcome back, dear viewer. Are you ready for some more questions? James, you're on the line.
Yeah, hey there, guys.
Hello, James.
I was wondering, if a patient has a positive Romberg test, where's the neurological lesion located?
That's a great question. And to answer your question, James, I will need the help of Monster. Monster, rise. Feet together and eyes closed. This is an example of a positive Romberg test, where the neurological lesion is located in the dorsal columns of the spinal cord, not in the cerebellum.
It's time for another warm-up review. Let's get going. What effect might each of the following teratogens have on a developing fetus? So we got a long list here. First one is ACE inhibitors that can cause renal failure, oligohydramnios. What about the aminoglycosides? That can cause ototoxicity. Diethylstilbestrol. That's going to cause clear cell adenocarcinoma of the vagina. So that's something that you're going to see much later on when the baby is in, or that person is going to be in their teens or 20s, but it can be seen as early as 7 or 8. What about the folate antagonists? So this would be neural tube defects. We know that decreased folic acid can cause neural tube defects, which is why we give pregnant women folic acid supplements. So it would make sense that folate antagonists to cause that neural tube defect. Next, we have lithium that can cause Epstein's anomaly, which is displacement of the septal and posterior tricuspid valve leaflets towards the apex, leading to atrialization of the right ventricle. Next, we have tetracyclines that can cause teeth discoloration. And then we have valproic acid, and that causes neural tube defects. All right, that's it for the warm-up. Let's get to that lecture now.
We're finally ready to tackle the very high-yield subject of brainstem lesions, specifically brainstem strokes. So you need to be able to determine where a particular lesion is located based on the description of the neurological deficits that the lesion produces. So first of all, what's going to make you think about a brainstem lesion in the first place? Well, the hallmark findings of a brainstem lesion, in general, are called alternating syndromes, which means you have discrete symptoms on both sides of the body. So you see long tract symptoms on one side, such as hemiparesis from a corticospinal tract lesion, or a lesion to the posterior columns in the medial lemniscus. So this could be a motor problem or a sensory problem. And then with those long tract symptoms, you're also going to have cranial nerve symptoms on the other side, because you're interrupting the cranial nerve nuclei. So when you see that combination of long tract symptoms on one side and cranial nerve symptoms on the other side, think about a brainstem lesion. And I want to share a shortcut method to localize these brainstem lesions so you don't have to memorize a bunch of different syndromes. The method is called the rule of fours. Now the rule of fours has been around for at least 25 years, and it was actually published in the journal Internal Medicine in 2005. I've included a link to the article, but we're going to go through the Cliff Notes version in the study guide in just a moment. Now the rule of fours is based on the fact that the medial brainstem and the lateral brainstem generally receive blood from separate arteries.
So in the pons, the medial structures receive blood supply from the paramedian branches of the basilar artery, and the lateral structures receive blood from the AICA, which we called a long circumferential artery. And in the medulla, the medial structures are supplied by the anterior spinal artery, and the lateral structures are supplied by the pica. And we've seen that the cranial nerve nuclei are organized sequentially in the brainstem, from cranial nerve 3 and 4 in the midbrain down to cranial nerves 9, 10, and 12 in the medulla. So, if we can figure out how high in the brainstem the lesion is based on the cranial nerve nuclei, and we can tell whether it's medial or lateral based on which tracts are involved, then we can identify whether the stroke is a right medial pons stroke or a left lateral medulla stroke or whatever. And from that, we can identify which vessel was occluded. There are 4 rules in the rule of 4, and each rule has 4 parts. The first rule is there are 4 medial or midline structures, and they all begin with M. So we're going to look at those in a moment. The second rule is that there are 4 side structures or lateral structures, and the side structures begin with an S. The third rule is that 4 cranial nerves originate in the pons, and 4 originate below the pons, and 4 originate above the pons. We saw this rule a few videos ago. So cranial nerves 3 and 4 originate in the midbrain. Remember, cranial nerves 1 and 2 originate in the forebrain, not in the midbrain. So brainstem strokes won't affect cranial nerves 1 and 2. Then the next bullet says cranial nerves 5, 6, 7, 8 originate in the pons, and cranial nerves 9, 10, and 12 originate in the medulla. And remember, cranial nerve 11 originates in the spinal cord because it's the spinal accessory nerve. So this means that with a brainstem stroke, the cranial nerves affected were going to tell you how far up or down the brainstem that stroke is located. If the stroke affects cranial nerves 5, 7, and 8, you know that's a stroke in the pons. If it affects cranial nerves 9 and 10, you know that's a stroke in the medulla. And then the fourth rule is that the 4 motor cranial nerve nuclei in the midline are the ones that divide equally into 12, except for cranial nerves 1 and 2, because those nuclei aren't located in the brainstem. Remember, they're located in the forebrain. So the 4 cranial nerves that divide into 12 are cranial nerve 3, cranial nerve 4, cranial nerve 6, and cranial nerve 12. And again, those are all motor nuclei, and they're all medial or midline brainstem structures. So now you can see how the rule of 4 is useful. If on your exam they give you a patient with long tract symptoms on one side and cranial nerve symptoms on the other side, you know it's a brainstem stroke. And say the cranial nerve symptom is impaired abduction of the left eye. Well, eye abduction is the abducens nerve, cranial nerve 6. So that means the stroke is in what level of the brainstem? 5, 6, 7, 8 is the pons. So this is a pontine stroke. And then is the cranial nerve 6 nucleus a medial structure or a lateral structure? Well, 6 divides into 12, so that tells us that the cranial nerve 6 nucleus is a medial pons structure. And since the deficit was impaired abduction of the left eye, that means that this is a stroke of the left medial pons from occlusion of one of those penetrating median or paramedian branches. That's how the rule of 4s is used. And based on that, you can even predict what long tract symptoms you would expect to see on the right side of the body. So let's look back at the first 2 rules in more detail. The first 2 rules help you to remember the long tract symptoms. The first rule says that there are 4 medial structures that begin with an M. There's the motor pathway, which is the corticospinal tract. So if you go back and look at the diagrams of the brainstem, the corticospinal tract is located in the medial pons and in the pyramids of the medulla. And what kind of neurological deficit would you expect from a lesion of the corticospinal tract? Weakness of the contralateral arm and leg. The next medial M structure is the medial lemniscus, which you remember is the continuation of the dorsal columns in the brainstem. So this carries vibration sense and proprioception and fine touch. And a lesion here would cause loss of vibration, proprioception, and fine touch in the contralateral arm and leg. The third M is the MLF, the medial longitudinal fasciculus, which is involved in controlling the eyes. So the deficit associated with an MLF lesion is called internuclear ophthalmoplegia. And I'm going to explain what that is a little later on. So you'd see ipsilateral internuclear ophthalmoplegia. And then the last medial structures are the motor cranial nerve nuclei. So this is where the 4th rule comes in. So which motor cranial nerve nuclei are located medially? Again, it's the ones that divide into 12, cranial nerves 3, 4, 6, and 12. So a lesion here could potentially cause ipsilateral defects of cranial nerves 3, 4, 6, and 12, depending on what level of the brainstem is affected. So those are the medial structures.
And then the second rule is the lateral structures, which start with S because they're located on the side. So the first one is the spinocerebellar tract. Now, we didn't talk specifically about that tract, but where does it come from and where's it going? Well, it's spinocerebellar, so it carries information from the spinal cord to the cerebellum. And if you look back at the drawing of the medulla, you'll see the inferior cerebellar peduncle, which is where the spinocerebellar tract runs. And a lesion here will cause ipsilateral arm and leg ataxia. The next S structure is the spinothalamic tract, which carries pain and temperature sensation. So the deficit would be an alteration of pain and temperature sensation in the contralateral arm and leg, and rarely on the trunk. Then you have the sensory nucleus of cranial nerve 5, which would cause ipsilateral alteration of pain and temperature sensation on the face. And the last S is the sympathetic pathway, and the deficit is ipsilateral Horner syndrome, which is that triad of ptosis, meiosis, and anhidrosis. So that's the rule of 4s. Now, it probably seems complicated, but as we work through these various brainstem stroke syndromes, you're going to see how these rules simplify things and help you put it all together. Let's review some specific brainstem stroke syndromes. Now, most books and lecturers cheat just a little bit. They tell you up front what the lesion is, and then they give you a huge list of deficits that lesion might cause. But on step 1, and in real life, patients don't come in with the location of the lesion stamped on their foreheads. They come in with symptoms and physical exam findings, and it's up to you to figure out where the lesion is located. So I'm going to describe some patient presentations, and then we're going to practice using the rule of 4s to figure out where the lesion is. So imagine that a patient shows up in the emergency department with acute onset of hoarse voice and difficulty swallowing, loss of pain and temperature sensation in the right arm and leg, and ataxia in the left arm. And then on physical exam, the uvula deviates to the right. So where's the lesion? Well, first of all, this patient has some symptoms on one side and other symptoms on the other side, and a combination of both long tract symptoms and cranial nerve symptoms. That's that alternating syndrome I mentioned earlier. So that suggests this is a brainstem stroke. So now we can use the rule of 4s to figure out where in the brainstem the stroke is located. Now, I like to start with the cranial nerves to decide what level of the brainstem is affected. So what cranial nerve lesions will cause hoarseness and dysphagia? Well, the vagus nerve, cranial nerve 10, innervates the larynx and also most of the pharyngeal muscles, along with the glossopharyngeal nerve. That also goes along with the deviated uvula from a vagus nerve lesion. So at what level of the brainstem do cranial nerves 9 and 10 originate? Well, if the pons is 5, 6, 7, 8, then cranial nerves 9 and 10 must originate below that down in the medulla. So now we know that this is a stroke in the medulla. Then, once we've localized the lesion vertically, we also need to localize the lesion horizontally. That is this a medial medulla stroke or a lateral medulla stroke? That's where our long tracts come in. Loss of pain and temperature sensation in the arm and leg. That's the spinothalamic tract, right? And ataxia in the other arm is the spinocerebellar tract. Well, these are both S structures or side structures, lateral structures. So that means that this is a stroke in the lateral medulla. And more specifically, this must be in the left lateral medulla. Now, a lesion in the lateral medulla produces a constellation of findings called Wallenberg syndrome, which is about a 4 or 5 star topic for step 1. If you don't know anything else from this video, know Wallenberg syndrome. We have the symptoms associated with lateral medullary syndrome or Wallenberg syndrome listed in the study guide. There's loss of pain and temperature on the contralateral side of the body from the spinothalamic tract. There's loss of pain and temperature sensation on the ipsilateral side of the face from the spinal trigeminal nucleus. Remember, we said that the cranial nerve 5 nucleus is so big that it starts up in the pons, but then it stretches all the way down into the medulla. You can see hoarseness, difficulty swallowing, and loss of gag reflex because of a nucleus ambiguous lesion. Remember, nucleus ambiguous is speech and swallowing. You can have ipsilateral Horner syndrome because this affects a descending sympathetic tract. Then I want you to either circle or star the next one. Vertigo, nystagmus, and nausea and vomiting because of damage to the vestibular nucleus. Lateral medullary infarcts almost always cause some vestibular cerebellar symptoms, very common. And that includes the ipsilateral cerebellar deficits because of damage to the inferior cerebellar peduncle. We called that the spinocerebellar tract back in the rule of 4, but it's the same thing. So Wallenberg syndrome causes a very particular constellation of symptoms. No motor weakness, and no sensory deficits other than pain and temperature. But you can have any combination of these other symptoms. Again, it's very high yield for step 1. Then the next question says, which vessel is most likely occluded in a patient with a stroke of the lateral medulla? The lateral medulla is supplied by the pica, the posterior inferior cerebellar artery. You might also hear this called pica syndrome. And if you look at all the structures there, you can see how it causes all these deficits. Let's consider another patient. Say they give you a patient who comes in complaining of weakness in the right arm and leg, and numbness in the right arm and leg, and on physical exam he has decreased vibration sense and proprioception in the right arm and leg, plus his tongue deviates to the left. So again, start with a cranial nerve defect. Which cranial nerve provides motor innervation to the tongue? It's the hypoglossal nerve, cranial nerve 12. So what level of the brainstem is this? Well, cranial nerve 12 originates in the medulla, right? And then the arm and leg weakness comes from corticospinal tract involvement. And the sensory deficits in this case are due to the involvement of the medial lemniscus, which was the continuation of the dorsal columns in the brainstem. So the motor tract and the medial lemniscus are both medial or midline structures, so this must be a stroke of the medial medulla. And it has to be the left medial medulla because it's causing weakness and numbness on the contralateral arm and leg, over on the right side. Plus, we said that with hypoglossal nerve lesions, the tongue licks the lesion. So the tongue deviating to the left goes along with a left medial medulla stroke as well. And maybe you remember rule number 4, which said that the motor cranial nerve nuclei that are medial are the ones that divide into 12. So the cranial nerve 12 nucleus is a medial structure as well. So it all fits. So to reiterate the findings of medial medullary syndrome, there's contralateral hemiparesis, or arm and leg weakness, because of damage to the corticospinal tract. And this is an upper motor neuron lesion, so this is going to cause spastic hemiparesis. There's damage to the medial lemniscus, which causes contralateral sensory deficits, tactile and kinesthetic defects. That's another word for proprioception. And then the hypoglossal nerve damage will cause the tongue to deviate toward the lesion. The patient may present with slurred speech because the tongue isn't working correctly. And remember that the vessel involved is the anterior spinal artery, which supplies blood to the medial structures in the medulla. So hopefully you're starting to become more comfortable with the rule of 4s, because we're going to go through the rest of these a little bit faster. Say you have a patient with left facial droop affecting both the upper and lower face, loss of pain and temperature sensation on the left side of the face, and loss of pain and temperature sensation in the right arm and leg. Now in this one, the facial droop suggests cranial nerve 7, which originates in the pons. And the sensory deficit suggests that enormous spinal trigeminal nucleus and the spinothalamic tract, which are both S structures or lateral structures. So this is a stroke of the lateral pons. And specifically, this is the left lateral inferior pons because the facial nerve nucleus is located in the inferior pons. So the symptoms of lateral inferior pontine syndrome include ipsilateral facial nerve paralysis because this affects the facial nerve nucleus. If this were the superior pons, you might see trigeminal nerve involvement and jaw weakness. You'll see ipsilateral limb and gait ataxia, ipsilateral loss of pain and temperature sensation on the face. You're going to see contralateral loss of pain and temperature sensation on the body. So the ipsilateral loss was in the face, contralateral loss of pain and temperature sensation is in the body. And you might have ipsilateral Horner syndrome because of the sympathetic fibers. Lateral inferior pontine strokes can be caused by occlusion of the anterior inferior cerebellar artery. But there's a lot of collateralization from the superior cerebellar artery and the pica, so lateral pontine strokes are fairly uncommon. Here's another patient presentation. Say you're seeing a patient with inability to abduct or adduct the right eye, horizontal nystagmus in the left eye when looking left, left arm and leg weakness, and loss of fine touch, vibration, and proprioception in the left arm and leg. Now, in this one, the cranial nerve lesions could be confusing with the nystagmus and so on, but notice that we have an inability to abduct the right eye. That suggests a right cranial nerve 6 lesion, doesn't it? And if you think back to rule number 4, cranial nerve 6 divides into 12, which reminds you that the cranial nerve 6 is one of the motor nuclei located medially. Now, the arm and leg weakness suggests corticospinal tract involvement, which is a medial structure, M for motor. And then the sensory deficit suggests the medial lemniscus. So this all suggests a stroke in the right medial pons. So with medial pontine syndrome, you have contralateral spastic hemiparesis due to corticospinal tract damage. You have contralateral loss of light touch, vibration sense, and proprioception due to medial lemniscus damage. You may see internuclear ophthalmoplegia due to damage of the MLF, the medial longitudinal fasciculus. I'll explain what that is in just a moment, but this is part of the eye findings I described and also the nystagmus. Adjacent to the MLF is a structure called the PPRF, the paramedian pontine reticular formation. So both the MLF and the PPRF are involved with coordinating conjugate gaze. and damage to the PPRF makes the patient's gaze drift away from the side of the lesion. We didn't see that in our patient, but you certainly could. But we did see ipsilateral paralysis of the lateral rectus muscle due to damage of the cranial nerve 6 nucleus, the abducens nerve. Now, we said that lateral pontine strokes are uncommon, but medial pontine strokes are much more common. And they usually present with prominent ophthalmoplegia or eye movement problems. And what vessel is to blame for medial pontine strokes? The basilar artery, or more specifically, the median and paramedian branches of the basilar artery, which are the branches that penetrate the pons. So what kinds of ophthalmoplegia or eye movement problems are we talking about? Well, I mentioned it's called internuclear ophthalmoplegia, which is caused by a lesion of the medial longitudinal fasciculus. So sometimes you're going to hear this called MLF syndrome, for medial longitudinal fasciculus. Now the MLF is a structure in the pons that helps the eyes track together when you look side to side. It allows the lateral rectus muscle on one eye to coordinate its movements with the medial rectus muscle on the other eye, so that your eyes can kind of look in the same direction at the same time. So if you lesion the MLF, you're going to get a medial rectus palsy when you attempt a lateral gaze, when you try to look side to side. In letter A, the patient is looking straight ahead, which looks normal. In letter B, the patient is looking to the right, which also looks normal. But in letter C, when the patient looks to the left, you have two problems. First of all, there's a medial rectus muscle palsy in the right eye because the MLF lesion is on the right. So the left eye abducts, but the right eye cannot adduct. So the right eye just stays looking straight ahead. And then the second problem is that the left eye, which is abducting, has horizontal nystagmus. So if the patient looks to the right, there's no problem. But if the patient looks to the left, you have medial rectus palsy in the right eye on attempted lateral gaze, plus nystagmus in the left eye. But if you ask the patient to cross his eyes to focus on something up close, that's called convergence. And convergence is normal. So the medial rectus can function, it just doesn't work on attempted lateral gaze. And I want you to know the two main clinical situations in which you're likely to see internuclear ophthalmoplegia. They're multiple sclerosis, especially in patients younger than 50, and in older patients, those over 50, think about medial pontine strokes. While we're talking about lesions in the pons, I also want to mention something called locked-in syndrome, which is where the patient is fully awake and alert and aware of what's going on, but he's not able to communicate or move anything except the eyes. It's like you're locked into your body. Now, locked-in syndrome occurs due to basilar artery strokes that affect both sides of the superior pons. It's also classically associated with rapid correction of hyponatremia, or low sodium. And this can lead to lysis of the myelin in the central part of the pons. We call this central pontine myelinolysis. And on MRI, you're going to see this as an increased signal intensity in the pons. It's pretty rare, but that's a classic association. And then the very last topic I want to cover is a midbrain stroke, which is called Weber syndrome or Weber syndrome. But Weber syndrome is another 3 or 4 star topic. Weber syndrome is caused by an anterior midbrain infarction resulting from occlusion of the paramedian branches of the posterior cerebral artery. This causes infarction of the cerebral peduncle, which were those wings on the anterior surface of the midbrain cross sections, just anterior to the substantia nigra. And within those cerebral peduncles, you're going to find the corticospinal tract and the corticobulbar tract, which carries motor signals to the medulla. That's what bulbar means, medulla. Now, infarction of the corticobulbar tract will cause problems with swallowing and speaking and controlling the tongue. An infarction of the corticospinal tract will cause contralateral hemiparesis and weakness in the arm and leg. And because the fibers of the oculomotor nerve run right past here, you can also see ipsilateral oculomotor nerve palsy with ptosis, pupillary dilation, and lateral strabismus, which means the eye is going to look down and out. Now, for the end of session quiz, we have some more patient presentations so you can get more practice using the rule of 4s. So try those on your own, then we'll go over the answers. First question. A patient comes to the ER with double vision and left-sided weakness. On physical exam, she cannot abduct her right eye. In addition to motor weakness of the left arm and leg, she also has loss of fine touch, proprioception, and vibration sense in the left arm and leg. Where is the lesion and what vessel is most likely involved? Well, this patient has a right cranial nerve 6 palsy, an involvement of the right corticospinal tract and the right medial lemniscus, so this is a lesion of the right medial pons. And the vessels that supply this area are the median and paramedian branches of the basilar artery. Next, a patient presents with vertigo, nystagmus, and slurred speech. Physical exam reveals right-sided ptosis and meiosis, decreased gag reflex on the right, deviation of the uvula to the left, diminished pain and temperature sensation on the right side of the face, and diminished pain and temperature sensation on the left side of the body. So where's the lesion and what vessel is most likely involved? Well, this patient has Wallenberg syndrome, which is a lateral medullary stroke. In this case, the lesion is in the right lateral medulla, and the vessel is the right pica, the posterior inferior cerebellar artery. And the last question. A patient presents with double vision, slurred speech, hoarse voice, and acute right-sided weakness. Physical exam shows weakness of the right arm and leg, and the left eye is depressed and abducted. It's down and out. So where's the lesion and what vessel is most likely involved? This is Weber syndrome. Left oculomotor nerve palsy, bulbar symptoms, and right hemiparesis. So this is a lesion of the left anterior midbrain, and the vessel involved is the left posterior cerebral artery. And that's it for now. I'll see you next time.
It's time for a warm-up review. Let's get going. What is the function of the lysosome? So the lysosome is going to contain the enzymes that break down cellular wastes and cellular debris. Next, what are the characteristic features of a cell undergoing apoptosis? So you get lots of things. You get cellular shrinkage, you get nuclear shrinkage, which is called pycnosis. You have karyoresis, which is fragmentation of the nucleus. You have karyolysis, which is fading of the nucleus. You have apoptotic bodies that are going to be formed, and then you're going to have membrane blebbing. Next, how do BAX and BCL2 affect apoptosis? So remember that BAX promotes apoptosis, it's giving the X to the cell, and then BCL2 is actually going to inhibit apoptosis. All right, that's it for the review. Let's get to that lecture.
In this video, we're going to focus our attention briefly on CSF. Now, despite what you may find on Wikipedia, CSF does not stand for the Colorado Shakespeare Festival, the Canadian Snowboarding Federation, the Caltech Satanic Fellowship, or even classical swine fever. Although that's getting closer, I guess. Honestly, the fact that there are diseases out there called hog cholera and bovine viral diarrhea make me very glad that I chose med school over veterinary school, but I digress. Now, the CSF we're interested in is the cerebrospinal fluid, which bathes the brain and the spinal cord, acting as a cushion and a support for the brain, as well as tightly regulating the electrolyte concentrations and dissolved gases that contact the brain. So in this video, we're going to talk about a couple of disorders that involve the CSF. Let's start by reviewing the anatomy of the ventricular system and the circulation of CSF. There are two lateral ventricles, which are connected to the third ventricle, and that empties into the cerebral aqueduct and eventually to the fourth ventricle, which continues as the central canal of the spinal cord. So where does CSF come from? Well, it comes from the choroid plexus, which lines the ventricles. Now, from the lateral ventricle, the CSF flows into the third ventricle by way of the foramen of Monro. And from the third ventricle, it flows through the cerebral aqueduct into the fourth ventricle. And then from the fourth ventricle, it enters the subarachnoid space by way of the foramen of Luschka and the foramen of Magendie. And from the subarachnoid space, CSF is reabsorbed in the arachnoid granulations back into the superior sagittal sinus. The superior sagittal sinus is one of the dural venous sinuses, which are sort of channels within the layers of the dura where venous blood can flow. The superior sagittal sinus basically runs along the top of your brain in the midline, and this is where you find the arachnoid granulations that return CSF back into circulation. Then toward the back side of your head, on each side, you have the sigmoid sinuses, which is the last place that the blood from the brain travels through before it exits the cranium through the jugular foramen. And as the sigmoid sinus passes through the jugular foramen, it becomes the internal jugular vein. The internal jugular vein is found in the carotid sheath along with the vagus nerve. So you have three very important structures found within the carotid sheath: the carotid artery, the internal jugular vein, and the vagus nerve. Let's talk about what happens if the flow of CSF is interrupted. If the flow of CSF is obstructed anywhere in that pathway, from the lateral ventricles to the third ventricle and the aqueduct to the fourth ventricle, the CSF pressure is going to build up behind that obstruction, and that pressure causes the ventricles to dilate and expand. We call this a non-communicating hydrocephalus, or an obstructive hydrocephalus, because the communication between the ventricles has been obstructed, so it's non-communicating. Now, this can lead to severe headache from elevated intracranial pressure. It can lead to papilledema and uncal herniation with a blown pupil and possibly that down and out eye from a cranial nerve 3 palsy. And ultimately, it can potentially cause death. A communicating hydrocephalus occurs when there's no apparent obstruction. Everything appears to be flowing through the ventricles normally. But what's happening is that there's poor reabsorption of CSF at the arachnoid granulations. And that results in the same findings: increased intracranial pressure, headache, papilledema, and herniation. There's also something called normal pressure hydrocephalus. This is where there's expansion of the ventricles due to impaired CSF absorption, but when you measure the intracranial pressure, it's normal. But there's still no obstruction of flow within the ventricular system. And in order to recognize normal pressure hydrocephalus, you need to know the triad of symptoms: urinary incontinence, dementia, and gait disturbance. Now, the mnemonic you'll hear for this is wet, wacky, and wobbly. So wet is that urinary incontinence, wacky is the dementia, and wobbly is the gait disturbance. Now, the gait disturbance in normal pressure hydrocephalus is described as a magnetic gait, like there are magnets stuck in the patient's feet, sort of holding the patient's feet to the ground. So they take these very short, low amplitude steps. So make sure you can recognize that triad: incontinence, dementia, and gait disturbance. And normal pressure hydrocephalus is a cause of dementia that is potentially reversible. Most causes of dementia we'll talk about are irreversible, but this is one you'd actually like to be able to diagnose because you can put in a shunt and get that excess fluid out of the brain and the symptoms all resolve. There's another pathology that looks like hydrocephalus on CT, which is called hydrocephalus ex vacuo, or sometimes it's called ex vacuo ventriculomegaly. So it looks like there's dilation of the ventricles, but in fact the ventricles are not dilated. It's just that the brain tissue around the ventricles has atrophied, so the ventricles appear enlarged by comparison. That's why it's called ex vacuo. There's sort of a vacuum that gives the appearance of hydrocephalus. The main place you're going to see atrophy of the brain tissue is in dementia patients, like patients with Alzheimer's disease. Now, in your study guide, there's a table that compares all these different types of hydrocephalus, so let's fill that out together.
All right, so in this table I've listed several different types of hydrocephalus, and let's compare some of the different features of these. The first one is non-communicating hydrocephalus. We said this one is caused by obstruction of CSF flow. Then we'll skip intracranial pressure for a second and talk about the signs and symptoms. This can cause headache, it can cause personality changes, it can cause lethargy, it can cause papilledema, and it can cause cranial nerve 3 palsy and blown pupil. Then the next one is communicating hydrocephalus. Communicating hydrocephalus, we said, is due to impaired CSF absorption. And what part absorbs the CSF? The arachnoid granulations. Now, the signs and symptoms for communicating hydrocephalus are basically going to be very similar to the non-communicating hydrocephalus. And then we have normal pressure hydrocephalus, which is also due to impaired CSF absorption. And the main difference between normal pressure hydrocephalus and communicating hydrocephalus is with the intracranial pressure. So with communicating hydrocephalus and non-communicating hydrocephalus, you have increased intracranial pressure. But again, with normal pressure hydrocephalus, the pressure is normal. Not too big a surprise. Then the symptoms and signs that you see with normal pressure hydrocephalus, we said the mnemonic was wet, wacky, and wobbly. So this stands for urinary incontinence, wacky is dementia, and wobbly is that gait disturbance. And then finally we have hydrocephalus ex vacuo, which is not really a kind of hydrocephalus, but it looks like hydrocephalus on scanning. And this is caused by neuronal atrophy. And again, the intracranial pressure is normal. And the signs and symptoms you're going to associate with this are dementia, because actually it's the neuronal atrophy that we see with things like Alzheimer's dementia that cause hydrocephalus ex vacuo. So as a reward for you, I'm going to draw you a picture of my uncle. And you'll notice with my uncle that his pupil is dilated and his eye is deviated down and out because he has a cranial nerve 3 palsy. So his name is Uncle Herniation.
Now let's talk about idiopathic intracranial hypertension, which you may know by the name pseudotumor cerebri. In idiopathic intracranial hypertension, there's elevated intracranial pressure, but no hydrocephalus. So it's the opposite of normal pressure hydrocephalus, in which there's hydrocephalus without elevated intracranial pressure. So let's look at the study guide. What are the characteristic features of idiopathic intracranial hypertension? Well, the classic patient is a young, obese woman. They get daily pulsatile headaches, generally worse at night or early in the morning, possibly with retroocular pain, pain behind the eye that's worsened by eye movement. and these patients may also have some nausea and vomiting. They have papilledema and elevated intracranial pressure, which is why this is a pseudotumor, because clinically it looks just like a brain tumor. The most worrisome sequela is vision loss, which is one reason we treat this. That elevated intracranial pressure is squeezing the optic nerve and potentially damaging the optic disc. On CT scan, you do not see ventricular dilation or hydrocephalus, and there's no tumor or intracranial mass. You might expect to find a tumor based on the clinical picture of headache and papilledema and elevated intracranial pressure, but this is a pseudotumor cerebri. It's a false tumor, if you will. And when you do a lumbar puncture, the intracranial pressure is elevated. That's the hallmark of idiopathic intracranial hypertension, elevated ICP. In a non-obese patient, the CSF pressure should normally be less than 200 millimeters of water, and anything higher than that would suggest idiopathic intracranial hypertension. But in an obese patient, obesity raises the intracranial pressure a little bit, so the normal baseline is a little higher in obese patients. So the cutoff becomes 250. And then the next question says, how is idiopathic intracranial hypertension managed? We're going to discontinue any inciting agents like excess vitamin A, isotretinoin, tetracyclines, or danazol, because these can raise the intracranial pressure. The next bullet is weight loss in obese patients. Then the next one is acetazolamide, which is our first-line pharmacotherapy because it slows down the production of CSF. Then there are also some invasive treatment options. Serial lumbar punctures to draw off some CSF and keep the intracranial pressure low. You can do optic nerve sheath decompression and also lumboperitoneal shunting, or a CSF shunt, to keep that pressure lower. And while we're talking about lumbar punctures, let's review a couple of tiny points of anatomy. When you perform a lumbar puncture, what are the layers of tissues that the needle penetrates? This is one of those odd anatomical things that you might be tested on. You start with the skin and the superficial fascia. Then the needle goes through 3 ligaments, the supraspinous ligament, the interspinous ligament, and the ligamentum flavum. And then you enter the epidural space. Now there's no CSF in the epidural space, but there are some nerve roots here, so this is a great place for epidural anesthesia. So someone in labor that's getting an epidural has local anesthetic like bupivacaine or maybe the opioid like fentanyl placed in that epidural space. But if you're trying to get to CSF, you need to go deeper. So from the epidural space, then you go through the dura mater into the subdural space, and then through the arachnoid membrane and into the subarachnoid space, and that's where you find the CSF. Now, if we give anesthesia directly into that CSF space, that's called spinal anesthesia, not epidural anesthesia. There's a difference between epidural anesthesia and spinal anesthesia. We use both in labor and delivery. Spinal anesthesia is more potent. That's typically what we use for a C-section. And then real quick, let's talk about the landmarks you use to do a lumbar puncture, or an LP, or the common layman's term is a spinal tap, but that's nitpicking, isn't it? In adults, the spinal cord goes all the way down to L1 or L2. So when you do an LP, you want to insert the needle below that level, between L3 and L4, or between L4 and L5, to make sure you're not hitting the cord. So you can remember, go between L3 and L5 to keep the cord alive. And in children, you need to go even lower than that, between L4 and L5, or even L5S1. As you grow, the cord kind of migrates north in the spinal canal just a little bit. So if you imagine a horizontal line between the top of the iliac crest, that's going to help you identify the L4 vertebra, and you can palpate around and identify the spinous processes and then go between them. All right, let's pause the video and work through the end-of-session quiz. First question, where is CSF generated and where is it reabsorbed? So it's generated by the choroid plexus and it's reabsorbed by the arachnoid granulations in the superior sagittal sinus. Next, what's the difference between communicating and non-communicating hydrocephalus? In communicating hydrocephalus, you have decreased absorption of CSF at the arachnoid villi. In non-communicating hydrocephalus, there's a physical, mechanical obstruction of the ventricles. They both cause hydrocephalus, just in different ways. And the last one, what clinical features characterize normal pressure hydrocephalus? Well, again, the mnemonic is wet, wacky, and wobbly. Urinary incontinence, dementia, and gait disturbance. All right, that's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. Which protein is involved in transporting an endocytosed vesicle from the plasma membrane to the endosome? So you can see the clathrin coat endocytosing the vesicle and then uncoating here. So it is clathrin. Next, which developmental structure matches each of the following descriptions? So first we have the fetal placenta structure that secretes HCG. That's going to be the syncytiotropoblast. And then the maternal component of the placenta, that's going to be the decidua basalis. Next question, what is the main inhibitory neurotransmitter of the CNS? In which diseases are levels altered? So what's the main inhibitory neurotransmitter? That's going to be GABA. And then in which disease are the levels altered? You have decreased GABA in things like anxiety, also in Huntington disease. So with Huntington chorea, you have decreased GABA and decreased acetylcholine as well. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to talk about headaches, which are a 4 or 5-star topic for step 1. There are a lot of different kinds of headaches and lots of different causes of headaches. You need to be able to recognize some specific headache syndromes. There are 3 main headache types I want you to focus on. You've got tension headaches, migraine headaches, and cluster headaches. Let's walk through each of these one at a time, starting with tension headaches. Tension headaches cause constant, non-throbbing pain that lasts for about 4 to 6 hours on average, but possibly several days. They occur in the frontal or occipital regions, most commonly bilaterally, kind of in a squeezing nature, or they might feel like a tight band on the head. Tension headaches are not associated with sensitivity to light or loud noise. They are not associated with vision disturbances, nausea and vomiting, or any focal neurological changes. If you have any of those findings, you should be thinking about another cause of a headache. So that's tension headaches. Think about muscle tension causing that pain. Let's talk about migraines next. Lots of severe headaches get called migraines, possibly inaccurately, but you need to be able to recognize the features of a true migraine. One of the classic features of a migraine is an aura. Now, not all migraines are preceded by an aura. In fact, most migraines aren't preceded by an aura. So we classify migraines as either a migraine with aura or a migraine without aura. The aura might include visual changes, such as streaks of light in the periphery of your visual fields. That's called a scintillating scotoma. Or sometimes a migraine aura might be an unusual smell just prior to the headache. That can be similar to a seizure aura. In your study guide, there are a list of diagnostic criteria for migraines, and you'll notice that an aura is not one of those criteria. Again, only about 25% of patients who have migraines will have an aura before the onset of the headache, but these individuals do have a higher incidence of stroke. So let's look at the diagnostic criteria of migraines. The headache typically lasts 4 to 72 hours. It's a unilateral headache. It's got a throbbing, pulsating quality to it. Some migraines are worse than others, but migraines are generally severe enough to prohibit daily activities. Tension headaches don't normally prohibit daily activities. Migraines will. Migraines can be aggravated by routine physical activity. And with a migraine, you should have at least one of the following: nausea and vomiting, or photophobia or phonophobia, sensitivity to lights or sensitivity to loud noise. These patients just want to lie in a dark, quiet room until the migraine passes. Migraines are 2 to 3 times more common in women than in men. Tension headaches are just slightly more common in women. So if they give you a male patient with a headache, less likely to be a migraine. And then our third major cause of headaches is a cluster headache. Cluster headaches are much more common in men than in women, about 4 times more common, especially in youngish men, like 20s and 30s, and especially in young men who smoke. A cluster headache is strictly unilateral. It causes severe pain, often described as piercing or a boring pain, like someone's boring into the patient's head with a drill or something. And it's often located near one eye, so this is kind of like a periorbital pain or can be retroorbit behind the eye. Cluster headaches don't throb or pulsate like a migraine. It's a constant pain. And again, no aura here either. The headaches last for anywhere from 30 minutes to 3 hours. They can often occur daily, at the same time, every day for 4 to 8 weeks. It's a predictable pattern. And then eventually the headaches stop for several months and then return 1 or 2 hours the same time every morning for another month. So these headaches tend to be clustered together in a time. That's why we call them cluster headaches. Cluster headaches might be associated with a partial Horner syndrome, consisting of ptosis and meiosis, but not the anhidrosis, which is why it's a partial Horner syndrome. The patient may also have eye redness or tearing or rhinorrhea or nasal congestion, all on the same side as that terrible headache. Now let's talk through some of the treatments for each of these. Tension headaches are generally treated with NSAIDs like ibuprofen or naproxen or acetaminophen. Migraines are commonly treated with triptans such as sumatriptan, rizatriptan, or zolmitriptan. Let's talk about triptans for just a moment here. These triptans are all serotonin agonists, which cause some vasoconstriction. They also modulate neurotransmission in the trigeminal nerve. So the triptan drugs can be used for migraines or cluster headaches, or any severe headache. But classically, we use them for acute migraine. The sooner you take a triptan at the onset of a migraine, the better it will work. If you wait until the migraine's been going on for hours and hours, the triptans aren't going to work as well. So migraine patients should be instructed to take the triptan as soon as the headache starts, or as soon as they begin to experience that aura, or some migraine patients will have a prodrome, where the headache hasn't really begun, but they can feel it coming on. So take the triptan as soon as possible for the best effect. Triptans also have some important side effects. Because they cause vasoconstriction, they can vasoconstrict the coronary arteries. Therefore, triptans are contraindicated in patients with coronary artery disease and also patients with Prinzmetal angina, which is due to coronary artery vasospasm. Triptans are also relatively contraindicated in pregnancy because we don't want to constrict the vessels to the placenta. And then for treating cluster headaches, you could use a triptan, and you could use NSAIDs or acetaminophen, but the main treatment I want you to remember is to give 100% oxygen through a non-rebreather face mask. This will abort the headache in as little as 5 minutes, although you need to keep giving the mask for at least 15 minutes so the headache doesn't recur. For your test, 100% oxygen is the treatment of choice for cluster headaches. So far, we've covered the 3 big primary headache syndromes: tension headaches, migraine headaches, and cluster headaches. But there are lots of other things that can cause headaches, like meningitis and giant cell arteritis, brain hemorrhages. We're not going to cover every possible headache in detail right now. We'll cover those in other videos. But I do want to quiz you a little bit so that you can compare the diagnostic features of different kinds of headaches presentations. There's a big table in your study guide, and that says, what's the most likely cause of headaches based on each of the following descriptions? Some of the headaches are syndromes we've just been talking about, and some are those that we're going to talk about later in the course. So pause the video and try to answer these, and then I'll go through the answers with you right after you attempt it on your own. Ready? Let's go through these answers. What's made worse by foods containing tyramine? This is a migraine. Patients with migraines should try to avoid tyramine-rich foods. So where do you find tyramine? That's in aged foods, as aged foods tend to have more tyramine, which can trigger migraines. So think about brown bananas, aged cheeses, aged meats and wines, things like that. The other one is an obese female with papilledema. This is a classic presentation of idiopathic intracranial hypertension, aka pseudotumor cerebri. Or it could be a case of hydrocephalus. Anytime you see papilledema, you need to think about increased intracranial pressure. But in that obese female, that might be a clue that this is idiopathic intracranial hypertension. What about jaw muscle pain when chewing? That's jaw claudication, and that can suggest giant cell arteritis, aka temporal arteritis. This is a form of vasculitis, so we're going to cover it more in the cardiovascular section. What about periorbital pain with ptosis and meiosis? It's cluster headache. Photophobia and or phonophobia is more typical of a migraine. Bilateral frontal or occipital pressure, that's tension headache. What about a patient with headaches who's using topical retinoic acid for acne? Retinoic acid is vitamin A, and remember, vitamin A toxicity can cause idiopathic intracranial hypertension. Lacrimation and or rhinorrhea associated with headache. That's cluster headache. What about a headache with an elevated SED rate? Giant cell arteritis again. What about a patient who says they're having the worst headache of my life? And that's definitely a buzzword for subarachnoid hemorrhage. Headache plus extraocular muscle palsy. Think about cavernous sinus thrombosis. Scintillating scotoma prior to the headache. That's a migraine with aura. Response to 100% oxygen supplementation. That's cluster headache. Trauma to the head, followed by a headache days after the event that persists for a week and doesn't go away. That would be classic for a subdural hematoma. Severe headache plus fever or neck stiffness. Definitely think about meningitis. What about constant headache for weeks with neurodeficits and/or seizures? That's pretty worrisome for a brain tumor. Brain tumors typically cause a constant headache that doesn't come and go. It's just there all the time. It never gets better. It just gets worse and worse and worse as the week goes on. We have an entire video dedicated to brain tumors later. Now it's time for the end of session quiz. So work on those questions and we'll go through the answers together. First question. What features allow you to distinguish a migraine headache from a cluster headache or a tension headache? With migraines, you may have an aura or a unilateral throbbing pain. You also have nausea, vomiting, photophobia, and phonophobia. And the time frame is about 4 to 72 hours. With a cluster headache, you have daily headaches in those clusters of time. It's unilateral, but non-throbbing, and it's usually localized around one eye. You might have tearing or rhinorrhea with it. And a cluster headache is a shorter time frame, usually 15 minutes to 3 hours. And then a tension headache doesn't have any of those things. You'll just have a bilateral, frontal, or occipital pain that's typically not too severe, and it can go on anywhere from a few hours up to a week. What's the mechanism of action for sumatriptan? It's a serotonin agonist, specifically agonist of serotonin 1B and 1D receptors. Next question. What are the contraindications to sumatriptan use? We don't use triptans in patients with coronary artery disease or prinzmetal angina because they cause vasoconstriction and they're also relatively contraindicated in pregnancy. All right, that's all for now. We'll see you next time.
Do you suffer from migraine headaches? Did you know that many common foods can trigger migraines? Patients who are prone to migraines should avoid alcohol, chocolate, caffeine, aged cheeses such as cheddar, Parmesan, and Swiss, foods rich in tyramine, including processed meats, pickles, onions, olives, certain types of beans, raisins, nuts, avocados, canned soups, and red wine, monosodium glutamate, aspartame, nitrates and nitrites.
Stop! Are you trying to kill me?
Sorry, I guess I got carried away.
Let's go over the warm-up review. First question, how does having high cholesterol content in the plasma membrane affect the function of the plasma membrane? Well, high cholesterol content decreases membrane fluidity and it increases melting temperature. Next, what are the stages that an embryo goes through between conception and the development of an inner cell mass? So immediately after conception, you have a zygote. Then the next stage is the morula, which looks like a mulberry. And then when the inner cell mass develops, the embryo is called a blastocyst. And the last one, what are the differences between oligodendroglia and Schwann cells? These are both types of cells that myelinate neurons. Oligodendroglia are found in the CNS, and each cell myelinates multiple axons. Schwann cells are found in the peripheral nervous system, and each cell only myelinates one axon. And remember, peripheral nervous system axons are very long, so each axon has multiple Schwann cells myelinating it. All right, let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on brain tumors. Now just like Arnold Schwarzenegger, you're probably hoping that that headache you have right now isn't a brain tumor. But don't worry, that persisting problem with your memory is probably just the stress of a career-defining test looming in the not-too-distant future. So there's really no need to incessantly check your DTRs, and please stop asking your friends to look at your tongue to see which way it is deviating. All right, so let's get going. We're talking about brain tumors, and first we're going to talk about adult brain tumors. Now, about 50% of brain tumors are primary, meaning they originate in the brain. Then the other 50% are metastases from other tumors. Now, which cancers are most likely to metastasize to the brain? Well, unfortunately, almost all of them, or at least it feels that way. You have to think about lung cancer, breast cancer, GI cancer, thyroid cancer, kidney cancer, GU, and even melanoma. Now, the majority of adult brain tumors are going to be supratentorial, and the majority of pediatric brain tumors are going to be infratentorial. It's kind of easy to remember that because adults are taller than kids, so their brain tumors are going to be higher, they're supra. Now, patients will present with headaches that persist over a long period of time, and they get worse over time as well. Patients may also present with symptoms that are associated with a mass effect of that tumor. That includes things like focal neurological defects, seizures, even altered mental status. And what type of imaging would you get to evaluate the presence of a brain tumor? Well, you're probably going to get an MRI. To look at soft tissue of the brain, MRI is going to be the best choice. If you're looking for blood in the brain, like say a stroke or something, you're probably going to choose something like a CT scan first. So what are the major causes or types of brain tumors in adults? Well, in adults, there's a great mnemonic that we've used for brain tumors, and it's MGM Studios. So the first M is for metastasis. Remember, it makes up, again, about 50% of those brain tumors. And then G is for glioblastoma. The second M is for meningioma. And the S for studios is going to be the schwannoma. And that's going to be the order of prevalence of those brain tumors as well. So let's go into more detail on these primary adult brain tumors. So first we have glioblastomas. So glioblastomas are the most common primary brain tumor in adults. It is a type of astrocytoma. So astrocytes are some of the most abundant cells in the brain, and they provide support to neurons and they help form the blood-brain barrier. Well, these can become cancerous, unfortunately, and they cause glioblastomas. And again, unfortunately, this has a very poor prognosis. Good thing to remember here. The life expectancy is anywhere from about 6 months to a year. It is rapidly progressive. In fact, Ted Kennedy actually had a glioblastoma. Now, the location of these tumors is primarily in the cerebral hemispheres, and these tumors are irregular masses with necrotic centers, and they're surrounded by edema. Now, astrocytes will stain with something called GFAP, and the classic sign of glioblastoma is going to be the pseudo-palisading pattern. So with pseudo-palisading necrosis or tumor cell arrangements, you have kind of like the snake-like arrangement of the tumor. So be able to recognize that. All right, that's it for glioblastoma. Next, we have meningioma. So meningioma is the second most common primary brain tumor. Now, this is a slowly growing tumor, usually benign, but sometimes it can be malignant. They originate in the arachnoid cells of the meninges and are located near the surfaces of the brain. So since these are tumors arising from the meninges, it's actually kind of easy to remember that they are found more in the peripheral aspects of the brain. Now, it is more common in women, and risk factors include radiation exposure. And then patients with neurofibromatosis type 2, they're going to have about 50% chance of developing at least one meningioma. Now, many meningiomas are asymptomatic, and if they are discovered, then often there's really no treatment that's even needed. But symptomatic meningiomas will be treated with radiosurgery or just traditional resection. Now, on histology, you're going to see a whorled pattern. Also, you need to know that this tumor is associated with psammoma bodies. So psammoma bodies are laminated calcifications that look like rings on a tree. So be aware of psammoma bodies and how that is associated with meningioma. Now let's move on to schwannoma. So schwannoma is the third most common primary brain tumor in adults. These are benign nerve sheath tumors of Schwann cells. One type of schwannoma is the acoustic schwannoma, also referred to as the vestibular schwannoma or an acoustic neuroma. It has a lot of different names. Now, these tumors are often going to localize to cranial nerve 8, and patients will have tinnitus and hearing loss, and many will also have vertigo or at least some unsteady gait. Now, fortunately, these tumors are slow growing and are often resectable, and just about all schwannomas are going to be positive for a tumor marker named S100. Now, the bilateral acoustic schwannomas are found with neurofibromatosis type 2, so another brain tumor that is associated with neurofibromatosis type 2. And then next we have oligodendroglioma. So not as common as the first three primary brain tumors we just mentioned. The main thing to know about this one is the fried egg appearance. So what you have here is a perinuclear halo, also referred to as clearing of the cytoplasm around the nucleus. Now we see this in the coilocytes of HPV. They also have this perinuclear cytoplasmic clearing. And in seminomas, the testicular tumor seminoma can also have that perinuclear cytoplasmic clearing. So three different types of tumors, again, can have that very similar kind of fried egg cytoplasmic clearing appearance. Now, a student also gave us a great mnemonic that says, "Olego my ego," which reminds us of the fried egg appearance of the oligodendrocytes. And these are slow-growing tumors, again, and they're going to be found mostly in the frontal lobes. And then there's also pituitary adenomas, which classically secrete things like prolactin. This then leads to hypogonadism as a downstream effect. But you can also have pituitary adenomas that express other pituitary hormones, like maybe growth hormone, which causes acromegaly. Now, probably the only thing you really need about the pituitary adenoma is that on that prolactinoma is it can compress the optic chiasm, and you can get that really interesting bitemporal hemianopsia. Let's go on to the pediatric brain tumors. So childhood primary brain cancers. Remember, the majority of these are going to be infratentorial again. Now, another student, this one was from Memphis, suggested a mnemonic for the three most common pediatric brain tumors. This is kind of playing off the MGM studios for the adult brain tumors. It's Animal Kingdom, Magic Kingdom, Epcot. So that's going to stand for astrocytoma, medulloblastoma, and ependymoma. And then we actually have another mnemonic that actually adds on our last one that I kind of like too. It's called prepubescent minds eaten with cancer. And that's going to stand for the pilocytic astrocytoma, the medulloblastoma, the ependymoma, and then the craniopharyngioma. So use either one of those. So the first one we're going to talk about is our pilocytic astrocytoma. So this is the most common childhood primary brain tumor that we're going to see. So in adults, the most common brain tumor was a type of astrocytoma, again, called the glioblastoma. Well, in children, again, the most common primary brain tumor is another astrocytoma. So these tumors are located in the posterior fossa, and just like the glioblastoma, patients will have that elevated GFAP, which can be used as a tumor marker. Now, in this case, though, the prognosis is not nearly as bad as it was with the glioblastoma in adults. Now, under the microscope, you may see the Rosenthal fibers, and those Rosenthal fibers are eosinophilic corkscrew-looking fibers. Let's move on to the medulloblastoma. So the second most common primary brain tumor in children. The medulloblastoma is a malignant cerebellar tumor. And both medulloblastoma and ependymoma, which is we're going to talk about in just a minute, the third most common brain tumor, they're both known for compressing the fourth ventricle. So be aware of that. The medulloblastoma and the ependymoma in children can compress the fourth ventricle, causing a non-communicating hydrocephalus. Now, medulloblastoma is also associated with the Homer-Wright rosettes. So with Homer-Wright rosettes, you have a circumferential pattern of cells around sort of a central tangle of fibrils. So you have this circle of cells, and in the middle of that circle, kind of a bunch of fibers or fibrils. That's going to be that Homer-Wright rosette. And then let's go on to the ependymomas. So ependymomas have perivascular pseudorosettes. So these are not the same thing as the Homer-Wright rosettes. A perivascular pseudorosette that you're going to see with the ependymoma is a radial, again, arrangement or a circular arrangement of tumor cells. But now in the center you have a vessel. So it's not just fibrils, it's an actual vessel. So I want you to definitely separate the two, the Homer-Wright and the perivascular. Remember, Homer-Wright is medulloblastoma. The perivascular is ependymoma. And the final one here, craniopharyngioma, the last childhood brain tumor to be aware of. So the craniopharyngioma also comes from Rathke's pouch. So just like we saw with the pituitary adenomas in adults potentially. So the craniopharyngioma, just like with pituitary adenomas, you can get the compression of the optic chiasm, and that's going to lead to bitemporal hemianopsia. And again, this is the most common childhood supratentorial tumor. Most of the other ones are going to be infra. All right, so we just covered some tough stuff. It's time for a new teaching segment called Game Show. I'm going to give you a series of descriptors, and you'll have to kind of yell out the type of brain tumor before the answer shows up on the screen. Yell especially loud if you're in the library. Let's get going. All right, first one here. Adult tumor, world pattern, Samoma bodies. That's going to be a meningioma. Next, we have pediatric brain tumor, fourth ventricle compression, perivascular rosettes. That's going to be an ependymoma. Next we have S100 positive, associated with cranial nerve 8, and then neurofibromatosis type 2, that's going to be a schwannoma. Next we have derived from Rathke's pouch, pediatric supratentorial tumor, bitemporal hemianopsia, that's going to be a craniopharyngioma. Next we have bitemporal hemianopsia, amenorrhea with decreased libido, secretes prolactin, that's a prolactinoma. Next, staying with GFAP, pseudopalsating necrosis, number 1 in adults, that's going to be a glioblastoma. Next, we have elevated GFAP, Rosenthal fibers, and then number 1 PD tumor, that's going to be your pilocytic astrocytoma. Next, we have cerebellar tumor, 4th ventricle compression, Homer right rosettes, that's medulloblastoma. Next, we have slow growing, frontal lobes, perinuclear cytoplasmic clearing, that's going to be oligodendroglioma. Okay, so that's it for the game show. If you got all those right, then you win our grand prize, an improved self-image. If you got some of those wrong, then you'll get another chance at the end of session quiz. All right, so let's move on to herniation syndrome. So if you have a brain tumor, if you have an epidural hematoma, or you have hydrocephalus, all those things can cause what's called a mass effect of the brain, and that extra mass inside the skull can actually cause herniation or movement of that brain in the wrong place. So what are some of the ways that you can herniate the brain? Well, you can have a cingulated or subfalcine herniation that goes under the falx cerebri. So here the innermost part of the frontal lobe is scraped kind of under part of that falx cerebri. Now this one actually doesn't cause as much pressure on the brain as some of the others, but you can compress the anterior cerebral artery. You can have a downward or transtentorial herniation, and that's also referred to as a central herniation. You can have an uncal herniation. So with an uncal herniation, you could have compression of the 3rd cranial nerve. As you begin to compress the 3rd cranial nerve, first you're going to lose the parasympathetic innervation to the pupil of the eye, and that's going to cause a dilated pupil. And then next, the eye will deviate down and out. Now also with uncal herniation, you have a contralateral homogeneous hemianopsia. You can also have ipsilateral paresis, and then direct hemorrhages in the paramedian arteries. And then you can also have herniation of the cerebellar tonsils into the foramen magnum. All right, guys, that's it for the video part. It's time for that end of session quiz. Try to answer those questions first, and then we'll go through those together. First question, what are the 3 most common primary brain tumors in adults? And then what are the 3 most common in children? So for adults, remember the mnemonic for the most common brain tumors was that MGM Studios. Now the first M is for metastasis, but that's not a primary brain tumor. That's a metastatic tumor from some other primary. So the most common primary brain tumor in adults is going to be that glioblastoma. It might have been referred to as glioblastoma multiforme in the past. Then the second M is for a meningioma, the S is for schwannoma. So the 3 most common primary brain tumors, not counting metastasis, glioblastoma, meningioma, schwannoma. And then in children, you have that pilocytic astrocytoma, the medulloblastoma, ependymoma, and then finally the craniopharyngioma. Next, which primary brain tumor fits the following descriptions? So we're going to do a bunch of descriptions again. So first we have pseudopalsating necrosis. Remember, that's glioblastoma. Neurofibromatosis type 2. Most common, that's going to be your schwannoma, but think of meningioma as well. Prolactinemia leading to galactorrhea, amenorrhea, and anovulation. That's going to be that pituitary adenoma, the prolactinoma more specifically. Next, we have Samoma bodies. That's going to be a meningioma. Fried egg appearance. That's going to be your oligodendroglioma or the oligomyego. Perivascular pseudo-rosettes. That's going to be the ependymoma. Bitemporal hemianopsia, that's going to be your pituitary adenoma pressing on the optic chiasm. Also, think in pediatric patients, the craniopharyngioma. Worst prognosis of any primary brain tumor, that's going to be your glioblastoma, fast tumor, a prognosis less than 6 months. Child with hydrocephalus, think about medulloblastoma and think about ependymoma. Homer right pseudorosettes is going to be the medulloblastoma. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. Hello, everyone, and welcome to another warm-up review. Let's get going. Which cranial nerve relays the following information? Hypoxia measured by the carotid body, This one is going to be the glossopharyngeal nerve or cranial nerve 9. Next, we have motor information for swallowing. This is going to be both the glossopharyngeal nerve and the vagus nerve, so cranial nerves 9 and 10. 9 and 10 are both motor and sensory. Blood pressure from the aortic arch, so this is going to be cranial nerve 10, the vagus nerve. Salivation from the sublingual glands, so this is going to be the facial nerve or cranial nerve 7, which controls salivation from both the sublingual and the submandibular glands. Next, salivation from the parotid gland. This one is not controlled by the facial nerve. This is the glossopharyngeal nerve, cranial nerve 9. Blood pressure from the carotid body. This one is the same as hypoxia measured by the carotid, so cranial nerve 9 or the glossopharyngeal nerve. This nerve carries chemo and baroreceptor information from the carotid body to the brain. Next, which type of collagen is abnormal in Alport syndrome? So that's going to be type 4 collagen. And then which type of collagen is abnormal in classical Ehlers-Danlos syndrome and then in the vascular EDS? So classical EDS is caused by a defect in type 5 collagen and type 1 collagen. And the vascular EDS is going to be caused by a defect in type 3 collagen. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to discuss dementia and delirium. And despite the fact that these can look very similar, you have to be able to tell them apart. It's definitely a 4-star topic, maybe even a 5-star topic. You could see several questions on topics covered in this video. They're going to give you a disoriented or confused or obtunded patient. They're going to ask you to either make a diagnosis or choose the most appropriate diagnostic test or choose the best treatment. So let's start with dementia. When you hear dementia, we usually think about memory loss, but there's more to dementia than just memory loss. Dementia also involves loss of a higher order cognitive ability, like executive function, decision-making capacity, sometimes language, and even personality. Dementia often involves neuronal death, especially in the prefrontal cortex, which is involved with executive functioning and personality, and also in the temporal lobe, the hippocampal area where the memories are stored. So that's why with dementia, you tend to have loss of cognitive ability, loss of executive function in your prefrontal lobe, and then loss of memory. So what causes this neuronal death? Well, often it's because there's buildup of some type of cellular debris within the neurons themselves. Now, take a look at your study guide, number 4. It says identify the neuronal pigment or inclusion that matches each of the following statements. Now, these aren't all disorders that cause dementia. We're just talking about the histologic phenomenon of cellular inclusions. The intranuclear inclusions seen in herpes simplex virus are called Cowdrey type A inclusions. The cytoplasmic inclusions pathognomonic of rabies are Negri bodies. Neuronal inclusions characteristic of Parkinson's disease are Lewy bodies. We're going to see those again in a second. Cytoplasmic inclusion bodies associated with aging are lipofuscin granules. Dark cytoplasmic pigment in neurons of the substantia nigra and locus coeruleus that is not seen in patients with Parkinson's disease is melanin. Remember, with Parkinson you have depigmentation and loss of melanin. So this is a normal cellular pigment or inclusion that's being lost. The next one, eosinophilic rod-like inclusions in the hippocampus of Alzheimer's patients are called Hirano bodies. Diagnostic of Alzheimer's disease are neurofibrillary plaques and tangles. Filamentous inclusions that stain with silver that do not survive neuronal death are PIC bodies. And filamentous inclusions that stain with PAS and ubiquitin are Lewy bodies again. Let's talk about some specific types of dementia, starting with Alzheimer's disease, which is both the most common type of dementia and the best known type of dementia. So Alzheimer's disease is characterized by the buildup of intracellular neurofibrillary tangles made up of something called tau protein. So these are insoluble proteins that are tangled up inside the cell. You also get senile plaques with Alzheimer's disease, where you have extracellular beta amyloid. So I want you to remember the phrase amyloid plaques, which are extracellular. Alzheimer's disease can run in families. You can have early onset Alzheimer, which is associated with a few different abnormal proteins, presenilin 1, presenilin 2, and APP, which is amyloid precursor protein. The APP gene is located on chromosome 21, so individuals with trisomy 21 or Down syndrome have an extra copy of this gene. That means that they're at an increased risk of development of early onset Alzheimer's disease. And then late onset Alzheimer is associated with the ApoE4 apolipoprotein. ApoE4 is a chaperone protein that helps induce beta sheet formation. So how do we treat Alzheimer's disease? Well, first of all, you cannot undo damage that's already been done. You can't bring back memory loss or cognitive function that's already been lost. But what you can do is slow down the progression of the disease. So there are two big categories of Alzheimer's drugs that are going to help do this: cholinesterase inhibitors and memantine. So one of the key neurotransmitter changes that we see in Alzheimer's patients is decreased acetylcholine. So we use cholinesterase inhibitors to block the breakdown of acetylcholine. The three cholinesterase inhibitors we use for Alzheimer's disease are donepezil, galantamine, and rivastigmine. I'm sure you know the brand name Aricept. That's donepezil. Another drug that might be helpful, either by itself or in combination with one of the cholinesterase inhibitors, is memantine. Memantine is an NMDA receptor antagonist. NMDA receptors are a type of glutamate receptors, and these NMDA receptors get overstimulated in patients with Alzheimer's dementia. Too much stimulation, too much excitation can actually be harmful to neurons. It leads to neurotoxicity, or what we call excitotoxicity, from all that excitement. And memantine is going to block those excitatory glutamate receptors and theoretically prevent that excitotoxicity. Let's talk about some other causes of dementia. Alzheimer's is the most common cause of dementia in the U.S., but the second most common cause of dementia is vascular dementia, or multi-infarct dementia. These are patients with risk factors for atherosclerosis who haven't necessarily had a big clinically apparent stroke, but they may have had numerous microscopic subclinical microvascular infarctions. And on the MRI, you're going to see ischemic changes in the white matter. Clinically, this is basically identical to Alzheimer's disease, but on MRI, you're going to see those white matter lesions and evidence of infarction. Another less common disease that can cause dementia is called dementia with Lewy bodies. Now, Lewy bodies are pinkish eosinophilic cytoplasmic inclusions made up of a protein called alpha-synuclein. Now, we see Lewy bodies in the brains of patients with Parkinson's disease in the substantia nigra. But in dementia with Lewy bodies, we see these big, round Lewy bodies in the cortex. So dementia with Lewy bodies is somewhat similar to Parkinson's disease in that it causes Parkinsonian features like bradykinesia, muscle rigidity, possibly some tremor, in addition to the dementia. Another characteristic feature of Lewy body dementia is visual hallucinations. And another is repeated syncopal episodes, so the patient's falling on a regular basis because of syncope. So those are three clues to the diagnosis of dementia with Lewy bodies: Parkinsonian features, visual hallucinations, and repeated falls or syncopal episodes. Now, another type of dementia is called frontotemporal dementia, or the old name is Pick disease. In Pick disease, you have spherical intracellular inclusions of tau protein called Pick bodies, which are typically seen on silver stain. And you also have atrophy of the frontal lobe and the temporal lobe. And because the frontal lobe is atrophying, the most common initial presentation is dementia plus behavior and personality changes. So long before these patients get dementia, they start having inappropriate social behavior, inappropriate personal conduct. They lose normal inhibition. These individuals don't get friendlier, they become more crass. They get more inappropriate social behavior. Or you could have dementia plus progressive aphasia. So these patients may have difficulty expressing themselves, difficulty understanding what's being said to them. So be able to recognize those two clinical pictures as characteristic of frontotemporal dementia. Another very rare cause of dementia is Creutzfeldt-Jakob disease, or CJD. Now, this is a rapidly progressive dementia that's also characterized by personality changes, plus muscle spasms and myoclonus. But the rapid time course of this dementia is really pronounced. A lot of types of dementia might occur over a time frame of maybe 2 or 3 years, but with Creutzfeldt-Jakob, the dementia develops very rapidly over weeks to months. Now, CJD is a prion disease. Prions are transmissible infectious protein particles that serve as a template to induce conformational changes in the host's proteins. So this isn't a virus, it's just an infectious protein particle that's misfolded, and it basically causes the host proteins to become misfolded. Now, in the case of CJD, the prion induces the formation of beta-pleated sheets. And the downstream effect is neuronal death, so that the brain tissue develops lots of vacuoles, which makes the brain look a bit like a sponge. So sometimes this is called spongiform encephalopathy. Now, there are lots of other disorders that can cause dementia, such as neurosyphilis, HIV, B12 deficiency, Wilson disease, where excess copper accumulation leads to dementia. And then hypothyroidism can present like dementia a lot of the time with cognitive decline. There's normal pressure hydrocephalus, which causes the triad of urinary incontinence, dementia, and gait disturbance, or what we say is wacky, wet, and wobbly. And then in elderly patients, depression may present like dementia, which we call pseudodementia. The depression is actually producing the symptoms of dementia like memory loss and cognitive decline and so on. But one important diagnostic clue is that patients with true dementia don't really recognize that they have a problem. Patients who come in complaining of memory loss are less likely to have true dementia. The fact that they know that they're having some memory problems suggests that they have some other problem, but it's not really dementia. So when a patient comes in for dementia, you need to be familiar with how we work that up. You want to differentiate Alzheimer's disease, which is the most common cause of dementia, from some of these potentially treatable, reversible causes of dementia, like B12 deficiency or hypothyroidism or normal pressure hydrocephalus. Unfortunately, most types of dementia are irreversible. So if you find one you can treat, then by all means you want to treat it. And obviously, we don't do a lot of brain biopsies looking for amyloid plaques and neurofibrillary tangles in order to diagnose Alzheimer's disease. But what we can do is rule out other diseases that cause dementia, such as syphilis, so you're going to check an RPR. You need to check for HIV. You need to rule out vitamin B12 deficiency. You need to check a TSH to rule out hypothyroidism. And you need to do an MRI of the brain to look for evidence of normal pressure hydrocephalus or vascular dementia. So, in addition to a good history and physical, that's your basic dementia workup. Remember, Alzheimer's disease is a diagnosis of exclusion. Once these tests come back negative, you've excluded the possibility of all these other diseases, and all you're left with is a diagnosis of Alzheimer's disease. So, before we move on to delirium, let's do a quick whiteboard review.
Okay, I've listed several different features that could go along with dementia that might give you a clue as to what type of dementia you're dealing with. So let's look at each of these. If you have dementia plus visual hallucinations, that should make you think about Lewy body dementia or dementia with Lewy bodies. Dementia plus progressive aphasia, we said that was a feature of frontotemporal dementia, also known as Pick disease. Dementia plus ataxia and loss of pupillary light reflex. Tertiary syphilis, very important to be able to recognize that. Dementia plus megaloblastic anemia and peripheral neuropathy would be a feature of vitamin B12 deficiency. Dementia plus resting tremor and bradykinesia, that could certainly be seen with Lewy body dementia, or that could be a feature of Parkinson's disease. Parkinson's disease can definitely cause some dementia. I guess the biggest clue there would be, did the dementia come on first, or did the movement symptoms come on first? Dementia plus uninhibited social behavior. That one's a little bit vague, but for your testing purposes, I want you to think about uninhibited social behavior being a feature of frontotemporal dementia or Pick disease again. Dementia plus urinary incontinence and magnetic gait. That should make you think about wacky, wet, and wobbly. We said that was the mnemonic for normal pressure hydrocephalus. Dementia plus syncopal episodes. Again, that's Lewy body dementia. Dementia plus dysarthria and liver disease. We haven't really talked about this yet, but those are features of Wilson disease. You can see lots of different neurological complications, including dementia and also dysarthria. And then finally, dementia plus myoclonus. That's Creutzfeldt-Jakob disease.
Next, let's talk about delirium and focus on how you distinguish delirium from dementia. Delirium is a fluctuating level of consciousness that sort of waxes and wanes, usually with an acute onset. It doesn't come about over a month. It comes about over a period of a few hours or maybe a couple of days. Delirious patients can have disturbances in the sleep-wake cycle, so they might sleep all day and be difficult to arouse, and they might be raving all night long. They show a rapid decrease in their attention span and also in their level of arousal. Delirium is characterized by acute changes in mental status, disorganized thinking, hallucinations, often visual hallucinations, that sort of thing. And unlike dementia, delirium is usually reversible. It's very important. Delirium is the most common psychiatric illness that we see on the medical and surgical floors, and these patients often will have an abnormal EEG. Probably the two biggest causes of acute delirium are urinary tract infections and drugs, specifically benzodiazepines and any drugs with anticholinergic side effects. Anticholinergic drugs can make you mad as a hatter, so they can throw you into delirium. For that reason, we try to avoid medications that are going to cause anticholinergic side effects in elderly patients and in any patient with dementia. You might actually superimpose some delirium on some underlying dementia. But drugs of abuse and drug withdrawal can certainly lead to delirium. And you also have to think about other kinds of infections like sepsis or encephalitis or even just any type of fever. You should also think about hypoxemia, maybe from a pulmonary embolus, and electrolyte abnormalities like hyponatremia or hypercalcemia. But if you see a new onset delirium, the first two things I want you to think about are, is there a UTI and is there a drug on board that's causing the delirium? So let's close out our discussion of delirium and dementia by recapping some of the big differences between the two. Because again, being able to tell them apart is probably the highest yield part of this material. So let's fill out this table in the study guide. Delirium has a very acute onset over hours to days. Dementia has a more gradual onset over months to years. Delirium tends to fluctuate, to wax and wane over the course of a day. It can change on an hour-by-hour basis. In dementia, the patient's daily course is generally consistent. They're forgetful, they might even be withdrawn and socially isolated, but they don't change a whole lot throughout the course of the day. They're much more predictable. Delirium is generally marked by a decreased level of consciousness, although again, that does wax and wane. But in dementia, the level of consciousness is generally normal. In delirium, these patients can have disorganized thoughts, they can have flight of ideas, they may seem psychotic with delusions and visual hallucinations. In dementia, thought production is impoverished, especially their executive functions, and then psychotic features are minimal, but maybe still possible. And we said that delirium is generally due to some medical condition, UTI, drugs, that sort of thing, but it's reversible and it's correctable. But dementia is usually irreversible due to degenerative changes and degenerative damage to the neurons. So, if nothing else, make sure you know the difference between delirium and dementia. Now we're ready for the end of session quiz, so take a look at those questions and then we'll go over the answers together. First question, what are the usual components of a dementia workup? So you need to check an RPR to screen for syphilis. You want to check an HIV test to look for any evidence of HIV infection and HIV encephalopathy. You want to check a TSH to rule out hypothyroidism. You want to check a vitamin B12 level to rule out vitamin B12 deficiency. And then you need to do an MRI of the brain to look for multiple infarcts or strokes as a cause of dementia, and also to rule out normal pressure hydrocephalus as a cause of dementia. So again, the components of the dementia workup include RPR, HIV, TSH, B12, and an MRI of the brain. And usually some basic labs like a basic blood chemistry and a CBC. Next, why is Alzheimer's disease more common in patients with Down syndrome? Remember, it's because Down syndrome patients have 3 copies of chromosome 21, which is where you find the APP gene, the gene for amyloid precursor protein. Next, what's the mechanism of action of the drugs used in the treatment of Alzheimer's disease? So cholinesterase inhibitors like donepezil and rivastigmine prolong the action of acetylcholine, and memantine is an antagonist at the NMDA glutamate receptor. The last question. A 72-year-old woman is brought to the clinic by her family because of strange behavior over the past week. So that's acute onset. She's been very agitated and she takes many naps during the day, so that's alterations of consciousness. She occasionally urinates on herself, which is a red flag for a possible UTI, and she's had a poor appetite. She will not focus her attention on the questions you ask her. So what's the most likely diagnosis? Well, this is delirium. It's clearly not dementia. And it's just that simple, being able to distinguish between the two, so be sure you can do that. And that's the end of the end of session quiz, but we also have a handful of rapid-fire facts. The most common cause of dementia is Alzheimer's disease. The second most common cause of dementia is vascular dementia. Extracellular amyloid deposits in the gray matter are the amyloid plaques that you see in Alzheimer's disease. Intracellular deposits of hyperphosphorylated tau protein are the neurofibrillary tangles, also seen in Alzheimer's disease. And the last one, intracellular spherical aggregates of tau protein seen on silver stain. Silver stain means we're talking about PIC bodies, which are seen in frontotemporal dementia or PIC disease. And that's it for now. I'll see you next time.